Assalamu alaikum, ladies and gentlemen. Please, I would request everyone to be seated. Bismillah ar-Rahman ar-Rahim. Dear seniors, colleagues, ladies and gentlemen, Assalamu alaikum. Welcome to the 44th annual conference of Pakistan Society of Anaesthesiologists, Karachi chapter. And this is the day one of the scientific session. Yesterday we had a house full of inaugural ceremony, Alhamdulillah, and today we hope that it will be a more successful scientific session day one. To begin with, I would like to invite the chair scientific committee, Dr. Azhar Rahman, to come on the stage and brief about the scientific program, please. Dr. Azhar Rahman.
Assalamu alaikum. Distinguished guests, respected senior colleagues, honorable speaker, faculty members, residents, and dear participants, Assalamu alaikum, and a very warm welcome to all of you. It is both an honor and a privilege for me to welcome you to the scientific program of the 44th PSA Karachi Conference 2026. As you know, the theme of our conference for this year is Anesthesia, Global Standards and Local Solutions. On the behalf of scientific committee, including Dr. Muhammad Suhaib, Dr. Numan Akil, and me myself, would like to thank Dr. Saida Haider and Dr. Fawzia Khan, who helped us to shape up this scientific program. This year's scientific program has been carefully designed to provide a balanced blend of academic excellence, practical relevance, innovation, and collaboration. Over the next 2 days, we will engage in plenary lectures, panel discussions, debates, pro-con sessions, expert forums, resident competition, breakfast roundtables, and research presentations covering a wide spectrum of anesthesiology practice. This time we have added 2 new sessions. One is the Jeopardy style quiz for the residents and parliamentary debate. I hope you will enjoy both these sessions as well. Conferences like these are not only platform for learning, but also a space for inspiration, mentorship, and professional growth. As chair of scientific program, my sincere hope is that every participant leaves this conference with new knowledge, renewed motivation, stronger professional connections, and practical ideas that can improve patient care in their own institutions. Finally, I would like to thank the Pakistan Society of Anaesthesiology Karachi chapter for their trusted support. I wish you all a productive, engaging, and memorable conference. Thank you very much.
Thank you, Dr. Azhar. Let us begin with the session 1, which is a plenary session. To moderate this session, I would like to invite Dr. Huba Ahmed on the stage, please.
Assalamu alaikum, everyone. I'm Dr. Huba Ahmed from Dow International Medical College, and I welcome you all to the first session of the day, that is Anesthesia from Present Practices to Future Horizons. For this, I would like to introduce our chairs. Our first chair is Dr. Muhammad Hamid from Aga Khan University Hospital. He is General Secretary and former President of Pakistan Society of Anaesthesiology, Karachi chapter. Our second chair for the session is Professor Rana Altaf, President PSA Multan and Central, Chairperson Faculty of Anesthesia, University of Health Sciences. Over to the chairpersons.
Okay, Assalamu alaikum. So this is our first session, and we have this is plenary session, Anesthesia from Present Practices to Future Horizons. And in this session we have 3 presenters, and the first presenter is Dr. Shahab Naqvi. I would like to invite Dr. Shahab Naqvi on the stage. Dr. Shahab is the Professor of Anesthesiology and Intensive Care, ex-President, Pakistan Society of Anaesthesiologists, ex-Dean Anesthesia in CPSP, and currently working as Chief Operating Officer, Bahria International Hospital, Rawalpindi, and HOD Anesthesia and Intensive Care. And his topic is Driving Surgical Innovation Safety and Anesthesia in Modern Era. Dr. Shahab.
Assalamu alaikum. First thing first, thanks are due to the organizers for arranging such a beautiful conference here and giving me a chance to speak to this August gathering. Let's start. So my topic, as it's been informed, Mr. Chairperson, is surgical innovation, safety, anesthesia in the modern era. There is no conflict of interest, of course. So before we start, I would like to say a few words about how was the life of the patients, the humans, and the surgeons especially before the anesthesia started, and how that the anesthesia has developed along with the surgery later on, and what are we up to these days. So a little blast from the past. So this was one of the situations. So I'm sorry, this cartoon I made in 2006. I thought it's not a bad idea to repeat it after 20 years. So this is how it looked like before anesthesia. And let me quote one incident, that there was a very well-known surgeon named Robert Liston. He was a renowned surgeon in the early 19th century, and he was a very fast surgeon, and he had very good results, and used to do amputations less than 2 minutes or so. And he used to say that, "Time me, gentlemen," before starting. If you just Google this, "Time me, gentlemen," you will see the whole history of this. So हुआ क्या कि it ended up that he had a 300% mortality in one of his surgical amputations at University College Hospital, London. And this happened that he was this is the gesture he used to make after every surgery. But unfortunately, in one of the incidences, when he was doing the amputation of the femur of a patient, in just hurry, he just cut the 2 fingers of his assistant, and the huge hemorrhage of the patient. And when he got panicked, and when he lifted his hand, he cut one of the observers' face and all. So in the end, all 3 died. Patient died, the assistant died, and the observer also died because of the shock. So this was the story of surgery before the anesthesia was came into being. So since 16th October 1846, serenity of the anesthesiology gave cover to the surgical development. And since then, surgery and anesthesiology has got the symbiotic relationship. So हमारा खून भी शामिल है तज़ीन गुलिस्तां में, कोई माने या ना माने, और मानते हैं हम लोग. So few surgical achievements, advancements, we all know it. There is no point reading it or the whole slide. So it is changing from maximally invasive to the minimally invasive, and anesthesia is also has got challenges according to that. And we are shifting to the day case surgeries, and at the same time we are having prolonged surgeries as well. For example, in craniofacial remodeling also, where 2, 3, 4 surgeons even are involved in one surgery, and it goes to about say 12 hours or 10 hours or so. So then the heart transplantation, pediatric surgery with the congenital defects, robotic surgeries, and anesthesia is evolving to give space to all these developments. So we are working hard to improve the patient safety along with the surgeons, right? So this there is a shift from just in intraoperative care to the perioperative medicine. Anesthesiologists considered as perioperative physicians these days. Shared decision making of patient care, high standards and zero harm goal. SOPs and checklists have been made and followed. Protocols have been made. ERAs and IRACs have developed, and they have made standardization protocols. And regional anesthesia under ultrasound guidance has become a routine these days. So I'll give you just 2 examples about the surgeries and how anesthesia has adopted according to that, and then we'll go for the anesthesia of the modern era. So, for example, robotic-assisted surgery, anesthesia adopted as precision neuromuscular blockade to keep the patient still and ensure zero patient movement, protecting the delicate robotic arms. And then steep pendulum back position support, managing the physiological stress of extreme positioning and the intraocular pressures, and of course the new drug Sugamidax that allows deep neuromuscular blockade till the last stitch. Laparoscopic surgery is very common, and they are changing from minimally to the minimally invasive, even in the spine surgery as well. So single port surgery, anesthesia facilitates it by the high pressure pneumoperitoneum management, advanced ventilation modes, for example, volume generated pressure control ventilation to combat the restricted lung compliance caused by the CO2 insufflation. Opioid-free anesthesia using dexmedetomidine and lidocaine infusions to reduce the post-op ileus and enabling early discharge of the patient. So scope is also expanding, and non-operating room anesthesia is developing day by day. In the interventional radiology suites, we have to go there as a routine in electrophysiology labs, in the cath labs where TEVI and TEVR is there, and and the hybrid operating theaters are being used. Education and training based, simulation training is being adopted. High fidelity simulations, even in Pakistan, in few centers are available, and should be, we think that they should be used more frequently. Artificial intelligence and machine learning, predictive analytics, AI algorithms that predict hypertension or respiratory depression before they happen. Automated titration, closed loop system of TIVA, propofol infusions, remifentanils, and the decision support, AI as a co-pilot, not a replacement. So this is one of the models where all these inputs goes to the computer and the system, and then the infusions, different infusions are adjusted according to that, and the anesthesiologist can interfere in the decision making at that time. The next is the augmented reality guided regional anesthesia. Augmented reality is the 3D imaging. Vital signs or ultrasound data is overlaid into the anesthesiologist's real world view through a head mounted display like Microsoft HoloLens or specialized AR glasses. Clinicians see necessary data integrated directly into their field of vision. Key applications include vascular access, where AR can project map of the patient's veins. So this is how it looks like. They can see in their specs exactly the position of the needle and the ultrasound data and all. And then training of the AR guided approach is also happening in the happens on the simulators. Then virtual reality as a digital anxiolytic. This is also a very promising area to be explored. I don't know if somebody is doing it already or not. I went through one of the articles in the British Journal of Anesthesia 2020, and it says that VR reduces the preoperative anxiety scores by up to 30 to 40%, often matching the efficacy of midazolam. So it is preoperative anxiety relief especially for the children and in adults as well. Then there is a study in 2026 this year published in Journal of Personalized Medicine showed VR reduces frequency of intraoperative anxiolytic use from 61.7% to 5.8% in VR group. VR has the anesthesia sparing effect by increasing the pain threshold through cognitive immersion, and hence reduces the analgesic requirement, especially in regional anesthesia. So this is how it looks like. It is available, in all the routine shops in Pakistan, and the cost here is about 1,20,000 or so in the modern. Meta makes it, Apple makes it, Samsung makes it. They are all available, and it is like they wear it just like the specs, and they are inside the field in a 3D, three-dimensional space, and they can play games, see video movies during the surgery, especially in the blocks. This is one of the patients enjoying the VR during the surgery, and this reduces the analgesic requirement. Now, coming to the next aspect, this green anesthesia concept, reducing the carbon footprint in anesthesia. Phasing out from gases having high global warming potential, for example, which is desflurane and nitrous oxide, to low flow, using of low flow anesthesia. We are already using it, and shifting it to total intravenous anesthesia. Coming to robotics in the in anesthesiology, the first robot, as I said, is like this reality name system is the first ever robot that has been diagnosed for the air to aid the tracheal intubation. So this is the reality, a robotic endoscope automated via laryngeal imaging for tracheal intubation. And this is how it looks like. This portion is used like a joystick, and this is the scope. This is the hard part, and this is the movable part. And this automatically, searches the glottis and presents it to the operator, and they can intubate. This is how it works. At stage 1, it is, for example, here at the arytenoids, and then it moves to stage 2, and then to 3, and then into the trachea. The good thing about it is that anesthesiologist is still required. So, so we don't have to fear that it might replace us. So next is tele-anesthesia care, high bandwidth communication and real-time data transmission in the form of sending high-definition videos, focus images, AI-driven alerts, for example, impending hypertension, etc. It is a force multiplier that extends the reach of experienced anesthesiologists beyond the walls of operating rooms. So this is the main benefit, and especially after the discharge, the post-operative care can be carried out at their home as well. So it is PACU and beyond on the daycare surgery. But obviously there are certain limitations, and the commonest one are the medico-legal ones. Because if some mistake happens, then who is responsible? The bedside provider or the remote consultant? That has to be decided, and laws have to be amended according to that. So certain newer drugs, there's few are approved new drugs, some are newer drugs in the clinical trials, and newer formulation of the old drugs. So tapentadol is centrally acting mu-opioid receptor agonist with selective norepinephrine uptake inhibition, approved by FDA in 2008. It is less potent than morphine, but recommended to treat moderate to severe acute pain. It has plasma half-life 4 hours, undergoes first order kinetics, and hence has no cumulative effect. First order kinetics is the process when the rate of drug elimination is directly proportional to the drug concentration in the body. So there is no accumulation. So that is the advantage of this drug. Remimazolam is like on the remifentanil type. It is ultra short acting benzodiazepine. But has no analgesic properties. It is not metabolized in the liver, no excretion through the kidneys. Ester hydrolysis by non-specific tissue esterases, approved by the FDA in July 2020. Then the gentacurium was one of the drugs, was very promising, ultra short acting, the onset time was very good. So it was, they were thinking that we are getting the replacement of the dexamethasone, but due to certain reasons, the trials have been stopped, and then CW002 is replacing it. So then the liposomal bupivacaine is a good option that has increased the duration of analgesia for up to 72 hours in the drug. And it acts through the depot foam technology, covering the drug molecule in the lipid bilayers, resulting in the slow release. Etomidate has also been modified in the methoxycarbonyl etomidate by non-specific tissue esterases. Now coming to the precision anesthesia, that is pharmacogenomics. That is the most exciting, field. And we can give, a tailor-made anesthesia to every patient if we go through the pharmacogenomics. I have gone through this article. This is a very good article if you want to go through it, published in January 2026 in Frontiers in Anesthesia. It is precision anesthesia and pharmacogenomics. So it has given the tables, and almost every drug genome has been identified. I have written a few just to show you that I have been through this article. So this is like advantages are personalized anesthesia, reduced complications, better predictability or drug effects. Challenges are obviously cost and delays in the surgical procedures. So evolution as molecular technology becomes more economical and easily available, pharmacogenomics can be integrated in anesthesia care later on. Another interesting article published in Pharmacology, again in this year, 2026, this is omics and anesthesia. There is pharmacogenomics, proteomics, and metabolomics. So if somebody is interested, they can go and, have a look at this article. So conclusion is the same. Challenges to overcome are ethical considerations of AI in the healthcare, integration cost and human touch, which we are losing because of the technology. So we have to integrate the human touch in high-tech environment. Disparities in anesthesia access is already there. It was discussed very nicely by Professor Gohar Afshan last night. So to summarize, the core of anesthesia remains vigilance and safety. Technology should be an enhancer of our clinical judgment, and the future belongs to those who adopt to digital and sustainable shift. That is also very important. So to me, quality anesthesia is the basic human right. Now, at the end, let me introduce you for the conference that is coming up in this October, Epicon 15. And you are all cordially invited, especially the youngsters. We have got the Young Presenter Award, and the prize money this year is 100,000 rupees from our side. And there is another award from the Epoche, and they are giving registration of the Euroanesthesia, about 600 pounds to the best poster presentation. And you must visit this website. It is very active. I've shared it in the groups. If somebody wants to see anesthesia community group, में कई दफ़ा मैंने share किया है. So please do come there, and it is your conference, and it has been being started after a gap of 7 years or so. So thank you so much.
Thank you, Dr. Shahab Naqvi, for a wonderful talk. And now you request our second speaker, Dr. Saida Haider, the patron of Pakistan Society of Anaesthesiologists, Karachi, Professor Emeritus, Indus Hospital Network, and the strong passion for the clinical excellence, academics, and potential-centered care. Dr. Saida Haider. His talk is about the legacy of anesthesia in Pakistan. Tracy.
So Shahab gave us how anesthesia has sort of grown in globally, and I'm going to take you what's been happening in Pakistan. Okay, so in the next 20 minutes, let me trace the legacy of anesthesia in Pakistan. From the agonizing ordeal that Shahab just shared to the present-day anesthesia, where it is safe and painless, and from the speciality being an unknown speciality, converting into sort of covering almost all specialities of anesthesia. So today's agenda of my talk is the then and the now of anesthesia, the historical memories. And I can sort of compare it to a barren land. Anesthesia was like a barren land, and it has got converted into a green forest today. So the journey through time, my thanks to all those who helped, my special thanks to Gohar and to Brigadier Salim. My thanks to all those who helped, especially Gohar and Brigadier Salim, and my deepest apologies to those who might have missed out. It is totally unintentional. So how we got here today, anesthesia through the years have been like, it was like a barren land in 1947. There was hardly any anesthetists in Pakistan. The journey began in the 50s and more joined in the 60s and the 70s. And today, it's like a green forest. So that's how anesthesia has grown today. The number and the caliber of anesthesiologists in Pakistan has increased, although we still lack anesthesiologists in Pakistan, but we have been producing quite a large number today. To the extent that we've been exporting anesthesiologists globally, these homegrown flowers, they go and they are serving in UK, Ireland, Kingdom of Saudi Arabia, UAE, Oman, Qatar, Kuwait, and Bahrain, and where else. So anesthesiology, how it grew in Pakistan, it just didn't come up like, you know, sort of, it was not a miracle that happened without somebody's. It was because it is filled with courageous, determined, and exceptionally talented anesthesiologists facilitating the advancement of the specialty anesthesia against all odds. And since most of us are anesthetists, we know those odds are the surgeons themselves, the hospital admin, the lack of public awareness, and the lack of political will at the level of the government. Actually, anesthesia is one specialty जिसके ऊपर बहुत सारी specialities dependent हैं. It's not just पहले हम लोग कहा करते थे advancement of surgery is only possible with advancement of anesthesia. Today, it's the dependence is on, you know, most specialties, the endoscopy unit, the cath lab, the radiology suite. It's everywhere. We are covering almost all specialities. So the story of anesthesia is really a story with humble beginning in Pakistan. In 1947, we just had Dr. K.E. Madan. He was the only lecturer, and he wrote the only anesthesia reference book, which was named Elementary and Advanced Anesthesia. और ये भी qualified anesthesiologists नहीं थे, ये trained anesthetists थे. He was there before partition. He practiced and taught in Lahore, and his focus was basically he was bringing the basics and the clinical together, and was bridging the gap between pharma and clinical application. Then only limited surgeries could be done, and these were done by not anesthesiologists, but by doctors having some random skills of managing airway and circulation, and the ENT surgeons, I believe, helped them, sort of trained them how to put in a tube, etc. And anesthesia was not recognized as a medical discipline. Later, in a decade after that, we were fortunate that certain people got interested, and like Dr. Rustam Ali Nabi, Dr. Hussain Ahmad, Brigadier Anisur Rahman, Professor A.M. Attar, and Professor Sayyid Waqar Hussain Zaidi. Brigadier Anis and Attar Sahab, I believe, was sent by the government. They were interested in anesthesia, so they were sent by the government to the UK, and they got honorary fellowships and DAs. And Dr. Rustam Ali Nabi and Hussain Ahmad Sahab also first practiced as medical officers. Then later on, they qualified in the 50s, and they were given actually honorary FFARCS. They were the facilities at that time could be, you know, they are seen in the History Museum today, like Schimmelbusch mask and Boyle's bottle and the reusable glass syringes and the red rubber tubes, etc. This is all that they had to work with. So we will always remain indebted to these pioneers who initiated the formal anesthesia and pain services. Rustam Ali Nabi Sahab, Anisur Rahman Sahab, Hussain Ahmad Sahab, and Brigadier Salim. We were very fortunate that with the inception of CPSP in 1962, our first MCPS of anesthesia qualified in 1964, and Professor Faizur Rahman, most of us who have been students later, not during this period, much later, remember him as a very tough examiner. So he was heading NICVD. He was the first MCPS, FCPS in anesthesia, and he did that in 1968. Dr. Jamil was someone who was a qualified FFARCS in Peshawar, and Dr. Habibul Haq Siddiqui Sahab was practicing as a DA in Lady Dufferin Hospital, Karachi. So anesthesia picked up gradually, better anesthesia equipment, manual monitoring, finger on the pulse, and spontaneous breathing. That is what anesthesia was. However, this is the landmark era, 1975 to 1990. This is when anesthesia changed in Pakistan, and the reason was that many stalwarts, highly qualified anesthesiologists returned home from UK and the USA, and this was an era when anesthesia boomed. The ones who changed the face and fate of anesthesia in Pakistan, it so happened that it happened simultaneously all over Pakistan, and in Karachi, Professor Munir, Professor Tipu Sultan, Professor Rehana Kamal, Professor Fauzia Anis Khan, Ursula Jahan, they all somehow came, right after, one after the other. Professor Dr. Akhtar Waheed Khan, Akhtar Aziz Khan, a diplomat, American board, Ali Raza Zaidi Sahab, Jakirani Sahab, Sajda, Dr. Sajda in Karachi Adventist Hospital, and in Lahore, SU Call, Noman Ahmad, Razia Imtiaz, Atya Sakhi, Qudsiya. Similarly in Multan, Mehdi Hasan Mumtaz, Quetta, Peshawar, and the armed forces, and anesthesia was booming. It was because of the commitment and dedication of our seniors and contemporaries, and as Longfellow said, the heights of great men reached and kept were not attained by sudden flight, but they, while their companions slept, were toiling upwards through the night. So it was a lot of hard work put in by these people. The ones who led in Karachi, Multan, and Lahore, we are all familiar with them. Mehdi Hasan Mumtaz Sahab, Akhtar Waheed Sahab, Rehana Kamal, and Professor Tipu have got special contribution in which, they led to the expansion of the domain of the anesthetists in Pakistan by introducing critical care services. Now, it was not just critical care services that were sort of added to anesthesia. It sort of led to the advancement of surgery. Transplant surgery could be done, major and complicated surgeries could be done, and as Shahab said just now, not with 300% mortality, but with 100% success. And gradually, the anesthesiologist has changed from some na-maloom person to a perioperative physician. Habibullah Haq Siddiqui Sahab ko we cannot forget him. It is him that we owe this platform to. Pakistan Society of Anaesthesiologists, which was formed in 1971. I must also mention over here that Pakistan Association of Anaesthesiologists was formed by Brigadier Salim earlier on, which got amalgamated to this, and Habib Sahab was the founder patron of it. He laid the foundation of PSA. He was also the anesthetist of Benazir Bhutto. So Bilawal is someone who has whom we suffer because of him, really. 1990 onwards, international standards in major hospitals of all major cities. How can I move on without mentioning Brigadier Salim's name? He is the august buyer of Pakistan. He is the Baba-e-Pain medicine. He actually introduced the concept of Anesthesia Society, the Pakistan Association of Anesthesiologists in 1984. As early as 1985, he formed this Society of the Treatment and Study of Pain and got it affiliated with the International Association for the Study of Pain. The first pain clinic in 1990 in CMH Pindi, और उसकी बड़ी लंबी कहानी है, which I have heard from him, and it was not just pain clinic was formed. उस ज़माने में पैसे नहीं होते थे, आने होते थे, and he formed this ANA pain score, एक आना पेन हो रहा है या 16 आना पेन हो रहा है, depending on how much pain the patient had, and the recovery score. He had contributed to the textbook of anesthesia that was written by him and General Salim. And he's the one who actually has donated the Salim Gold Medal that some gold medalists are sitting over here who got the gold medal from CPSP. He was one of those people who has inspired me to be a teacher of physics and equipment in anesthesia. So this is what his son sent to me. They were celebrating his the recovery score. Some days that was a celebration day for that. So pain medicine owes it to him. Professor S. Tipu Sultan, I think where we stand today, the recognition that we have nationally and internationally, I think we owe it to him. Anesthesia became a choice for many. He was an NSF leader, and there were a lot of boys in NSF who all became anesthetists actually, and it was because of him, because he was a role model for them, and he was a catalyst he seemed like a catalyst for anesthesia in Pakistan. He initiated modern anesthesia techniques, equipment, drugs in the public sector hospital in Karachi, launched teaching and training. There was no teaching, postgraduate training program in DMC and CHK. He launched that. And the structured viva that you take today, most of the examiners sitting here, that was actually introduced by him. He had been to Ireland and been a part of such an exam, and then he introduced it to Sultan Farooqi Saab, and he accepted it. He activated PSA into a role model society. I'm proud to be a member of it. Initiated critical care services by starting the first surgical ICU in the public sector hospital in 1991. We had our first pain clinic in 2001, and a very big conference was held, the South Asian Confederation of Anaesthesiologists in 1997, and it was his organization. So the feather in his cap basically is the formation of Dow University alumni of anesthesiologists. A single institution has produced so many, and if you see FCPS के उसमें रो में सबसे पहला नाम मेरा है. So I was the first FCPS from Dow Medical College. We recently, he completed his 50 years in anesthesia, and his students celebrated Golden Tribute ceremony on the 6th of September 2025. And I think this is the quote that was written on all his letterheads, etc. So I thought maybe we should incorporate that. So the shield that we gave had written on it, with all his sham drudgery and broken dreams, it's still a beautiful word, strive to be happy. Professor Mehdi Hassan Mumtaz, he's the lead anesthesia in Multan. He led anesthesia single-handedly. He pioneered critical care in Multan, a marvel at... time ho gaya kya? A marvel at physics and equipment, a great teacher. Contributions, he has references in major textbooks, produced future leaders in Multan like Rana Altaf Saab sitting over here, Salman Waris Saab. Arranged conferences, Nishta Medical College and Mehdi Hassan Mumtaz go together. Recently, his students celebrated his 80th birthday in Multan. Professor Kaul Sahab, he was the inspirer and the role model, and the special thing that he developed was the concept of group practice, the Kaul Associates. He activated PSA in Lahore in 1976. So the real recognition and the respect and the confidence that we got is not from just the knowledge and competence, but the leadership and teamwork. I think anesthesia is one specialty which does not require submissive people. We need leaders and we need teamwork. And anesthesia became at least a co-captain of the OR, ICU, and pain medicine, if not the academics and post-graduation took off, CPSP supervisors, postgraduate courses, workshops, and research papers and qualified anesthesiologists, etc., etc. Pakistan Society of Anaesthesiologists also started started expanding and having its branches all over, with showing its international presence in most of the international associations. So anesthesia, critical care, and pain medicine gradually got at par with international standards. Modern anesthesia equipment, adjuvants, cannulian lines. There was no cannula. Sodium thiopentone was being given by needles. Preoperative clinics, daycare anesthesia, and there has been no turning back. Ultrasound-guided regional anesthesia, critical care, acute and pain management. Let's have a little go through of some photographs that we have of people that we might, some new faces might not remember. There was somebody very important in anesthesia, Madam Habiba Jatoi, Ghulam Mustafa Qazi, they are from Hyderabad. Waqasi Sahab is still part of us. Ahmad Sumro leading anesthesia in Larkana. Maqsood in Sakhar, Saleh, Pro Vice Chancellor as well as HOD in Nawab Shah. Rafia Tabassum is doing a great job in Nawab Shah, Kashif Mehman, and there's a Dr. Kalash also. I'm sorry, I don't have his picture. They have been leading anesthesia recently in Hyderabad. Some of the past and present of Punjab, Asif Gulkiani, a big name in pain medicine. Salman Waris yesterday got his Lifetime Achievement Award. Rana Altaf Saab, President, PSA Center. Shahab Naqvi, who doesn't know him, General Shahab Naqvi, who did so much while he was at AFIC. Shahida Khwaja, patron of Society of Anesthesiologists, Lahore branch. Arshad Taqi, Khalid Bashir, Ismat Wasim Chaudhry. KPK in Balochistan have, the big names over there. Musarrat Shah ki mujhe tasveer na mil saki, maine bahut koshish ki. Raha Sahibzada Sahiba, she was such a great, someone who led anesthesia in Peshawar. Akbar Saeed Jan, Nasreen Laik Sahiba, Nasir Niaz Sahiba, I remember him very fondly. Faiz Tareen, Amjad Ali leads today, and Shahryar is amongst us. I think he's here. The teachers and trainers of today, everybody knows that the contributions of these people that we see over here. Fazal has been holding such important posts in AKU. We have also had great representation from our members at the international forums. Fawzia has been a part of WFSA for the last 15 to 16 years. And today, these people make us proud, Gohar and Hamid and Samina. And we recently celebrated Anesthesiologists Beyond Anesthesia on the 6th of May, where we celebrated these three who have recently become members of various committees and chairing various committees at the WFSA. And Saleh for, running for a vice chancellor, and Noor for helping us hold these conferences. It is just because of him that we are able to collect the funds, and then we are able to spend lavishly over here. Celebrating anesthesiologists beyond anesthesia, a beautiful couple, Asma and Azhar, and some other photographs from that day. And thank you, God, for giving him back to us. So welcome back, Dr. Akhtar Aziz Khan, a very special person amongst us. some more of the past and present. There are another beautiful couple, Shumaila and Jodat, Nighat, Shabir, and the call associates people. Zareen Naqvi has been a very powerful contributor to PSA, and she used to work in PIA, great people to fly with. Akhtar Waheed Khan Sahab, I don't see him today, I wish he was here. Khalid Paracha is someone who now is in Ireland, however. He's the one who has given us this logo that we have today for PSA. We cannot move on without mentioning Tariq Hayat Khan. 2 minutes और दे दें. Who has been consistently publishing this journal since 1997, the Epicare Journal. Some very precious moments. Great achievements are only possible because some people work beyond the call of duty. Recently, Asma has been a recipient of the 2026 Global Scholar Award. Liaqat Ali and Salman Salim have been contributing to pain medicine in Punjab. And our very special Ashraf Zia, Dean Faculty of Anesthesia presently. And I cannot move on without mentioning Vinod Kumar, who is our overseas coordinator. All the programs that you see, all the banners that you see, everything that you see has been done by him sitting in Dubai. The present status, no doubt we have progressed by leaps and bounds. However, there is still lots to do. Someone has to take the responsibility from here onwards. Look, our seniors have done a lot. Now you have to, the youngsters sitting over here, have to take the responsibility. The present status, unfortunately, is that the peripheral hospitals and small cities still lack proper facilities and qualified manpower. There's a constant brain drain. Ministry of Health and Health Commission need to be sensitized by the representative body of anesthesiologists, which are us. The great achievements are only possible if you have an egalitarian approach, a leadership role. We must lead. We cannot be submissive. Accept the patient's responsibility. Just don't say, I have to anesthetize and, that's the end of it. No, be a perioperative physician. Those of you who are good in teaching, teach because you learn when you teach. Create public awareness, be part of multidisciplinary teams. Recognize yourself, only then you will be recognized, because the access to surgery is a basic human right, and we must make a difference to the patient outcome. So work hard in silence. Let success be your noise. And my 2 cents are, I think I love this Oprah Winfrey's quote, I have come to believe that each one of us has a calling that is unique as a fingerprint. The best way is to discover what you love and then offer it to others in the form of service, working hard and allowing energy of the universe to lead you. Future of anesthesia depends on you, the present-day anesthetist. The woods are lovely, dark and deep. You have promises to keep and miles to go before your sleep. So this is my humble advice to those who can make a difference. And this is how I saw how anesthesia grew. But remember, what you see depends on where you stand. People in the top window have a different perspective from those at the bottom. And those, I apologize if I missed out an important name. Everybody sitting over here is equally important. And my very special thanks to Dr. Dillu Raja and Dr. Talal for organizing this conference. Thank you.
Thank you, Dr. Saida, for excellent presentation on anesthesia journey in Pakistan. Now the next speaker is Dr. Ahsan Waqar. He's consultant anesthesia and critical care at Shaukat Khanam Hospital and medical director for oncology services in the hospital. So he will talk about the hidden contribution of anesthesiologists, what surgeons forget. Dr. Ahsan Waqar.
Assalamu alaikum. First of all, my thanks to the organizers for doing a wonderful job. When this topic came up, I was thinking, why do we need this topic? Why do we need to talk about this? Is it some sort of an inherent complex that anesthetists have that we want to talk about? What are hidden contributions we are making? Do we have this sort of a thought process that our contributions are not being recognized enough? So what was the thought process? And then I thought, okay, fine, let's look at it scientifically. Let's try and explore whether there is any scientific evidence present that could lead us to think that our contribution is being hidden from some of our colleagues, namely surgeons. I don't have any conflict of interest as far as this topic is concerned. So what is the patient journey here? So let's just think about this. So we talk about perioperative medicine, just to declassify it. So there's a preoperative course, there's an operative course, and there is a postoperative course. What is our contribution in the preoperative course? Importantly, we don't realize that whatever we are doing preoperatively is not just optimization, it is risk stratification. And this is something I'm going to talk about again and again, risk stratification and outcomes. So risk stratification is something that forms an essential part of our preoperative assessment. That is something that is probably a bit hidden as far as anesthetists are concerned. The next bit is the intraoperatively. So what do we do as anesthetists, apart from giving muscle relaxants and a bit of propofol that probably our surgical colleagues believe we do? We play with physiology. And when I say play with physiology, what I mean is that we optimize physiology during the operation so that the outcomes can improve and the patients can survive. Which brings us to the postoperative period, which is the period where we provide a surveillance and rescue system. So critical care is not something just critical care. Medicine is a completely different field, nothing to do with anesthesia. But in that period, what we are providing is a rescue service. We have the ability to do that, and that is what we do. So without anesthetists being a partner in this whole patient journey, there is absolutely no way that the patient can actually pass through this. Where lies the blind spot? So the blind spot is what the surgeons believe is happening. And then, so what do the surgeons believe? So let's look at this. So they have this idea that mortality is actually being driven by the disease index. So whatever the disease is, that is why they're having surgery. The disease index is going to determine what is the outcome and mortality. Then the complications, the patients suffer complications because of the surgery itself. And then these complications are the ones that are driving the outcomes. So if the mortality is improved, that is because the complications have reduced. So this is what the surgical viewpoint is. What is hidden from their eyes is the role that we play in influencing survival. So how do we influence survivals? So in the earlier slide, we just briefly touched optimization of physiology during the operation. So the fact that we have the ability to optimize physiology during the operation means that this has a bearing on the outcomes. This is something that determines what the outcomes are going to be. If somebody decompensates during the operation, the fact that they may be having a colectomy, but because the liver has decompensated, doesn't matter how beautiful the operation has gone through, the patient is going to die. So that is the role of anesthetists, where we are optimizing physiology. By optimizing physiology, what are we trying to achieve? Reduction in the complications. Reduction in the complications during the operation, reduction in the complications after the operations. And remember, after the operation, we still have the ability to provide surveillance and rescue. And this is what determines the outcomes. So outcomes is not just determined by the disease index, by the fact that there is no surgical complication or there is a surgical complication, or because of these complications, the outcomes are now altered. No, the outcomes are determined by what the services that we are providing during the operation, optimizing physiology, and moving on and reducing complications henceforth. So the way I see it, the way I would like to classify this evidence about the contribution of anesthetists is foursome, which is ERAS, goal-directed therapy, critical care, role of critical care, and perioperative medicine. So we'll just explore all these individually. Sorry. Yeah. So let's just talk about ERAS for a minute. So this is a concept given by Danish people, early 2000s. What they believed was that we can improve outcomes if we can enhance patient recovery, enhance the patient experience. So from then onwards, we have moved to this day where ERAS is a certified, well-established concept. Almost every surgical specialty, subspecialty is adopting it, and there are outcomes, there are benefits. So this is a paper that was written in 2015, and they specifically explored the role of anesthetist in ERAS. And this is what they came out of it. These are the results that they gave us. The complication rates reduced by 30% because of the anesthetic interventions. The hospital stay, which is one of the banes of life of any administrator of a hospital, the longer a patient stays in the hospital, the more it costs a hospital, so the length of stay has to reduce. So anesthetist contribution was able to effect a 2.3 days reduction in hospital stay of these patients. So that is massive. From an administrative point of view, that's massive. Then the patient safety. So the patient safety increased by 22%. So whatever we are doing in operation theaters, the role of nurse, role of technicians, role of surgeon, role of anesthetist, all of us are trying to improve patient safety every day. This paper was able to prove that by implementing ERAS, the role of anesthetist has actually enhanced patient safety by 22%. I don't exactly know how they came up with this number, but this is what they were able to prove. And most importantly, the outcomes. So the patient outcomes improved by 9%. That's again massive. If somebody tells you you have a risk of an MI, 10% risk of an MI, most likely you're not going to undergo that operation. But if you can tell them the fact that we are going to do these 10 things during the operation, and actually this would improve your survival rate by 9%, I'm sure that your patients are going to be very happy by listening to this. Moving on to goal-directed therapy. So this is not the reverse trial, 2001 reverse trial. This is not what it is. This is the anesthetic contribution. This is the optimized trial, which was published in 2014, a while now. They took major non-cardiac surgical patients who had complications, who had ASA2, ASA3. They provided goal-directed therapy with LIDCO, and the results were astounding. So if you are able to provide goal-directed therapy during the operation by anesthetist, now I'm not talking about critical care. So goal-directed therapy has just lost its shine in critical care in the last few years because it hasn't produced the same results as initially everybody thought. So this is about anesthetists providing goal-directed therapy in theaters with the help of LIDCO. Not everybody has LIDCO, but that's not the point. The point is that if you are able to provide goal-directed therapy to this group of patients, more than 2,000 patients were recruited in this study, and all of these were having major abdominal procedures and major thoracic procedures. So the complication rate actually reduced by 31%. That's massive. So if you optimize fluids, the complications reduced by 31%. The hospital length of stay reduces by 1.7%. You might think, why is he talking about hospital length of stay? I love this. So hence the hospital length of stay reduced by 1.7 days. So if you are able to reduce 1.7 days in terms of total health economics, this is massive. And then importantly, what we all love is mortality. So mortality reduced by 28%. This is relative risk reduction. This is not absolute risk reduction. But the relative risk reduction was 28% because of this intervention. And hence, the final outcome, the culmination is that the overall outcomes improved by 22%. Again, this is massive. These are massive numbers. They have not been able to replicate them, but then a trial of this magnitude is not easy to conduct anyhow. So I don't think that a trial of this magnitude is going to be replicated soon. Moving on to the critical care impact. So again, a disclaimer that critical care is a completely different specialty. We must not conflate that with anesthetics, but it is the critical care impact that the anesthetists have brought about. And this was on the basis of NCPOT 2015. What they were able to say was there is a definite group of patients that can be labeled as high-risk patients. There's a whole definition of high-risk patients. We can't go into that in this lecture, but so there's a high-risk patient group. In this high-risk patient group, what was witnessed was there was a failure to rescue. The time when intervention could have been made, it wasn't made, and they deteriorated. If there was no failure to rescue, we would have improved outcomes, right? That is fairly understandable. Then we go into the specifics. What was found was, amongst those patients who died, so the group of patients who died, they were looked into, and what they found was that 45% amongst that group of patients who died, 45% could have benefited with intervention from critical care at the right moment. And if we had intervened at the right time, we could have saved them. So this is the conclusion they came up with. 45% is a massive number. So 100 patients have died. We could have saved 45 of them, almost half of them. That is unbelievably high number. And the fact that we, anesthetists, could have contributed to that point. Then moving on, delay in admission to ICU was another factor which contributed to 22% of deaths. So this is the group of patients. This is a very interesting group of patients. These are the group of patients who died. Then we came to the conclusion that they should have gone to ICU. But that's not the point. The point is there was a delay in sending them to ICU. So they did end up going to ICU. But that is not what saved them, because there was a delay. By this time, probably the physiology had gone worse. So we could not save them. Hence, going to ICU, the rescue mission, and then the timely intervention. Both are important in improving outcomes. So timely admission, failure to rescue, and they all improved survival and outcomes. Nobody talks about this, but there's plenty of evidence, and I think this is one area where anesthetists need to contribute more, is prehabilitation. We don't really think about it. So these guys, what they did was they looked at lower GI and upper GI patients. I think they excluded, I don't remember exactly, but I think they excluded hepatobiliary patients. So upper GI, lower GI, having major abdominal surgeries, so they gave them a prehabilitation package. They told them to walk for this many hours and do this spirometry and this. So they gave them a whole package, randomized. One group had the package, the other one didn't. So the outcomes again were astounding. The numbers are unbelievable. Those who had prehabilitation, and I think the prehabilitation was 14 days or 15 days before the operation, 30% reduction in the post-operative complications. 30% reduction, massive numbers. And again, my favorite, 1.8 days reduction in the length of stay. So health economics plus patient benefit, both are happening just because we intervened and gave them prehabilitation. Prehabilitations is something that initially surgeons never really thought that it is possible. So this reminds me, I had a conversation with Brigadier Salim quite a few years ago, and it was just mentioned by Professor Heather that 1990 they started pain clinic. So he told me that when they wanted to have permission to open a pain clinic, the surgeons laughed at him. And not just the surgeons, the whole of the medical community in the armed forces, they laughed at him and he said, "Are you now going to open a pain clinic? The next would be a diarrhea clinic?" There was no concept that you can have pain, and hence, at the moment, we are not really fully immersed that we need to do this prehabilitation. But this is the next thing that we need to focus upon. Prehabilitation improves outcomes. One of my favorite trials, POISE trial, simply started, how did it start? So Peter Devereux is a cardiologist in Canada. So Peter Devereux was always referred patients from anaesthetists and non-anaesthetists to optimize cardiac patients. So he came up with this idea that I have no idea how to optimize them. So let's give them beta blockers perioperatively. So the idea was that if you give them beta blockers, metoprolol, their mortality will reduce and their risk of having an MI during the operation would reduce. So yes, non-fatal MIs did reduce, 2.8% versus 3.1%. But the incidence of stroke increased. And subgroup analysis showed that in this group of patients, the mortality had also increased. So those patients who are having stroke, they were dying. And hence, the beta blockers debate was finished for once and for all, that beta blockers, if you want to give them, at least give them 1 week to 2 weeks before the operation. Don't start it a day before. That worsens outcomes. Very relevant trial, extremely relevant to our practice every day. And the more and more patients are getting beta blockers these days, so this is becoming even more relevant as the time goes on. Long-term survival. I think we have discussed this enough, so I'll just skip this because we have, in various slides, we have discussed this. Okay, so they were very concerned about the quality initiatives. So perioperative medicine improves patient outcomes across the surgical journey, multidisciplinary. That is another important factor here. It needs to be, the input needs to come from various sides, not just from one single person. Single person driving the system is not accepted anymore. Okay, so if there was a preamble to my whole presentation, the previous slides was just a preamble to this slide. In my opinion, this is the most important slide I have. कि मोहम्मद से वफ़ा तूने तो हम तेरे हैं, ये जहाँ चीज़ है क्या लौह कलम तेरे हैं. My father used to say that the whole idea of writing Shikwa and Jawab Shikwa was to write this verse at the end. He used to say that was just a preamble. He wanted to write this, but he had to create a whole background to write this. So my slides were just a background to this main slide. How are we contributing as anesthetists human factors? University of Aberdeen came up with their paper in the early 2000s, anesthesia non-technical skills, ANTS. From then onwards, initially there was no purchase. Nobody really believed that this is going to help. Slowly and gradually people warmed up to the idea, and these human factors became important. This is an area where we must improve ourselves, and this is an area where our intervention is going to go miles. Just the fact that we can communicate and improve our teamwork, just the fact that we should be more aware of the situation that we are in, improve our decision making, provide a leadership role, improve patient safety culture, improve the whole culture of speaking up, and then systems, incorporate systems that are going to improve things, not single entities, not single individuals, systems improving things. What has it showed? Unbelievable numbers again. 28% reduction in mortality, 35% reduction in complications, 20% improvement in the patient outcomes, 41% reduction in adverse events. Again, these are massive numbers. You do not see these numbers in ordinary trials. What do the surgeons see? Surgeons only see the operation. Surgeons only see the surgical field. That is what they are looking at, and that's their job, which is fair enough. I'm not saying they should be looking at our monitor, but that is what their focus is, and they become a little tunnel vision. I'm not going to use the word blind, but I would say they become a bit tunnel vision. What do we see? I think that's where I can, if I remember the share correctly, है कहाँ तमन्ना का दूसरा कदम यारा, हमने दश्ते इम्का को नक्शे पा पाया. So this is that nakshe pa. We've already been there. Team communication, we have conquered that. Crisis prediction, we are there now. Pharmacology, we know pharmacology. Hemodynamics, ventilation, coagulation, human factors. Anesthetists are driving all these things. Anesthetists are in charge of all these things. And hence, the surgeon can focus on their surgical field alone. The only reason Surgeon can do that is because Nakshe Pa pe hamara control hai. We are looking after the perioperative wheel, and that is our Nakshe Pa. This is what I believe our footprint is. This is where we need to go. So this is far cry from 300% mortality from the days, yeah? Okay, so 30-day mortality driven by systems, perioperative outcome, failure to rescue, reduction in complications. And this is the last slide. So the wheel is in between. This is the systems. These are the systems. And the outcomes are going to be determined by the systems. And those systems are determined by anesthetists. Anesthesia is central to all this. The fact that we can collaborate, we are now in a position to collaborate, will improve outcomes and hence save lives. So any questions, please? Our question at the end.
Thank you, sir. There are no questions in the plenary talk. So we end over here.
Thank you to all the speakers for your distinguished talks. May I request our respected chairpersons to kindly present certificates to the speakers as a token of appreciation. For this, I would like to invite Dr. Shahab Naqvi on stage to please collect your certificate. Thank you, sir. Dr. Saida Haidar, please collect your certificate. Dr. Ehsan Wakar, please collect your certificate. Now I would like to invite Dr. Akhtar Aziz to kindly present the certificates to our chairpersons. Dr. Hamid Ali. Dr. Ana Altaf. With this, we come to the end of this session. Thank you to our esteemed speakers, chairpersons, and audience.
This is the QR code for this first session, and if you want to scan and give, I would request everyone to scan and give the feedback for the first session. Thank you.
Assalamu alaikum and good morning everyone. Welcome to session 2, a panel discussion on training, education and research in anesthesia. This is a topic close to all of us who have trained in Pakistan and continue to shape the next generation of anesthesiologists. We are honored to have two exceptionally distinguished chairpersons with us today. Dr. Nasreen Laik is a professor and head of Department of Anesthesia at Lady Reading Hospital, Peshawar, and served as president of PSA Center from 2018 to 2023. And Dr. Naila Asad as head of Department of Anesthesia at Queen's Medical College, Ehsan Mumtaz Teaching Hospital, Lahore, and currently served as vice president of PSA Center. I warmly invite both of them to please take their seats on the panel. I now hand over to our respected chairperson to formally open the session.
Bismillahirrahmanirrahim. First, I would like to invite Dr. Fazil Hamid Saab, who is currently working as the Puri Bal and Noor Muhammad Ali Momin, Endowed Chair, Professor of Anesthesia, and Associate Dean for Faculty at Aga Khan University Hospital, to please come on stage and present his speech.
Okay. Bismillah ar-Rahman ar-Rahim. And I think after listening to three very, very distinguished talks, I'm really mesmerized because Dr. Shahab, then Dr. Saeeda Haider, and Dr. S.N. Waqar. So this morning, I think the scientific committee, I am really thankful to them for giving me this opportunity to talk on a topic which is near and dear to the heart of many examiners, many trainees, and the candidates who normally appears in the examination. So just a little bit of introduction to the topic. Topic says anesthesia examination in Pakistan. Are we meeting the international standards? So before I proceed to give the introduction, I would like to invite my worthy panelists, and they are very senior examiners and medical educationists. First of all, I would like to invite Professor Ashraf Zia, who is the Dean Faculty of Anesthesia at the CPSP and Head of the Department of Allama Iqbal Medical College, Jinnah Hospital, Lahore, Professor Ashraf Zia. Next, I would like to invite Professor Saleh Qasteli. Saleh Qasteli is the Head of the Department of People's Medical College of Damafsha and sort of an extremely senior examiner by himself. Then I would like to invite Dr. Nasir Ayub Khan. Nasir Ayub is having this distinction that he is a medical educationist anesthesiologist and also a liver transplant anesthetist by himself. So he has done a PhD in medical education, Nasir. And then finally, I would like to invite my dear friend and colleague, Professor Amin Khwaja, who is the head of the Department of Anesthesiology at the National Institute of Cardiovascular Disease, and also a faculty member of the Faculty of Anesthesia at CPSP. Just like we have heard the history, so again a little bit of the reason for this discussion that we are having today. It's very simple, because we have come a long way. Our examination system, and for the sake of sort of a, duration that the time that has been given to me, I will restrict myself to MCPS and FCPS exit examination only, exit examination, and I will not talk about part 1 and anything. So again, historically, our examination has come a long way. We have evolved from a time when the MCPS used to happen in individual centers, individual, hospitals, and there was no structured viva. Similarly, the FCPS was not having a structured viva as such, and we have heard from Dr. Saeeda that the structured viva started, in the mid-2000s. So again, coming from a modest beginning of no structured viva, we started structured viva in both MCPS and FCPS. There was no OSCE, used to be no OSCE. We started OSCE, and then we converted to TOCS. There was long case was always there, and some of you may remember that in the long case we used to have a physician and a surgeon coming to examine the anesthesia candidates. I was examined by a professor of medicine and a professor of surgery, and he certified me that I am an anesthetist. So again, we have evolved. We have evolved from the perspective that our long cases were also not structured, but now at least we have got some sort of a semi-structured long cases. And this, I think what the objective of this today's session is just to see as to how our current examination system, if there are certain misconceptions, certain perceived assumptions, and certain, theories in the mind of people, often we heard from them, whether they are true, and can we do something to improve these things further, our examination system further. And when we compare it to international studies, obviously we have got 3 examination system, one is, or 2 rather, one is ours, and we just want to compare it with FRCA, Fellow of Royal College of Anesthesia, and American Board of Anesthesiologists. So if briefly we see that what difference they are doing, I think mostly in their examination, they have got structured as the basis of their examination. They've got feedback to the candidates as the basis of their examination. They've got competency-based assessment as the basis of their examination. They've got simulation station or simulation use as the basis of their examination. They've reached to the point that there is very little variation. So if a set of examiner is there, if that set of examiner is examining, he will produce exactly the same result if that set of examiner is producing. So now, I think with this brief introduction, and again, please remember, our examination has been very robust. Why our examination has been very robust? Because the candidates who are passing through our examination system are gaining or going, as Saida mentioned, going to different part of the world, and they have proven themselves to be as good as any other, candidate from their part, because they do their examination. So examination robustness is there, the training part chilled. But the debate now is, are we now lacking behind from the international things? Are we lacking behind certain modern facets of education that we should incorporate in our sort of examination? And if that is the case, how can we address that? So after this, we will have some questions from our worthy panelists, and following that, we will try to wrap up the session with certain recommendations, key recommendations, and the idea is only one. That we want to, as Professor Tipu introduced this structure viva, is there anything that we, the now examiners, can suggest to the CPSP to introduce it to our examination system so that next generation of the trainees and the candidates benefit from this. So again, coming back to now, to our worthy panelist, my first question is going to be from Dr. Ashraf Zia. So Dr. Ashraf, this is a very common sort of a, misconception in mind of some of our juniors, like, they are not being made examiners. So my question to you is, our examiners, they are like trained in assessment methodology, or are they primarily selected based on seniority and experience?
Sir, thank you very much for giving me this opportunity to be here. My first question from the hall will be, who amongst all of us knows that what is the current mechanism of selecting an examiner by CPSP? Those who know, please raise your hands.
Anyone? Okay.
जिनको आइडिया है कि जी एग्जामिनर्स को किस बेस पे सिलेक्ट किया जाता है, अगर नहीं है तो आई विल लाइक टू एक्सप्लेन, बिकॉज सर का जो क्वेश्चन है कि आर वी सिलेक्टिंग एग्जामिनर ऑन द बेसिस ऑफ एक्सपीरियंस और एनी अदर methodologies like that. So let me briefly describe it. After passing this exam of FCPS, which is taken by the very senior examiners, जो कि आपके बड़े बहुत ही seasoned examiners होते हैं, the fellow after 3 years of experience is allowed to submit MCQs for further taking up as an examiner. So after 3 years, he is allowed to submit MCQs, which are then reviewed, and after 5 years post-fellowship experience, that person is allowed as an supervisor. So after 5 years being supervisor, then after 6 years, he is allowed to be observer for MCPS and IMM exams. And after 8 years, he is allowed to be examiner for MCPS and IMM. While after 8 years, he is allowed to be observer for FCPS exam, and after 10 years, he is allowed to be an examiner for FCPS exam. So this is the examiner system. When he comes as an observer, he is asked to observe the exam along with those who are seasoned examiners for 2 times. He is not opted as an examiner for the first time. So after 2 tenures, then he is taken up as an examiner, initially for MCPS and IM, and then secondly for FCPS. So this is the mechanism of selecting examiner, and I think this is fairly enough to judge a person as an examiner. After FCPS, 3 years MCQs, then 5 years being supervisor, and after 6 years, then 8 years and 10 years There are few exceptions in some disciplines which are which have certain less number of examiners. Otherwise, this is examiner selection criteria.
Thank you, Chef. And the next, I think.
Sorry? Workshop भी हो रही हैं, and other important point is that recently उसका जो एक system develop किया गया जो examination की जो आप एक और आपका question था कि are we training examiner or we are inducting just as such. So we have started, CPSP has started their workshops, and along with that their training sessions, and anesthesia training session is coming in the queue in few months.
So this was another the concern of some of the people that whether our examiners are formally trained in assessment or not. So Ashraf Zia has answered this, that now the CPSP is planning to conduct training sessions for the assessment methodology for our examiners, and I hope that all the examiners, whether seniors or juniors, when we'll be coming to examination,
they will have to go through that system.
Fair enough. So now I think I move on to Dr. Amin Khwaja Sahab. Amin Khwaja Sahab, one of the issue that our candidate faces in the long case is that sometimes the variation of the cases are such that one candidate can get a small, easy case, the other candidate gets a very difficult one, and then obviously the long case is a structured one. But sometimes one portion of the long case is not that much structured, and the examiners usually decide on the day of the examination what is to be asked and things like that. So is there a sort of a need to introduce paper patients in FCPS long case and assess clinical skills as extended talks in our examination system?
Sir, thank you very much for inviting, and thank you organizers for choosing me to be a panelist. That is the valid concern of the candidate, and as an examiner, I also see this is the. I think it is an open chapter for the examiner, whatever he wants to ask. Now, as sir you have said, paper patient is a necessity. Yes, in the last faculty meeting, it was in principle decided, and it was minute that paper patient should be introduced, and that was sent to the council. Now the paper patient and extended talks. So this is called as an hybrid model. So one thing, paper patient helps to assess the patient, and extended talks, which initially in the 90s that was called as an OSCE, still in FRCA it is being used. In practice in FRCA. So we are doing talks that was converted by the College of Physician and Surgeon that helps the candidate to assess the history taking, extended talks, communication, then examination, and the leadership role. So that will be very helpful if we introduce this thing also, the extended talks. But the paper patient is already been minute, and it is being sent that this should be introduced. Because in the COVID era, Dr. Gohar was with us, and she was the, she introduced, we did a paper patient, and that was appreciated by all the candidates and also by the examiners.
Thank you. Sir, Salih, you would like to add something?
Sir, if you allow me, can I talk?
Yes, please. Yes, please.
Sir, I am also in the favor of paper patient, but the problem which we observed in 2 exams, paper patient, that was just a viva question. So the simulator which were presented were either house officers or some persons from CPSP, and they don't have any comorbids, but the candidates reproduce some murmurs and things like that, and we in those candidates who were properly fit and have no comorbid. So I am in the favor of paper patient, but it should be like that. There should be some approach to that clinical methods, and candidate must diagnose something क्योंकि जो आपका पेपर पेशेंट, वैसे जो पेपर पेशेंट आपने प्रेजेंट किए थे उसमें इट वाज जस्ट सम सॉर्ट ऑफ वाइफा क्वेश्चन, सो इट नीड्स टू बी, जो हमने अभी सबमिट किया है, वी हैव सबमिटेड दिस टू द काउंसिल फॉर अप्रूवल विच इज़ इन क्यू, वी आर वेटिंग फॉर दैट, बट वी नीड टू प्रैक्टिस अ लॉट बिफोर वी make some sort of paper. What sort of paper patient we need to produce for the candidates?
Salih?
ज़िया साहब ने सही कहा है, लेकिन जो सर का सवाल ये था कि एक्सटेंडेड टॉक्स, तो जब आप पेपर पेशेंट विद एक्सटेंडेड टॉक्स करते हैं, दैट इज़ अ हाइब्रिड मॉडल. दैट एक्सटेंडेड टॉक्स stations will help the examiners to assess the patient, how to take a history, examination, communication, decision making. So this is the question was paper patient plus extended talks. So
thank you both of you, Ashraf and Amin, and I think
yes sir,
last comment from Salih, and
yes,
then we move forward.
As far as long case is concerned, from last 1 year, College of Physician Surgeon had training of the examiners, and in which they emphasized that if there is patient, both examiners must make consensus key prior to embarking on the taking examination. So that will make the generalization and fair examination of every candidate. Apart from this, as Professor Amin said, I have been also in faculty this time and last faculty. So we had a very great experience of the paper patient in alternate to the original patient. In last exam in which we were together, we had at the 11th hour, no patients were coming. Yes. And we put one baby of anemia to one candidate. So that was difficult for him. It was not generalization.
So yes, thank you. I think the problem that is being highlighted is that, it is very difficult for the examination department to gather patients on the day of examination. Then on the second day, the same patient comes. On the third day, sometimes those patient comes, those patient refuses, the another group of patient comes. So I think that is the reason we are discussing this, and Ashraf, and I think the current the faculty is very, I must appreciate that they are trying their level best to communicate and convince to the CPSP Council to have this change implemented as soon as possible. And obviously, the limitations about making the, correct paper patient is going to be there, and hopefully our senior examiners, the young examiners sitting here will obviate, will overcome this problem. So now, I think again, as I talk about non-technical skills, my question, Amin, to you is that, are we texting the non-technical skills such as communication, leadership, teamwork, and crisis management adequately in our current system of examination?
Yes, and the FCPS examination is doing two things. We are doing a knowledge assessment, and we are doing a clinical assessment. Still, it is inadequate. Non-technical skills like communication, leadership, and other professional crisis management, that is not limited, that is in a very limited part we are assessing in the form of the tables or the talks or sometime. But yes, in FCPS exam, we are assessing the knowledge and clinical skill, but non-technical skill, it is very limited portion we are assessing. So if you go through the FRCS exam, they have gotten a simulation based, so that helps the patient candidate to assess the real time how to manage leadership, teamwork, that is all included in their examination system, but we don't have. We are just assessing two things, knowledge and clinical.
Nasir, you would like to add to this?
Thank you very much, sir. First of all, the CPSP is taking all the summative examinations. So if we see summative examination, then they are doing very good work. But what you are saying, for that we need to introduce a pragmatic assessment in our training programs, so that at the end of each module, they can be assessed, and there you can get different feedbacks. There you can see DOPS, you can see 360-degree feedbacks. There you can assess. CPSP also has introduced ACLS. If you see, to some extent, those things can also be assessed indirectly. Of course, still they are not a part of our final examination, but ATLS, ACLS also include those things. So we can, to some extent, we can assess those things.
So, Nasir, coming from there, I think anybody from the audience? Yes, sir. Yes, sir. So, first, Professor Tubu and Arshad, but we want the audience to be brief in their comments because we have given a very limited time, sir.
I'm sorry, you have been given a very little time. We need more time. Two quick things that regarding the assessment, as Amin has said, you are doing clinical knowledge assessment in theory and in viva, and there is a lacking problem that you cannot assess all the knowledge base by MCQ only. So we need to do something at that end also, that we are seeing at this moment a lot of candidates who are short of that. Second, when you are examining for the skill, then again the paper patient does not fulfill all the requirements. Live patients were at one time, but as we have said, there is a problem. So the actor patients are very good at this moment, and that should be there also. And there should be a mechanism of skill determination. Time frame, yes, 4 years, 5 years, 10 years, something like that. And the other thing that the first requirement of the person is he submits 25 or 50 questions, and that's it. And what sort of question he submits, what happens to that, no feedback. The last thing is that we must introduce a feedback mechanism from the candidates for the examiners, because वो अक्ल कुल नहीं है. Thank you.
Thank you, sir. This question is there with me, but Arshad, please, brief comment and then we move forward.
No, sir, it's not a comment, question.
Okay.
So, but before the question, two one-liners. Pehla, any system is as good as the people who are using it. The second, there's formative assessment and there's summative assessment. And at this moment, we are discussing summative assessment only. My question is that CPSP goes to great lengths to have 2 examiners on each SEC station, Viva, long case, wherever. The whole idea is to have a fair assessment by 2 independent raters. And I'm focusing on the word independent raters, which means the raters are supposed to be independently rating without any adjudication. So my first question is that are you making sure that they are rating independently without any adjudication? Second, that also is a measure of the competence or the performance of the 2 examiners, that their rating is then over time compared with the ratings of their examiners, and that becomes a measure of their performance as an examiner. So are these 2 steps being ensured?
So Arshad, sorry, I think thank you very much for this, and I think on behalf of the panelists.
Answer the question.
Okay, please. So I will not take any further question from the audience, because audience can comment and give their opinion. Please give their opinion on the topics that we are discussing. Don't ask question, because if you start asking question, there is not going to be a limit, because everybody has got certain question in their mind. I will request, if some question or some discussion is being generated, please give your opinion of what is best, what is not best, was it advisable, what is not advisable, sort of a thing. Don't ask questions, because otherwise it will end till late 5 p.m. or maybe, please.
Sir, thank you very much. In fact, the topic is so important, the time allocated is, I think it's not sufficient for this.
Yes.
Let me respond to the question asked by Dr. Ashataki. Your first question was that there are 2 examiners, and are they taking the exam and marking independently as per instruction of the college and observation made by the convener, and there are CCTV cameras and everything like. They are assessing the candidate independently and marking out independent sheets, which is submitted immediately to the CPSP people who are there. If there is a great disparity between their marking of the 2 examiner, that is taken up by the CPSP, not at the right time, but after maybe 1 or 2 attempts, that this examiner is not fair enough, it may be biased, and that is then filtered out. This is the system currently CPSP is following. Thank you.
So again, Arshad, taking this, your question, I will ask from Saleh. Saleh, please.
Yes.
Are we, documenting or monitoring the inter-examiner variability at CPSP level, because you're also a member of the CPSP faculty? And if we are doing that, are we doing something to, communicate to the examiners that there is a big variability in your assessment or from this examiner to this examiner?
Yes, sir. As Professor Ashraf said, there is mechanism. And mechanism is robust, but it's not because for many reasons it's not in practice. If we ask our own performance, they email us. Controller sends us email in last exam what you did, how you rated your candidates, but not for the others. Being a responsible person of faculty, as Professor Arshad highlighted 2 points. To me, this effect exists. This is called as panel effect as well as halo effect. Panel effect is that when after the two examiners are sitting together, sometimes though they are restricted by College of Physician Surgeon, but sometimes they have some discussion for final marking of that candidate. That should not exist. That's our own fault. That's not the fault of the College of Physician Surgeon. And then another is halo effect. If a candidate is known to me, or he's, at the beginning he's going to perform well, then we think he knows every stuff of this content. So this also matter. So there are international certain studies. They said one cohort of the examiner have variability from other cohort, almost 16% variability. So this does exist. But for the borderline cases, it matters. One candidate passes with the panel, maybe that candidate fell with the other panel.
So again, the question and the discussion that Arshad initiated is related to the fact that are our current examiners marking the candidates independently, or they are marking the candidate based on a discussion sort of a thing, and which is a very, very valid question. And I think we should take certain steps, sir, as Dean of the CPSP, to identify the individuals who are doing this, because this actually harm the candidate in a longer, in a way, sort of. So,
sir, thank you very much. CPSP is trying its maximum to make this exam non-biased and transparent. Okay. Recently, what they have introduced that initially we knew which roll number is going to which examiner, and maybe we all are colleagues, maybe someone said, KG, please, my candidate is coming, look over it. Now, nobody knows which candidate is going to be presented to which panel of examiners. They just write it candidate 1 and candidate 2, and result is not announced like that on the spot. It is emailed to that candidate through his or her email. So your question will be taken up, and I will convey this to the President and Council, and what at the end I will suggest, if you have any suggestion, so please convey to Professor Fazal or to me, to be conveyed to the President or to the Council, because we all are working together for the betterment of this exam system and to produce the better quality of patient doctors and our consultants.
So I am being told that last 2 minutes are left, but so before, I think I would like to take chairperson permission to at least take 5 more minutes, because we were given.
This topic is very important.
We were given 40 minutes for this session, but suddenly I am being told that only 2 minutes are left, because in my watch it is only 30 minutes I start the session. Talal, is there something discrepancy somewhere? Because it is only, we were given 40 minutes. No, I'm just asking. Somebody told me there's only 22 minutes left. We were given 40 minutes. It's only 30 minutes, we have started, it's only 30 minutes. वो घड़ी सर गलत चल रही है ना, वो घड़ी के टाइमिंग जो हमें बताई गई है उसके हिसाब से नहीं चल रही वो घड़ी, सॉरी खैर, अच्छा सॉरी सर आपकी इजाज़त है, कुछ 10 मिनट ले लें इसके ऊपर, और टॉपिक बड़ा इम्पोर्टेंट है, अगर आप इजाज़त दें तो
आगे इम्प्रूवमेंट की स्ट्रेटजीज
it should be discussed, because one more suggestion which has been forwarded to the council is to incorporate foreign examiners. We have made a request to bring the foreign examiner in all systems, yes,
very good,
to make it more well recognized and transparent.
So this is, I think, Arshad, this is very important, information that Dr. Ashraf has given to us. And again, coming back to same because most of the concerns related to examiner variability, biasness, things like that. Sorry, Nasir, can examiner bias, conscious or unconscious, significantly affect results?
Yes, it can affect, because as Dr. Saleh had said about hollow effect, sometimes some examiners are very strict, some are very lenient. Sometimes we get impressed even by the accent of the candidate. They are speaking very good, they present themselves very good, even their knowledge is not very deep, so it can affect.
Okay, so what is anybody from the problem that is, we have always, I have been an examiner since 1997. I examined with individuals who are very, very, dominant, and they used to undermine the younger examiners. So the question here is that if we have to overcome this, what sort of a strategy shall we use? Any examiner from this table of anesthesia, please, because we need to have their opinion about how can we, overcome this problem whereby a senior examiner guide the younger examiner कि ये तो ऐसा था वैसा था इसको fail कर दो या pass कर दो. Sorry, maybe very occasionally, but it does happen. Arshad, can you comment on this?
देख रहे हैं और उसको एक स्टैटिस्टिकली कंपेयर करते जाएं तो आपको पता चलेगा, क्योंकि प्योरली इस वक्त तो आप एग्जामिनर बना रहे हैं कि इतने साल हो गए, इतनी एमसीक्यू सबमिट कर दिए, बट हाउ आर दे परफॉर्मिंग एज एन एग्जामिनर? कोई ऑब्जेक्टिव क्राइटेरिया यही हो सकता है कि आप उसकी रेटिंग को दूसरों की रेटिंग से कंपेयर करें एंड डू इट कंटिन्यूअसली, तो आपके पास डेटा आ जाएगा।
सर हम इस पे इंटर रेटर लाइबिलिटी कैलकुलेट कर सकते हैं, जिससे एक्चुअली मैं वो आंसर मेरी तरफ नहीं था, इसलिए मैं अगर हम इसको कैलकुलेट करें, मेजर करें, तो इन फ्यूचर वी कैन यूज दिस, देन ट्रेनिंग एंड प्रोफेशनलिज्म रिड्यूस इट।
डॉक्टर गौर, 10 मिनट हो गए, बोले टाइम बार बार घंटी बज रही है भैया, खत्म करना है मुझे इसके बाद। लास्ट कमेंट फ्रॉम यू।
सो डॉक्टर फजल 2 और 3 पॉइंट्स, एक तो प्रीवियस के भी थे, शायद टाइम ना हो तो मैं बात ना कर सकूँ। जो पहली चीज़ डॉक्टर अशरफ जिया ने बताई इफ अबाउट द एग्जामिनर्स, सो आई डोंट एग्री दैट्स काइंड ऑफ अ सिंपल रिटन document is available at CPSP. So we should not mislead the junior. Yes, the supervisor is a very clear guidelines and paper is available that who can be the supervisor and this requirement. So examiner ki we need to have that written so that everyone should be settled down. Secondly, about this is my, yes, the written examiner, yes, I know the supervisor can be that, there's a very written standard document is available, but as far as I know and my recent knowledge,
no. Sorry, on this, Ashar did share with me, sorry, that there is a notification of the CPSP and he was trying to project it here, but I said to him with the perspective, there is a notification.
Some maybe notification is something else, and that the examiner's criteria and everything written in that side. Secondly, about sir examiner, majority of the thing is about the professional conduct. ये जो ऑब्जेक्टिव चीज़ें हैं दैट वेरी वेरी इंपॉर्टेंट, द क्राइटेरिया इज फॉर प्रोफेशनल कंडक्ट, द कन्वीनर इज देयर इन एग्जामिनेशन एंड कन्वीनर रिपोर्ट इज अ वेरी इफ somebody who is convener and he really writes today what is happening, what is observed, who the examiners are talking to, that convener can interrupt, and we all observe that sometimes some of the people they do this. So I think the professional conduct is our responsibility, and the somebody who is senior as a convener is a responsibility, no matter if I'm a friend or no, he has to maintain the discipline of that, and every students observe that. So what is happening? And the third, that convener report, what happened with the convener report and what happened to the feedback of students. And the fourth is about inter-rater variability. There's a process there, but we are not discussing that.
So again, as these are very worthy colleagues who have volunteered to be the panelists, but please remember there are certain responsibilities which lie with the CPSP. And the CPSP actually at various levels, maybe they may not be communicating to individuals, they take the action on the convener report, because sir has been convener, I have been a convener, but I write reports. I noticed that, the change has occurred, and, in the subsequent examination, I found out that person was there or not. So that is, but again, so we, to conclude this, one single change that you would like to implement, Dr. Amin Khwaja, in the examination system, one single change that will affect the current system.
Time to time, examiners should be updated, and there should be some mechanism. They should be assessed by the College of Physicians and Surgeons, or there should be some teaching sessions. Because I'm honestly saying there is some fault in examiners also. So they have to be improved. With the duration of time, they are just with statics, and they are not following whatever the...
Thank you. One-liner, sir.
Sir, before one line, I would like to give one comment that this council, faculty has written given in writing to the council that feedback by the convener and by me from faculty as a dean should be taken up seriously, and it is being implemented.
Yes.
And one line I will say that it's continuous improvement process, because always there is space for improvement. So workshops for the examiners, for the supervisors, and continuous monitoring for transparency, and including foreign examiners to upgrade the exam system is my...
Thank you. Saleh?
Sir, training of the examiners and at CPSP level as well as at examination branch, that is inter-rater variability should be statistically assessed by them through their methods. The tools exist. So thereafter they should either train that examiner or may eliminate for further examinations. And another need is advanced simulation based examinations like virtual reality examination. They will eliminate many things of bias as well as ethical issues.
Nasir, as a medical educationist, please suggest some improvement.
I think that the process of quality control and assurance in assessment should be implemented. If we implemented that, then we know the weakness in our system and we can continuously improve it.
So with that, I think since time is very limited, but we have got a very senior examiner who has evolved and who has actually traveled with the examination system of CPS, Professor Tipu Sultan. I would request him to just conclude this by giving his final comments.
Thank you very much. A very interesting question that please give one-liner statement. So that is very interesting part of it. The one-line statement, I would like to say that there should not be so much centralized role of CPSP. The faculty of anesthesia and the faculty of other specialty should have a very clear role in the selection of examination, in checking of the examination and everything. The decision made at this moment should not be so much centralized that the president or any other person, not even the controller of examination, selects the examiners and he disobeys a lot of laws. So the role of faculty should be very clear, and scrutiny by the faculty should be, because in other especially there are a lot of very horrible stories. Thank you.
So
sir, just clarification. This faculty has autonomy from CPSP as far as whatsoever we give standardized policy for the examination. Only the selection of the examination is to the controller, because he has to manage throughout these all three centers. That could not be done by the faculty.
Because the majority of the examiners, they regret at very odd times. So it's not the faculty, because we don't have the whole list, but we have put this suggestion to the council that faculty should be given this free hand, at least to select the examiners, and then they can select any one examiner out of that.
I'm sorry, I disagree. I have been dean for 3 years, and there is no autonomy to faculty in selection of examiner. कोई नहीं पूछता किसको बुलाएं किसको ना बुलाएं, कोई रोल नहीं उनका.
Okay, sir. देखिए, I think there are certain things which is in the hand of our panelists. The purpose of this discussion is only that we take the feedback from these panelists, from individuals here, examiners, and maybe we can suggest some of the recommendations to the council. Whereas I think what the autonomy is, as they are saying that now they are more autonomous, maybe the time has changed. Khalid, from your time, maybe the CPSP has given them more autonomy now currently. So if that is the case, obviously thank you, and I think you have got now more responsibility as the CPSP faculty, because of all the discussion that we have had, may, if you can do maybe 25% of these discussion implemented, it will, go a long way in improving the examination stand. Thank you very much to all four of you and to the audience for a patient listening, and for the organizers for, listening to me and giving us this time, and to the chairperson also. Thank you very much.
Thank you, sir, Fazli Hamid Saab, and to all the panelists, and including all the audience for their valuable talk and discussion. क्योंकि ये टॉपिक बड़ा ही इंटरेस्टिंग है और इस पे जितना भी बोला जाए तो कम है, लेकिन हमारे पास टाइम की लिमिटेशन की वजह से हम इसको भी क्लोज करते हैं और सेकंड टॉक पे चले जाते हैं. थैंक यू जी.
Thank you very much, all the panelists. Now I would like to invite Dr. Hamidullah, who is currently working as Associate Professor, Head of Cardiothoracic Anesthesiology at Aga Khan University Hospital. Dr. Hamidullah, please. Thank you.
Assalamu alaikum. तो हमें पहले बता दिया कि आपके पास टाइम कम है. तो कोशिश करेंगे इसको छोटा करने की. So before I start, I would like to invite the panelist. The first panelist is Dr. Mohsen Nazir. He is the Associate Professor and Vice Chair Research at the Aga Khan University. Dr. Asiya Taqi, who is working as a consultant anesthetist at Call Associate Lahore. Dr. Salman Waris, who is a Professor Emeritus, Nishtar Medical University, Multan. He is a Professor of Anesthesiology at Multan Medical and Dental College. Professor Dr. Shaida Khwaja is a renowned anesthetist and healthcare leader with over 3 decades of experience and owner of National Hospital and Medical Center. So the question that I have is research in anesthesia, whether it's a necessity or a luxury. So I'll omit my presentation and take the question directly to the panelists and the audience. So there are 3 keywords in this title: the research, necessity and luxury. मेरा नहीं ख्याल इनमें से कोई भी लफ्ज़ मुश्किल है. So हम अगले आधे घंटे में ये साबित करने की कोशिश करेंगे कि research is probably a necessity, but it has some luxurious components as well. हमने सुना डॉक्टर शाहब ने जीनोमिक्स और AI एंड प्रिसिशन मेडिसिन की बात की. डॉक्टर सईदा ने तारीख़ बताई हमें, हाउ इट इवॉल्व्ड. डॉक्टर एहसन वकार ने पूरा बहुत ही एविडेंस बेस्ड presentation की. But we did not see any local evidence. We did not talk about the progress in research that this community has made. So that tells the state कि हम कहाँ खड़े हैं research के मामले में, especially in anesthesia. अगर हम अपना global footprint देखें of anesthesia research with respect to publications in the global world, so it's 0.1% according to the searches that I have made. So we are contributing less than 1% in global research in anesthesia. So मेरा पहला सवाल डॉक्टर मोहसिन से कि why should we do research?
Okay, thank you very much for inviting me in the panel. I will start with the basic theme of the research, that everyone naturally do research him or herself. Whenever you are prescribed some medication, or some interventions. Hello. Whenever you are prescribed some medications or some interventions, you go to the literature, you go to consult with someone, you get the data, you get the best options for yourself, and you opt that option. But when comes the problem of the population, of the community, of the patients, of your society, you don't go with this pattern. Why? So we should go with the same pattern, we should consult, we should get the data, we should do our own research, our audits, our researches, and then compile the results and apply to our population, which are beneficial in the long run, not only for yourself, for your family, for the community, for the society. The other thing is that you also contributing your data in the global data, because the overall results of the research that are publishing internationally, approximately 1/3 of the trials that are conducting currently internationally are conducting in developing countries. They are initiated by high-income countries, but they are conducting in developing countries. Our data is also part of their research, and we are contributing to some extent, but as a physician, as a clinician, we don't opt to initiate ourselves. So I think it's a necessity for us, for the clinician, for the anesthesiologist per se, and also critical care physicians. One more comment, the last comment is about the epidemiological changes, the environmental exposures, the genetic variations, and a lot of other stuff that are different in our nation. So we should have our epidemiological data, our genetic footprints, the expressions, the responses of different interventions to our body, and then contribute to the main literature. So these are very important aspects. Therefore, in my opinion, it is a necessity, and we should do whatever we think for ourselves, we should think for the society and for the problem of the society. Thank you.
Dr. Asiya I would like to ask, what if we use the data that has already been generated, published and presented and even validated in large cohorts? What is the harm in using their data? So
thank you, Dr. Hamidullah, for giving me the opportunity to talk. The data which is from the developed countries, it does not match ours because our population is different from them. In that manner, we have to do research which is being done there on our population. Because we have seen, we have done, I just want to mention the study, it was regarding the device iGel. You people must have used. The whole data, they have done study in our department. And you know, the size of the iGel, which they recommended for the population, that does not fit ours. Because our females, they were of smaller size, and they said size 4 like that. But hardly size 3 iGel that fitted to our population. So in the similar manner, the drugs which we are using, these drugs are like opioids. If you see, they give morphine, pethidine, and high doses. But when we give these drugs to our population, they fail to wake up early or quickly. So that causes delay. So we need to do, we have got drugs, everything, but we need to do some research on them so that how those drugs, their doses can be given. And one thing is that, like what he said, there's very scarce data regarding these things, and we don't have drugs in our public sector hospital where we can do research. And especially, I feel sorry to say, there are some, of us we don't use new drugs. We don't try them on our population because we are not familiar with them. So like that, these are the things which need to do. And one thing more, we need to see the socio-economic status of our system. We need to use those drugs which are economical, especially in the public sector hospitals. Anything else?
Thank you, Dr. Asya. डॉक्टर सलमान से मेरा सवाल ये है कि रिसर्च लग्जरी भी हो सकती है?
जैसे आपने कहा ना कि 0.1% हमारी कंट्रीब्यूशन है
जी
कि पूरी वर्ल्ड में जो रिसर्च हो रही है, तो दो कंपोनेंट जो हमारे फेलोशिप और जो एमएस के जो दो एसेंशियल कंपोनेंट में एक रिसर्च है जो डिसर्टेशन है या आपके पेपर्स हैं या आपके थीसिस है, ठीक है। अब वो बेसिकली आपको इनिशियल ट्रेनिंग देता है कि रिसर्च कंडक्ट कैसे करनी, ठीक है। और अगर आप प्रॉपरली उस पर रिसर्च करें, उसको खुद करें, तो फिर तो एक आपके लिए यूज़फुल पैटर्न और जो भी हम कह रहे हैं कि नेसेसिटी है, सब कुछ है। अगर हम वो किसी को पैसे दे के लिखवाएं और ख़ुद उस मेथडोलॉजी को अपनाएं ना, फिर वो लग्जरी है, ठीक है ना। लग्जरी आपको बायस्ड स्टडीज़ आती हैं, डाटा जितनी भी फार्मास्यूटिकल्स करवाती हैं, वो फ्लॉ जो है उसके स्टडी डिज़ाइन में है, उसके आउटकम में है, रिजल्ट्स में है, जिसको उनको फेवरेबल है, तो वो लग्जरी हो जाती है, उसके ऊपर मिलियंस ऑफ डॉलर्स कमाए जाते हैं। तो अगर हम प्रॉपरली ये जो CPSP भी उसको एक्सेप्ट कर रहा है और यहाँ पे गैंग्स बने हुए हैं जो कि सिर्फ फ्यू इंस्टीट्यूशंस के अलावा वो एक्सेप्शनल हैं, वो प्रॉपरली रिसर्च कराते हैं, बाकी सारी रिसर्च फ्रॉड हो गई, जो थीसिस के नाम पे, जो पब्लिकेशन के नाम पे, वो सब फ्रॉड है।
And anybody from the audience want to address this luxurious component of research? Sir,
Thank you. I think that the phenomena of intellectual dishonesty in academia is a real thing. आप इसको deny नहीं कर सकते कि हमारे पास हमारे setup में है।
I think we are not discussing this. Intellectual dishonesty is something else.
Anyway, let's go on to the component of the research.
That is luxury.
Just mentioned. तो luxury ये कि research की drive क्या है आपके पास? What is the phenomena that is driving your research? If it can be a luxury, it can be driven by an examination, it can be driven by some financial gains. तो वो outcome तो उसी पे dependent होगा.
Okay, sir.
भाई मेरा आपसे एक बहुत ही बेसिक सवाल है, ये किसने टॉपिक बनाया कि रिसर्च लग्जरी हो सकती है? हाउ इट इज़ पॉसिबल? रिसर्च कैन नॉट बी ए लग्जरी एनी टाइम, इट इज़ अ मस्ट, इट इज़ अ मस्ट, इट इज़ अ मस्ट। और ये जो यूनिवर्सिटी और तालीम की तरबियत जगह है, मुख्तलिफ जगह है, तीन तो काम है बेचारों की यूनिवर्सिटी के, तालीम है, हुनर है और रिसर्च है। हम रिसर्च नहीं करते इसलिए दुनिया में हमारा कहीं नाम नहीं है। और फिर आपने एनेस्थीसिया में रिसर्च की बात की है, अरे भाई रिसर्च तो हर सुबह दोपहर शाम चाहिए, रिसर्च ही रिसर्च चाहिए, उसके बगैर हम तरक्की नहीं कर सकते, किसी सूरत भी नहीं कर सकते। तो आपका टॉपिक ही गलत है ये।
Sir, can I add something? Sir, research definitely we can do, लेकिन मसला ये है कि रिसर्च के लिए फंडिंग भी तो चाहिए। सर पब्लिक सेक्टर में कहाँ पे फंडिंग इज अवेलेबल? सो दैट्स माय
सो असल में मुझे नहीं पता, हमें थोड़ा सा एक फ़ोन आ गया था, मिस हो गया था। बेसिकली रिसर्च इफ़ इट इज़ रेलेवेंट दैन इट इज़ नेसेसरी। रेलेवेंट रिसर्च एक्चुअली हमारे मुताबिक मुल्कों में जो इम्पॉर्टेंट चीज़ है, मैसेज है कि इस रिसर्च को रेलेवेंट होना चाहिए, जो आप उसको अप्लाई कर सकें। मैं किसी ऐसी चीज़ पे रिसर्च करूँ जिसमें पाकिस्तान में अगले 50 साल में वो चीज़ टेक्नोलॉजी नहीं आने वाली, वो मसला नहीं है, तो दैट काइंड ऑफ अ थिंग इज़ अ काइंड ऑफ उसको कह सकते हैं कि आप नियर लग्जरी, लेकिन बेसिकली रेलेवेंट रिसर्च इज़ नेसेसिटी।
Yes, so thank you very much. The word that is used as Mohsin, इस पे थोड़ा सा elaborate करेंगे। The context, the research should be contextual. So आपके कॉन्टेक्स्ट में जो सवालात हैं उनको अगर आप जवाब ढूंढने की कोशिश करें, so that research is necessity. आउट ऑफ कॉन्टेक्स्ट बेंच रिसर्च, मॉलिक्यूलर, जेनोमिक्स, फलाना ढमकाना, जब आपका बेसिक काम अभी बहुत कुछ वहाँ पे डेटा आपके पास नहीं है, सो प्रोबेबली दैट पार्ट, सर उसकी बात कर रहा था मैं, ये वाली जो रिसर्च है इसकी तरफ अगर तवज्जो ज़्यादा करेंगे तो वो शायद लग्जरी है जिसका ये श्योर।
अच्छा, आई जस्ट वांट टू से कि ये आपका थीम जो कॉन्फ्रेंस का था, दैट वाज गाइडलाइंस लोकल, जैसे डॉक्टर गौहर ने प्रेजेंट किया। सो इफ़ वी, हमें इतने टॉपिक्स इस कॉन्फ्रेंस में मिले हैं कि इफ़ वी जो फॉरेन गाइडलाइंस हैं, हम उनको जिसे कहते हैं ना A to Z या अपने सिस्टम में वी कैन नॉट उनको नहीं अप्लाई कर सकते। सो अगर हम अपनी सारे जो हमारे डिपार्टमेंट्स हैं डिफरेंट, कराची, लाहौर, एवरीवेयर, एक एक गाइडलाइन ले लें और अपने जो बच्चे हैं आपके, जिनके थीसिस, जिनके पेपर्स हैं, आप उनको दें और वो स्टडी करें, तो वो आपकी गाइडलाइंस तो खुद ही बन जाएंगी। और दैट कैन बी ऑन डिफरेंट ड्रग्स, दैट कैन बी ऑन एनीथिंग, द इक्विपमेंट, और इसमें कोई लग्जरी नहीं है, बिकॉज आप अपने सिस्टम को, योर पेरी ऑपरेटिव, लाइक डॉक्टर एसन सेड, ईरास, हर चीज़ को हम कर सकते हैं उसमें, इन दैट स्टडी।
So actually guidelines generate करने के लिए we need local data, because we don't have data, and we don't have data because we don't research. So मैडम से सवाल है मेरा कि what are the major barriers कि why we don't do research? We are the 5th largest population in this world. We have a very high percentage of surgical burden of disease. We have so many anesthetics going on. Despite producing so many, I would say, anesthetists specialized, we are still short. But again, we don't have data. So क्या barrier क्या है, क्यों नहीं करते?
जी, I think the biggest barrier is the need to do it. Incentivism. We should have some incentive to have a local population research. As we said, it's genomic studies. We don't have genomic labs, but I believe the simplest thing is that we can have it simply on our routine patients. If we have proper data, that how did the patient respond to, if we say, supposing जैसे डॉक्टर आसिया ने कहा कि जी response of morphine, we can see कि इतने patients अगर हम supposing data रख रहे हैं अपने 1000 patients का, तो we should honestly see कि किस patient की क्या response थी, उसके लिए कितनी डोज की ज़रूरत थी। मतलब we don't need to have very elaborate labs to do it, because even internationally I think genomic labs are very few. तो इसलिए पाकिस्तान के अंदर जो मैं बिलीव करती हूँ वो ये है कि हमें अपनी ये नियत रखनी चाहिए कि जी हमने अपने बच्चों को इंसेंटिवाइज करना है कि अपनी पॉपुलेशन के लिए, विच इज़ देयर फ्यूचर जनरेशन टू टेक केयर ऑफ, वो अपनी स्टडी करके अपने पेशेंट की रिस्पॉन्स टू डिफरेंट ड्रग्स वो देखें। जैसे अभी कहा कि जी ब्रिटिश पेशेंट्स की डिफरेंट रिस्पॉन्स है टू डिफरेंट ड्रग्स। I remember thiopentone for a Pakistani patient used to be just 150 milligram to put that patient off to sleep, और जब गोरा आता था तो उसको 250 milligrams देता था। That was a dose जो कि हम normally books में भी पढ़ते हैं, और हमारी इतनी books जो लिखी गई हैं उसमें हमारा अपना research का patient related data इसी वजह से नहीं है, because हम research करते हैं but we don't like to publish it। हम उसकी collection करके अपना एक साइड पर रख देते हैं। दैट्स व्हाई आई सेड वी नीड टू हैव इंसेंटिव कि जी हम यही कह देंगे जी हमारे इन बच्चों के जब पेपर पब्लिश होंगे इनके नाम आएंगे, चाहे लोकल जर्नल्स में दे दें, इंटरनेशनल जर्नल्स में दे दें, उनके साथ उनके अंदर थोड़ी सी जोश आएगा, उनके अंदर टू प्रोड्यूस देयर ओन डाटा रिलेटेड टू देयर ओन पॉपुलेशन होगा। एंड सेकेंडली आई थिंक रिसर्च के लिए वी डोंट नीड टू हैव very highly specialized labs or things like that, and I don't think so it should be very costly, क्योंकि अगर हम अपनी as anesthesiologists हमारी जो pharmacokinetics and dynamics है, हम clinically भी अगर देखें और routine test के साथ patient की response देखें, तो I think we should be able to collect a lot of data। और ये जो जैसे अभी हम कह रहे हैं CPSP के जो research papers होते हैं, उनके अंदर भी जो बच्चे हैं वो जो पेपर्स अपने निकालते हैं, आई होप दे आर नॉट द फिक्टिशियस नंबर्स, दे हैव वर्क फॉर दैट, और उनके सही उससे रिजल्ट्स आए, उनको भी कंपाइल करें तो बहुत अच्छा हमारे पास रिसर्च डेटा आ सकता है।
जी, ये तो आपने मैंडेटरी रिसर्च की बात की ना, ये तो अभी थोड़ी देर पहले बात हुई कि ज़बरदस्ती कराई जाती है और ऐसे और वैसे और यूं और तुम। व्हाट इंसेंटिव should be there for a research? What is the incentive that anybody can give to?
I think that, जैसे मैंने कहा, if we ask them to publish their papers, that is one of the incentive for the younger generation कि जी उनकी international publications
So
आई हैं।
what are the other barriers to research?
Can I?
Yeah, go on.
I think
I agree with madam कि incentive होना चाहिए, but the first thing is barriers तो बहुत ज़्यादा है. The first barrier is the children are not ready to make a research. They are not interested in it.
नहीं, let's not discuss children. Let's discuss us.
हाँ, तो उसमें ये कि उनको incentive आप
नहीं, मुझे क्या incentive चाहिए?
आपका monetary incentive मैं दूंगी तो आप research करेंगे. This is the basic fact. ये basic barrier है हमारा. कि हम किसी आपको मैं monetary incentive दूंगी.
So you think so
आजकल monetary incentive is the basic incentive which is drawing them. What they do is they run away. They don't do it. उनका कोई interest ही नहीं है.
So
can I add something?
So you think that all the publications that are happening, ये जो international level पर research हो रही है, इसका कोई monetary incentive है?
Internationally नहीं, मैं तो local की हम बात कर रहे हैं. हम अपनी बात कर रहे हैं.
Can I comment on incentive?
A short comment.
Yeah, I believe we should not go back what it has happened. We should work on the time protected. One, for incentive. Second, we as a society go into the industry that raise the funds as a grant for the local people, just as an incentivize to work your research. Third is to, like in a research is a moral responsibility, is a contribution to our society, like Dr. Tipu said, I absolutely agreed. The third is the problem with the solution is a research. What the local problem, we more focus on it in spite of going on the literature to see the problem of Canada and America and work on here is a useless. Thank you.
Okay. आपका कुछ जी? हाँ, वो ज़रा सामने आए ना.
अस्सलाम वालेकुम, डॉक्टर फजली करीम. मेरा ख्याल ये है कि जैसे मैडम ने कहा कि मॉनेटरी या फाइनेंशियल का बहुत बड़ा बैरियर है. हमारे बहुत सारे यंगस्टर्स जो हैं वो इस टाइम पर कोशिश कर रहे होते हैं टू मीट एंड्स मीट, लेकिन उनके पास टाइम नहीं है. या तो वो अपना काम कर लें टू
So time is a barrier.
Barrier plus financials. So there should be two teams. One should be for research and they should be financially supported, and other team should be providing data with financial support. So there should be a team work.
Okay, so finances, time. Anything else? Sarfaraz.
So thank you. So basically we know a lot of barriers, but if we want to have a way forward, so I think there should be a research culture in the department.
Culture in the
department, as somebody said, incentives. So PSA and other bodies are incentivizing resident for best poster and like that. So research culture in the department institute, funding from the department and institute to the
funding होगी कुछ और
and support staff is very important. Infrastructure, because people don't want to go into research because they don't have support, because they have to do clinical work.
Agreed.
So research assistant, research support in the department, that is really helpful.
Yes.
Thank you.
और फिर सर,
ये जैसे मैडम ने बोला कि आपको नियत होनी चाहिए.
नियत.
Self determination is the key. If there is a will, then there is a way.
Right. नियत. हाँ?
ये चारों पांच चीज़ें आई एग्री विद दैट. दूसरी बात इज़्ज़त व तौक़ीर, जो कि आपको रिसर्च के हवाले से होनी चाहिए. और लास्ट ये है कि कल्चर डेवलप करना चाहिए टू अचीव ऑल दीज थिंग्स. इसके लिए मेरे पास एक सिर्फ शेर है रिसर्च के हवाले से कि खुदा तुझे किसी तूफ़ान से आशना कर दे कि तेरे बहर की मौजों में इस्तराब नहीं.
Mohsin has a comment.
So my comment is about the incentivization. So So every research work may not have monetary incentives. They have recognitions, as discussed by Dr. Tipu. And also, we have different forums from where you can get your financial supports. We have national and international bodies from where if you have a good quality project, you can get grants. And over the year, I have been reviewing the abstracts of PSA from last 4 or 5 years, and I have seen there's a lot and lots of improvement in the quality of the projects. We are coming, and recently one of our colleague has got a global grant from IARS, Dr. Asma Abdul Salam. She got the grant. So we are working on it. We are searching things. We are approaching different bodies, national and international bodies. So I think our direction is good. But the next level is the deep learning, is the machine learning, is the predictive modeling. So now prepare for that, and for that we need a data, a big data. If you don't have the data, you can't cope with the global pace. So my suggestion for all to start working on it today.
Dr. Fadl.
With due respect, sir, देखिए बहुत सारी बातें हो गई. मैं सिर्फ ये कहता हूँ कि हमारी younger generation is struggling to have both ends meet. You know, you cannot have this luxury of doing research if your home does not have enough economy to, you know, sustain a house living. We are passing through a very difficult time now that, you know, suddenly the inflation and everything has gone so much that our younger generation, you know, we are seeing the result of this effect psychologically, traumatically. You know, we hear from these individuals that, you know, we cannot sustain our, I am a associate faculty, I daily from AKU even, the younger faculty comes to me and says, sir, we are having this problem, we are having this. So again, when we are talking about research culture, sir, talk about economy of these individuals. अगर हमारी इकोनॉमी अच्छी होगी तो रिसर्च होगी, इकोनॉमी अच्छी नहीं होगी तो रिसर्च करना सिर्फ पेट भरों का सौदा है. आई एम सॉरी, जो भूखा पेट है वो पहले पेट भरेगा, उसके बाद रिसर्च करेगा.
डॉक्टर गौर.
जी थैंक यू वेरी मच हमीद. अच्छा हमीद, मैं कुछ मुझे ऐसा लग रहा है कि कुछ नॉर्म्स चीज़ें होती हैं जो एक्सपेक्टेड होती हैं और हम उनको अब हम जस्टिफाई या हम कह रहे हैं कि क्या हम करें. देखिए यूनिवर्सिटी जब होती है ना, कोई भी यूनिवर्सिटी, कोई भी आपके बड़े बड़े इदारे हैं, उनके कुछ काम हैं. और किसी भी यूनिवर्सिटी में यहाँ इतने सारे लोग बैठे हैं जो यूनिवर्सिटी की फैकल्टी है, असातिज़ा हैं. असातिज़ा का एक काम, यूनिवर्सिटी का एक काम है नॉर्मल कि उन्हें रिसर्च करवानी है. वो बेचारे यंगर को सब कह दे रहे हैं, यंगर तो जब करेंगे जब आपका कल्चर होगा. सो आई एम विद ऑल द यंगर्स की अवेलेबल है. तो बेसिकली जो एक नॉर्म काम है वो हम नहीं कर रहे, तो पहले देखना है कि हम क्यों नहीं कर रहे. अब इतने बड़े बड़े इदारे हैं, हमारे टर्शियरी केयर सेंटर्स हैं, दे आर सपोज टू डू समथिंग. मैं बिल्कुल इस पर हक़ में नहीं हूँ कि पहले हम डायरेक्ट जो है बड़ी ग्रांट पर चले जाएँ. मे बी ए स्मॉल ग्रुप कैन डू दैट, maybe a small group can do that. हमारा फोकस इसमें होना चाहिए कि मैं अगर उठा के किसी इंस्टीट्यूशन से पूछूं कि भाई डॉक्टर हमीदुल्लाह आप बताएंगे कि आपके 6 महीने में कितने पोस्ट ऑपरेटिव नोज़िया वॉमिटिंग हो रहे हैं, कोई डाटा है आपके पास, क्योंकि मुझे ये करना है. सो आप कहेंगे नहीं मेरे पास तो नहीं है. सो मैं ये कह रही हूँ टू स्टार्ट विद दैट, और ये हमारी रिस्पॉन्सिबिलिटी है. प्लीज़ इसको ना ये समझें कि लग्जरी है. कुछ बेसिक डाटा इकट्ठा करना, अपनी हेल्थ पॉलिसी में उसको डलवाना, दिस इज़ आवर रिस्पॉन्सिबिलिटी. और ये हम जवाब दें कि हम क्यों नहीं कर रहे, हम करें ना करें ये तो सवाल ही नहीं है. सो मेरा मतलब ये कि सब फैकल्टी बैठी है, फैकल्टी सोचे कि अपने डिपार्टमेंट में रिसर्च कल्चर क्यों नहीं बनाया. ठीक है, थैंक यू वेरी मच.
So I think what I get, the message is that research is part of your portfolio if you are a university appointee. वो अपनी बात जगह ठीक है सर कि इकोनॉमिक्स को तो फिर पढ़ाने पे भी मुश्किल हो जाएगी, फिर ये कॉन्फ्रेंस में कोई नहीं आएगा, ये सब हम सब काम कर रहे होंगे. So there are things that we need to do. We need to, I think, मेरी राय है कि हमें कुछ वक्त निकालना पड़ेगा, कुछ मेहनत करनी होगी. वो बात ठीक है कि बेंच रिसर्च और लैब रिसर्च, उसके लिए बहुत सारी फंडिंग, जैसे मोहसिन ने कहा, बहुत सारी ग्रांट्स अवेलेबल हैं. ये एक फोरम है, यहाँ से अगर आज कोई कमिट कर ले कि हम छोटी मोटी ग्रांट अपने PSA के मेंबर्स को देना शुरू करेंगे, जो बच्चे आके यहाँ प्रेजेंट करते हैं अपने पेपर्स, उनको ग्रांट देना शुरू करेंगे तो सो यस, ये बैरियर्स हैं. आखिरी क्वेश्चन मेरा ये है पैनलिस्ट से कि व्हाट आर
मेरी जो डॉक्टर गौहर ने बात की, पहली बात है कि डेटा कलेक्शन इज़ द फर्स्ट स्टेप. कि डेटा तो हो, कितनों को नाज़िया वोमिटिंग हुआ, कितनों को PDPH हुआ, आज किसी के पास कोई डाटा नहीं है हमारे. आई एम सॉरी टू से. डेटा इज़ द फर्स्ट स्टेप, उसके बाद रिसर्च अपने आप ही हो जाएगी।
So मेरा अगला सवाल यही है कि what are low cost, high impact projects that we can conduct while we are doing our routine work? Mohsen.
So for the low cost, high impact projects, we can have our institutional and provincial audits and also our national audits. And also we do have collect data from different cross-sectional studies within the department, within country, within province and across the country. So, and the most economical is we have online forms, Google Forms and RedCap, and you can easily send someone, there is no cost involved in it. You just prepare your questionnaire and you send it to the colleagues within the country or out of country and collect the data, because this data is very important for the future of your research, and for current era it is very important for predictive modeling.
So concluding remarks from everybody, Dr. Asia.
Anji, I just want to just add, I think so you all know that, कि हम सारे यहाँ पे कम से कम बैठे हुए हैं, the head of the departments, the emeritus and all of us. So study किसने करनी है? आपके juniors ने. So who is going to ask them to do the study? वो अपने ओन पे तो नहीं करेंगे, ठीक है, वो अपने ओन पे they can bring कि जी ये फलानी मैंने स्टडी करनी है. You are the ones who's going to tell them कि ये बेटा स्टडी इस तरह से नहीं, आप इस तरह से कर लो, तो उसका इम्पैक्ट जो होगा फाइनेंशियल बर्डन नहीं, और यू आर गेटिंग एवरीथिंग, स्पेशली ऑब्जर्वेशनल या क्वेश्चनर फॉर्म में, उसमें आई डोंट थिंक सो कोई इतना ज़्यादा इनपुट ऑफ फाइनेंसेस होती है. कैन एनीबडी टेल मी कितनी, डॉक्टर फजल बताएं इसमें कितना पैसा लगेगा? यस, यू विल नीड अ स्टैटिस्टिशियन. हाँ, लेकिन अगर आपने कोई बहुत उस तरह की स्टडी करनी है, उसके लिए यू नीड ग्रांट्स.
So I think टाइम कम है डॉक्टर आसिया, बट मेरा मकसद बिल्कुल ये नहीं था कि इस किस्म के स्टडी में पैसा चाहिए. मैं सिर्फ ये कह रहा हूँ, देखिए पब्लिक सेक्टर में आज आप जाएं, 2 बजे तक वो काम करेगा पब्लिक सेक्टर, उसका वो निकलेगा, वो पैसा कमाने के लिए निकलेगा. दैट इज
नहीं, इट्स अ पार्ट ऑफ आवर जॉब जी, करना है, सीपीएसपी की रिक्वायरमेंट है.
एक पॉइंट जस्ट वन पॉइंट हमीदुल्लाह, जस्ट वन पॉइंट. एक एफर्ट करनी चाहिए हमें कि किसी हर अस्पताल में एक डिपार्टमेंट ऑफ मेडिकल एजुकेशन हो, जहाँ स्टैटिस्टिशियन मौजूद हो, तो गाइड करे किस तरह स्टडी होनी है. अभी लोग धक्के खाते रहते हैं, लोग किसी अस्पताल में नहीं है. ये रिकमेंडेशन में लिखी है कि हर अस्पताल में एक डिपार्टमेंट ऑफ रिसर्च होना चाहिए.
सर वो बात की ना, और
जो टीपू साहब ने बात कही कि रिसर्च जो है वो एसेंशियल कंपोनेंट, इसमें कोई लग्जरी नहीं है, एसेंशियल है. अब बात आ गई कि हमारे क्या बैरियर्स हैं. सबसे बड़ा बैरियर जो वो इनिशिएटिव है हमारा, प्रोफेशनल, तो वो जो अगर प्रोफेशनल ऑनेस्टी आ जाए, हम यूनिवर्सिटीज़ में कहीं ना कहीं हेड कर रहे हैं, हमारी रिस्पॉन्सिबिलिटी है कि हमारे नीचे बच्चे रेजिस्ट्रेशन रिसर्च वर्क कर रहे हैं, लेकिन वो रिसर्च वर्क करवा रहे हैं. अगर वो प्रॉपरली खुद करें, उनको आदत पड़ेगी, और सिंपल क्लिनिकल स्टडीज़ में कोई ऐसा फाइनेंशियल इशू नहीं.
Madam, last comment. So
जी, I think we don't need to have a very comprehensive system to collect the data. अगर हमारे अपने performers department के हैं of the perioperative period, अगर हम खाली वही performers properly भर लें, और उसके बाद end of the discharge of the patient from the post-operative ward, अगर हम उसका लिख लें, उस पर comments लिख लें कि what happened to the patient, और उससे हम कम से कम अपनी एक लोकल डाटा कलेक्ट कर सकते हैं फॉर डिफरेंट पैरामीटर्स जो कि हमने उस पेशेंट के लिए फिक्स किए हों. दैट्स व्हाट आई बिलीव कि वी डोंट नीड टू हैव लार्ज अमाउंट ऑफ मनी और टेक इट एज अ लग्जरी फॉर डूइंग रिसर्च एंड कलेक्टिंग डाटा. थैंक यू
सर. लास्ट कमेंट.
लास्ट मैसेज एक है जिसका अंग्रेजी में बोलते हैं टेक होम मैसेज, और उसमें गवर्नर ने बहुत सही बात बोली कि रिसर्च कल्चर डेवलप कीजिए. और मेरी दरख्वास्त ये होगी कि हर डिपार्टमेंट में HOD साहब को ये कहा जाए, हमारी तरफ से रिक्वेस्ट है कि वो रिसर्च सेल डेवलप करें, रिसर्च कल्चर डेवलप करें, और किसी किस्म की कोई यूनिट बना दें अपने डिपार्टमेंट में, एटलीस्ट टू कलेक्ट द डाटा और डू सम अदर थिंग्स। किसी भी पैसा कौड़ी की इसमें ज़रूरत नहीं है, एक विल चाहिए जो कि होनी चाहिए। थैंक यू।
लास्ट फाइनल लास्ट।
थैंक यू वेरी मच। हमें एक नेशनलिज्म की नीयत है कि हम पाकिस्तान में हमारा क्या डेटा है। वी लैक दैट नेशनलिज्म। इस वजह से हम अपना कुछ भी नहीं बना पाते कि इधर से ले लिया उधर से ले लिया। बिल्कुल अक्रॉस द बॉर्डर भी रिसर्च हो रही है और उनके भी लेवल पे कोई इतनी इकानमी तो बेहतर नहीं है। हमें पाकिस्तानी के लिए हैसियत से कि हमारा अपना क्या है।
बस वही नियति की बात हो गई।
नियति की
मतलब वी हैव एनेस्थीसिया स्पेसिफिक जर्नल्स, डॉक्टर तारिक, वी हैव अदर जर्नल्स। एक भी वो बेचारे पेपर के लिए आपको कहते रहते हैं कि जी पेपर्स भेज दें, तो वो और कैसे आएगा। सो वी हैव टू कंक्लूड। कुछ चीज़ें जो मैं हाईलाइट करना चाहता हूँ एंड में, वी नो वी हैव बैरियर्स, वी आर अ डेवलपिंग कंट्री, बट वी हैव अ वेरी लार्ज डेटा सेट अवेलेबल जिसको हम सिर्फ ऑर्गेनाइज नहीं करते। वी जस्ट डोंट कलेक्ट डेटा, वी डोंट रिकॉर्ड डेटा। बहुत सिंपल से कुछ चीज़ें हैं जो कुछ मोहसिन ने हाईलाइट की। वी कैन डू सिंपल ऑडिट्स, उसमें कोई बहुत रॉकेट साइंस नहीं है। वी कैन डू क्वालिटी इंप्रूवमेंट प्रोजेक्ट्स। इवेंचुअली तो इस रिसर्च ने पेशेंट केयर को इम्प्रूव करना है ना। वी कैन डू सिंपल ऑब्जर्वेशनल स्टडीज़ जिसमें कोई अगेन कोई पैसा और कोई चीज़ें ज़्यादा इन्वॉल्व नहीं होती। एजुकेशन इज़ वन एरिया जहाँ हमने बिल्कुल, हमारे पास इतना बड़ा ट्रेनी पूल है। देर आर हॉस्पिटल्स हु हैव मोर देन 50 ट्रेनीज। हम कोई एजुकेशन रिसर्च हम उसमें नहीं कर रहे। वी कैन डू पेशेंट सेफ्टी रिसर्च। रजिस्ट्रीज इज़ समथिंग जो बिल्कुल आप एक डेटा सेट बना लीजिए और उसमें अपने मरीज़ का डेटा डालते रहिए, 2 मिनट भी नहीं लगते, कोई पैसे नहीं है। कुछ अरसे के बाद आपके पास इतना डेटा हो जाएगा, यू कैन डू एनीथिंग। और वो जो बात हुई जीनोमिक्स की और जीन्स की और हमारी पॉपुलेशन डिफरेंस की, वो सब हमारे पास डेटा होगा। जैसे सिंपल है, हमारी पॉपुलेशन में पोस्ट ऑपरेटिव नॉजिया वॉमिटिंग की क्या मेजर कॉजेज़ हैं। वी डोंट हैव डेटा। वी हैव सो मैनी पीपल सफरिंग फ्रॉम दिस बट वी डोंट हैव डेटा। और फाइनली हमें कोलैबोरेट करने की ज़रूरत है। वी आर सो मैनी, वी जस्ट कैन कोलैबोरेट एंड हेल्प ईच अदर। बैरियर्स हमारे पास हैं, हमें इसी टाइम में से थोड़ा टाइम निकालना है। कुछ जिम्मेदारियां हैं, कुछ रिस्पॉन्सिबिलिटी है, कुछ नेशनलिज्म है, कुछ नीयत है। बहुत ज़्यादा पैसे वाली रिसर्च भी हैं, फंडिंग अवेलेबल हैं। देयर आर millions of dollars grants who people have acquired. There are renowned researchers in this country as well, but हमें अपनी कम्युनिटी में थोड़ा सा इसको इन्हांस करने की ज़रूरत है। आई थिंक जब तक लोकल डेटा नहीं होगा, we cannot progress. If we have to progress, we need local data. With this, I thank you everybody for your presence and contribution. Thank you very much.
Thank you everyone. That brings us to the end of session 2. I would like to call a chairperson to distribute the certificate. Professor Shahida Khwaja. Dr. Asya Taki. Dr. Mohsen Nazir. Dr. Salman Waris. Dr. Nasir Ayub. Dr. Saleh Khashkheli. Dr. Ashraf Zia. Dr. Amin Khwaja. Now I would like to call our moderators, Dr. Hamidullah, and Dr. Fazal Hamid Khan. Now I would like to call Dr. Gohar Afshan to present the certificates to our chairpersons. Professor Naila Asad. Professor Nasreen Laik.
Thank you so much. Now we are done with the session 2. It's time for a tea break. We'll be having a short tea break of 15 minutes. During this 15 minutes, go and have the tea, enjoy the tea, and there will be an inauguration of the Scientific Exhibition Center as well. I would request the senior people, wo piche hogi, we'll be having the tea at the ballroom B at the back of this, and I would request the senior people to head to the henna room for the tea. Gigi. And there is an inauguration of the scientific exhibition area as well. Please do join that as well. Thank you.
Good afternoon, everybody, and Assalamu alaikum. I am Dr. Aqsa Aman Kato. I am Assistant Professor of Anesthesia at Shaheed Mohtarma Benazir Bhutto Institute of Trauma, and today's Session 3 coordinator. It is my pleasure to welcome you all in the Session 3, which is Advances, Controversies and Practice-Changing Science in Regional Anesthesia. To guide us through this today's discussion, we have two distinguished leaders in anesthesia. First, we have Dr. Alia Ahmed, who is a Professor of Anesthesiology and Vice Chair, Education at the Department of Anesthesiology, the Aga Khan University Hospital. Madam, please. We also have Dr. Hamid Ali, who is the Associate Professor at Sindh Institute of Urology and Transplantation. Dr. Hamid Ali has also served as past President of Pakistan Society of Anaesthesiologists. Please join me welcoming our chairpersons. I now hand over the session to our chairperson to call upon the speakers.
Assalamu alaikum everyone. So I will announce the first speaker. The first speaker of this session is Dr. Farjad Sultan. He is Director, Professional Development Center and Chair of the Department of Anesthesia, Surgical ICU and Pain Management at Dow University of Health Sciences. And he's going to talk on, is regional anesthesia the answer to the opioid shortage in Pakistan? Dr. Farjad Sultan.
Session 3. Session 3, sorry. Farjad? Nice. खुल जाओ भाई अभी हो जाए एक से
Assalamu alaikum. Thank you very much. I'd like to thank the organizing committee for giving me this opportunity to talk. There we are. So, is regional anesthesia the answer to the opioid shortage in Pakistan? So I'm going to start with, I have no conflict of interest at all. What opioid shortage? Opioids तो बहुत है हमारे पास, कोने कोने पे मिल रहा है, हर ब्रिज के नीचे मिल रहा है, सस्ता भी मिल रहा है. मैडम वो कंट्रोवर्शियल बात हो जाएगी, मैं वैसे ही बहुत सारी कंट्रोवर्शियल बातें करूँगा यहाँ पे, वो थोड़ा सा ज़्यादा कंट्रोवर्शियल हो जाएगी. So when we talk about opioid shortage, it's not the drug trade that we're talking about. There's no shortage over there. What we're talking about is in hospitals, the standardized medication, the medication that are there in the guidelines. Is there a shortage? So that's the context behind this. Why does it actually matter in Pakistan? Well, there's an ever-increasing surgical burden. We have an ever-increasing population, and with the population, we have an ever-increasing problems and surgical burden. We have very limited perioperative pain services available. These services, when I say limited, it's available in tertiary care hospitals, training centers, but proper perioperative pain services, are they available in all the small centers? I'm not sure. We've had a discussion in the morning about a shortage of qualified anesthetists. The brain drain, the people who get trained, they leave the country. So hence there's a shortage of these things. There's the intermittent opioid shortages as well. Quota utilization, I'll have a talk about that. If we have unequal healthcare access between the urban and rural areas, and then there's awareness and fear of opioid-related side effect. Dr. साहब, संभल के नशा दिएगा, मुझे जिंदा रहना है, उठ जाऊंगी या उठ जाऊंगा मैं, कम दिएगा, ज़्यादा नहीं दिएगा, दर्द हो जाए कोई मसला नहीं है, मैंने जिंदा रहना है, मेरे छोटे छोटे बच्चे हैं, मैंने ये पढ़ा था कि देते हैं तो मर जाते हैं. So all these sort of things that we look at. What are the pain management issues specific to Pakistan? Well, we have the Control of Narcotic Substances Act in 1997, which has restricted the procurement systems, the import dependency of the raw material. We don't make the raw materials, we import all the raw materials, and then we combine them and then manufacture these things. Regulatory restrictions on narcotics. So from what I've gathered from the companies and from the rules, they have to say this is the quota that we are making, and for this, this is the amount of raw material that we need to import. And then they get the permission for it. Maybe. There's a lot of red tape involved. What that does is it causes untreated postoperative pain, which then has a different spiral, and it delays mobilization and increases the complication, and that has a direct effect on the health of the patient and the health by default of the economy. If a patient is not functional, cannot work, is not a functional part of society, the economy will suffer. And as I've mentioned, there is an ever-increasing surgical load. Our narcotic control laws are quite strict. There are allocated quotas. Is there any margin of flexibility? They're not flexible about it. And it may be due to the things that have happened, the fear of misuse or diversion. We've had the example, if I want to quote an example, the ephedrine fiasco. Now we don't get ephedrine because XYZ people diverted it, they got it in for medical use and diverted it for different purposes. Warned again, got, stop ephedrine. The one big group of people to suffer were the patients. But they had to do it because it was being misused. And this was a warning that was given again and again. And that is the same fear they have for the opioids, getting the raw material in, and then it is being diverted. Then with the current geopolitical situation, which keeps on and on, our currency fluctuation, economy, the LC that opens, dollar rate changes, and less amount, large amount, it becomes very messy for companies to import these things. And with the, as I mentioned, the present geopolitical situation of getting material shipped in when the Strait of Hormuz is closed and a lot of things are based out of Dubai or the Middle East, it becomes quite difficult and non-cost effective, very inefficient for companies to keep it up. So there are different problems that we have. So what are the opioids that we have available in Pakistan? We have fentanyl, we have morphine tablets, we have morphine. These are the ones that are registered in DRAP, and these have allocated quotas for only specific hospitals. They have to go through the process. And then recently, we have sufentanil and remifentanil. They've just been introduced into the market. They are registered with DRAP, but there's, again, the problem with the red tape of the allocation of the quota, how much to give, how much to not give. If you speak to the DRAP people, they think just because the name fentanyl is there, remifentanil is the same as fentanyl, and they don't realize that it's out of the system in 8 minutes. It's only for intraoperative use. So if they give the same allocation as fentanyl, it's not going to work. Someone needs to explain these things to them if they are willing to listen. So the glass is not half full, the glass is overflowing at that end. They're not willing to listen to these things, and that's where we get stuck with these things. Because using fentanyl is going to maybe not be as addictive as the rest of the other opioids available. I'm not going to mention tramadol or nalbuphine because they're not in a lot of the guidelines, international ones, and as mentioned before, maybe we need to rethink our local guidelines and put them in. But for that, we need data, complication data. Most simple being post-op nausea vomiting data, dose dependency. We have noticed at times that nalbuphine has a ceiling effect. Do we have the data for it? Are we collecting the data for it? Don't know. Most patients, tramadol does have a much more addictive potential than a lot of the other opioids available. Are we following these patients? We do not have the data for it. So this is where the opportunity for regional anesthesia comes in. We have spinal anesthesia, epidural, peripheral nerve blocks, and facial plain box, and we have a lot of technology around which has evolved over time. When I started anesthesia around 20-25 years back, yes, it has taken me, I am that old. We did not have ultrasound, was just coming in. We used landmark techniques, and ultrasound has just, the technology out there is amazing. But does it make sense in opioid sparing? Why not? It's not that complicated. If you think about it, there's reduced perioperative opioid requirement. If you have a motor block, why do you want to give opioid? I have seen people give a very nice block, patient has motor block, and then give opioid on top of it. And sedation. Sedation, fine if patient has anxiety, but why give opioid on top of a perfectly working block? It makes no sense, but people do it. So there's a lack of education. Regional anesthesia, there is less incidence of post-operative delirium because a lot of the drugs that affect the brain are not being used. It's very localized to a specific region of the body. And opioid-related complications, specifically in the extremes of ages, the very young and the very old, it's not there because, well, we haven't used the opioids at all. Pain management is with the local anesthetic agents. There's early ambulation, shorter hospital stay, and better turnover in the busy hospital. So the administration is quite keen for regional anesthesia because there's a more rapid turnover. More rapid turnover means better economy. So there's no problem getting the administration on board. The problem is otherwise. If you want to see the success stories of regional anesthesia, well, there's a spinal and epidural for cesarean section, labor analgesia. That has completely changed everything. Now, the standard, where it used to be GA for a cesarean section, is now spinal anesthesia, unless, and you don't give a GA unless there are very specific indications for it. Peripheral nerve blocks in orthopedics and plastic surgery, patient is awake, they're mobile, thank you. They will mobilize early. they get to go home. Most of them have gone to a daycare procedure, to the extent that in some parts of the world, shoulder replacement is a daycare procedure. Total shoulder replacement. Patient walks in the morning, gets an operation done, goes home in the evening. Rapid turnover. It facilitates all kind of surgeries, and with the growing ultrasound usage, initially with landmark techniques, we would be giving large volumes. The books have 40 ml of 0.5 bupivacaine, 60 ml. Now we're down to, in axillary block, 1 ml per nerve, supraclavicular block, 5 to 10 ml per nerve, interscalene block, 2 ml in the whole interscalene groove. So that's less volume with the same effect. Then we have improvement in technology. So this is one of the newer machines which is available in Karachi now. It's a handheld ultrasound device. We can use it. Ultrasound, you can see the nerve, you know where the needle can be going, you can see the tract, you can see any vessels, any complication, any anatomical things. There's more patient comfort. There's less chances of complication, and you don't need all those big bulky machines. These are small handheld, and they are available on, if you actually go around the scientific exhibition, they are handheld devices. I've seen a few over here which connect to your phone. That makes it very handy and very portable. But is it enough? Well, sometimes there is block failure for whatever reasons. The larger the nerve, the greater the chances of block failure, or less lack of training does. Visceral pain may persist. Duration of analgesia is limited. Again, you give local anesthetic, it is going to wear off. Lignocaine, 4 hours. Bupivacaine, 8 hours or so. It does require multimodal analgesia, yes, but with perineural catheters and elastometric pumps, this duration and all these problems can be mitigated, and the duration can be extended to 2 days, 3 days, 4 days, 5 days, as long as you know what you're doing. So what are the challenges of regional anesthesia in Pakistan? Well, appropriately trained anesthetist shortage. We've all talked about that. Limited access to ultrasound machines. There is a cost implication. Larger hospitals have it, smaller hospitals may not have it. Even if they do, they're more obstetric rather than the regional anesthesia. Heavy workload in public hospitals or larger hospitals, and there's a time constraint. The surgeons want a rapid turnover. Doc saab, aap bahut time laga rahe hain, kyun lag raha hai? So it needs to be planned. And then there's the auto prescription by surgical teams. No matter what you do in a lot of places, their junior is going to go and write down tramadol, metoclopramide, it's a standard. It's auto prescription. They will not look at our notes. So there is something that needs to be done about that. Urban and rural divide. Urban tertiary hospitals are better resourced. There's no rocket science about that. There's no doubt about that. Peripheral centers not only lack the equipment, but they also lack the manpower. And our regional anesthesia national training program, if there is, must be scalable to include all. What are the solutions for it? Well, for structured regional anesthesia, we have a lot of anesthesia training boards, FCPS, MCPS, MS, MD, DS, whatever it is. The training program should have it in a structured way. Increasing portable ultrasound access, there is a costing to it. Maybe the government can give subsidies on it. It is possible. We develop ERAS pathways. We've had a chat about ERAS and the importance of these things. And we need to standardize the regional anesthesia protocols. We need to document it down, make it a proper document, like the surgical safety checklist. It is there, established. We should have something for regional anesthesia as well. The role of professional bodies. Well, structured training program should be nationally. I've put down 3, PMDC, CPSP, and the PSA. Maybe there should be a credentialing pathway. A number of hospitals have it, all do not. Maybe the licensing bodies need to start a credentialing pathway. And there needs to be a mentorship program. People are willing to learn. We've had a number of workshops in every conference, and all these regional anesthesia workshops are always full, all over the country, all over the world. There needs to be a mentorship program. of them coming in to learn. What's the future direction? Well, investment in the workforce development, agreed, they're going to leave, but doesn't matter. They may leave, but 30 seconds. But they may leave, but we can train more. Better accessibility to pain service, opioid stewardship, and the mass education of the surgical teams. So take-home message, regional anesthesia reduces opioid dependency, it improves perioperative recovery, it's a no-brainer. Barriers are present but surmountable. So is regional anesthesia the answer to opioid shortage in Pakistan? Answer is yes, it is. But there has to be a strategic plan. Starts with the structured training program. It needs to be incorporated into the existing training. It's an evolutionary process. And there has to be balance with the surgical teams. So again, balance is not something you find, it is something you create. Thank you very much.
Thank you, Farjad. Question answer will be at the end of the session.
Thank you.
Our next speaker is Dr. Mohsin Nazir, Associate Professor and Vice Chair, Research in the Department of Anaesthesiology, Khan University Hospital. Dr. Mohsin Nazir.
Assalamualaikum. I would like to thank the scientific committee to give me opportunity to speak about it. The topic that has been given to me is awake craniotomy. Can it be done in limited resources? So there is no simple answer to this question, but we'll follow it and discuss further. So I have nothing to disclose. The roadmap would be the indication of the awake craniotomies, key criteria for selections, essential for conducting awake craniotomy, complications, challenges for awake craniotomy services and LMICs, recommendations that are customized to low resource settings, then take home message and summary. So starting with the awake craniotomy is considered as the gold standard technique for resection of brain tumors located in the adjacent eloquent cortical areas. The eloquent areas are actually regions responsible for the neurological functions, including the speech and language, motor functions, and sensory processings. So the primary indication for awake craniotomy is determined by the anatomical location of the lesion rather than its histopathologic type. But on the other hand, most of the tumor that has been evacuated or resected by awake craniotomy are gliomas. We have other type of tumors. There are gliomas which are low and high grade gliomas, metastatic tumors, and selected extra-axial tumors. These are some meningiomas, not all. The key criteria for selection are the location of the lesion. It should be supratentorial tumor within or adjacent to eloquent area. Patient cooperation. The patient must be able to cooperate, follow instructions, and remain calm during the cognitive mapping testing. And psychological readiness, that is a preoperative assessment of patient's ability to handle the procedure without severe anxiety. Now something about the benefits of the awake craniotomies. We have a number of benefits of awake craniotomies. I will discuss one by one. The first is the extent of tumor resection. In the real-time neurological monitoring, we can maximize the extent of tumor resection while preserving cortical neurological functions. Next is the risk associated to GA, that is minimized, and because of the intubation, mechanical ventilation, the risks are reduced as compared to the general anesthesia. The need for invasive monitoring is also individualized. It is minimize the need of invasive ventilation, but it is your individual decision that you put an arterial line or catheter. Then we have need of post-op ICU, that is also eliminated, almost eliminated or minimized the requirement for post-operative ICU in these patients. And the next is clinical outcome. The most important is clinical outcome. The superior clinical outcome with awake craniotomy as compared to the craniotomy under GA, there are significantly fewer post-operative neurologic deficits, 7% with awake as compared to 23% with the reduced average with the general anesthesia. And there is reduced average hospital stay. There is 1.7 days for awake craniotomy, but 9 days for the general anesthesia. Then functional recovery and health cost collectively enhance the patient's recovery, lower long-term healthcare cost, and improve the functional outcomes. One study that is conducted in 2017, the only cost-effective study of awake versus sleep, is the cost of brain surgery. It was a matched case control study conducted with the awake anatomy patients with direct cortical stimulations versus the patient under general anesthesia with intraoperative monitoring. The total inpatient expense in awake anatomy group was around $34,000 versus GA $46,000, with a significant reduction in awake group. And the length of hospital stay was 4.12 days in awake group as compared to 7.61 days in the general anesthesia group, which is also significantly lower in the awake group. So it concluded that the awake craniotomy is better in cost effectiveness and neurological outcome. Now some essentials of conducting awake craniotomy: as all other surgeries, we must have preoperative assessment. But for the awake craniotomy, we need to have neuropsychological evaluation of the patients, neuronavigation assistance during the surgery, intraoperative monitoring, anesthetic agents like different infusions, propofol, remifentanil, dex. Specialized equipment may also be required, and last but not the least is the trained multidisciplinary staff. And some equipment like airway management devices for emergency situations, monitoring devices, infusion systems, regional anesthesia, temperature management, seizure management, and positioning aid, because awake patient for the longer duration they stay supine or lateral or whatever the position of the neck is. So we need to have position aids for the patient. The other important requirement is a multidisciplinary team. For the successful awake craniotomy, a high coordinated multidisciplinary team is required, in which neuroanesthesiologists play a key role. Then the neurosurgeon, who is capable of resecting the tumor under awake condition with cortical mapping, the neurophysiologists who do the intraoperative neuromonitoring, the neuropsychiatrist for preoperative and postoperative assessment, and sometimes speech therapists for the real-time language testing during awake mapping. Now there are a number of challenges and complications during the surgery. The common are the cardiovascular instabilities, postoperative neurologic dysfunctions, and the airway obstructions. Then in LMIC, we have challenges for the awake craniotomy service to initiate, and we have the four major groups of the challenges that are lack of equipment, including neuronavigation devices or equipment within each hospital, cortical stimulator for intraoperative mapping, and intraoperative EEG. Then lack of expertise, lack of global or regional facility standards, and also cost of care. Although we have a number of studies published where in the low and middle income countries where the lack of equipment was there, in ideal situation, the formal cortical mapping is a must thing. It must be performed to maximize the resection of the tumor. Our study that is published, there is case series published in India of 8 cases of awake craniotomy with no formal mapping. Resection was guided solely by anatomic landmark and real-time feedback from the intraoperative testing. So outcome was acceptable. Only 2 developed transient neurologic deficit but recovered before discharge. The other cohort that is from Philippines, and in this retrospective cohort, the cortical stimulator was not used in all the patients. And the intraoperative complication rate in the cohort was 13.8%. And of patients who underwent tumor resection, the subtotal dissection was in 21%. So they concluded that, they recommended that the awake technique without the use of cortical stimulation lead to acceptable outcome, not the perfect, but acceptable outcomes. The other thing is lack of expertise and the step for the lack of expertise. The lack of dedicated structured neuroanesthesia training program in most of the centers. ICPNT accredited, that is International Council on Perioperative Neuroscience Training Program. We are lucky to have one program in Pakistan and recently accredited from ICPNT in AKU. And the other program within this region is in the Beijing. We have one fellowship that is sponsored by WFSA in Thailand. And we have lack of uniform credentialing process for the neurosurgeons also, because every neurosurgeon cannot do tumor resection in the awake condition. So a structured credentialing system for the neurosurgeon should also be developed. Then the formal dedicated the session for educational mission with the international societies like SNAC, and we do have online teaching for the last 1 year, that we do have online teaching for neuroanesthesia. Then lack of global or regional facility standard. The healthcare facility are not standardized by different societies. There's no available healthcare facility standards by organization and societies like WHO, like ASA, WFSA, or SNAC. Nobody described that which facility is capable of conducting awake craniotomy. There is no regional or local facility approval process exists, and no available minimal standard for facility approval exists. Then we have some recommendations for awake craniotomy service in LMIC is to establish minimum safe service requirements, as define essential versus advanced awake craniotomy service. Then build human resource capacity by training the multidisciplinary team, standardize patient selections, develop simplified institutional protocols, and establish quality and safety metrics. Now the take-home message is the question. The question that has been asked in the beginning, is awake craniotomy feasible in low resource setting? So the answer is yes, but conditional. Awake craniotomy is feasible in selected low resource setting if essential safety standards are maintained. Evidence from several LMIC centers show successful awake craniotomy can be performed safely without highly sophisticated technology when there is 4 things: appropriate patient selection, experienced multidisciplinary team, standardized protocols, and adequate airway and emergency preparedness. In summary, scheduling an awake craniotomy requires a specialized facility capable of coordinating a multidisciplinary team and essential intraoperative equipment and drugs. And we need to develop a safety standard for LMIC settings. And also we need to prioritize the patient safety over technological sophistications. Thanks.
Thank you, Dr. Mohsen, and that was very timely. That was very timely completed. Actually, we had planned to ask questions at the end of the session, but if there are any specific questions for Dr. Mohsen Nazir, we can take a couple of questions. Any questions for Dr. Mohsen Nazir on his presentation on awake craniotomy? Well, Mohsen, sorry to call you back because there don't seem to be any questions for you. Thank you.
Okay, Masha, thank you.
Okay, so our next speaker is Dr. Naila Asad. Dr. Naila Asad is Head of Department, Queen's Medical College, Ehsan Mumtaz Teaching Hospital, Lahore, and she is Vice President, PSA Center. And she is going to present on failed spinal scenario. What steps should be taken? Dr. Naila Asad.
Thank you very much for having me to talk about failed spinal scenario. What steps are to be taken? Now, what are the, just a very basics, what are the indications? Cesarean section, upper abdominal surgery, lower abdominal surgery, and urologic surgery. Now, what is failure? Let's talk about a little failure. जब आप टारगेट को शूट ही नहीं कर सकते, आप नहीं, टारगेट आपका आउट ऑफ टारगेट, एरो इज आउट ऑफ द टारगेट. नाउ देयर इज कंप्लीट, पार्शियल फेलियर, पैची, लो लेवल, रिग्रेशन. व्हाट इज कंप्लीट फेलियर? इज टोटल एब्सेंस, के इफेक्ट हुआ ही नहीं है, पेशेंट फील्स द पेन, न्यूरोलॉजिकल ब्लॉक फेल हो गया. पार्शियल एंड पैची इज डेवलपमेंट ऑफ पार्शियल ब्लॉक, आधी टांग हुई, आधी टांग नहीं हुई, द रेस्ट इज, और देयर आर सम फेलियर्स. मोटर ब्लॉक फेलियर है खाली, सेंसरी ब्लॉक फेलियर है, दैट यू हैव टू फिगर इट आउट. This was taken by this study by Begley et al. He did an incidence and associated factors on failed spinal anesthesia, and I found the incidence to be 1 to 17%. Then what are the causes of failure? क्या होते हैं? थोड़ा सा मैं I'm just going into the basics as well. Causes आपके ये होते हैं, ये आपने बच्चे को एक गन पकड़ा दिया तो वो आपको ही मार देगा, टारगेट पे तो कम ही मारेगा. So that is the base at no voice. Why I said that was a no voice. अगर एक पहले दिन आपका PG resident आया and you ask him to give a spinal, so definitely chances of failure. Now studies have shown this, Begley et al. He showed that children with anesthetists with less than 1 year experience, they have a failure rate of 43%, and in comparison to more than 3 years of experience, which they had a 12% failure rate. Another study by Demelli et al. Showed that less than 2 years of experience had 55 to 60% failure rate, with more than 5 years experience has 6%, 5.8% failure rate. The next is we are talking about what causes, one was experience, the other is faulty technique. The faulty technique would be site of needle insertion, size of needle, type of needle. So these are the certain types of needle. And talking about size of needle insertion, Shagri et al. Show that more than 25 gauge of needle that cause significant failure rather than 22, 24, that is 45% of failure rate as compared to 26%. Then we have another study by Naisora. He said incorrect needle insertion. Needle is half the way through. You think that you aspirate and you think the CSF is there, but when you push the CSF, it pushes the meninges forwards and your drug is not in the correct side. Either it's subdural or it is epidural. Malpositioning of the needle. Poor patient position. Poor patient position most commonly in obstetric anesthesia. So that is a cause of the failure. Coming to solution injection errors. Very common, and that is incidence. This study by Yuksek showed that he did total spinal anesthesia procedures 1004, and he found to be the failure rate to be 16%, in which 4.1% was solution injection errors. And that could be due to leakage, anything when the hub is not properly attached. And this is what I just said, this is from Naisora, that when you aspirate, the CSF is aspirated, but the meningeal layers, they move and the subdural injection occurs. This study by Demelli showed the dose of bupivacaine. The dose is important with the less 5 to 10 milligram, 34% failure rate, which is quite significant as compared to 19 or 20. Another study with the Shagri showed the volume of local anesthetic. Volume is important as well along with the dose. Less than 2 mils, definitely more failure. Okay, coming to anatomical abnormalities. This is an X-ray of a patient with a curved spine, scoliosis. ये मेरे पास सीमियो हॉस्पिटल में आया था. इसको मैंने I gave a paramedian लगा दिया था, paramedian लगा था. So this is most common where even with an experienced hand you can have failure. And this study by James Coe, he did it in clinical implications of neuraxial in the parturient with scoliosis, and he found patchy block or unilateral in 8% patients, and spinal needle placement failure was in 4%. Another study by Balarapu was, he compared thoracolumbar curve and Cobb angle in determining spread of spinal anesthesia and scoliosis. And he found that he divided into two groups. One was less than 50 degrees Cobb's angle, the other was more than 50 degrees. And in group B, he found 26.9% failure rate, which was more than 50 degree Cobb's angle, and group A 7.5%. This was quite statistically significant. Characteristics of the CSF. Bloody CSF is found to be cause more failure rather than a clear CSF, which is shown in this case by Demelli, that 69.2%, which is a significant difference. Another one which was done by Shagri, he also favored a bloody CSF with 45% failure rate. Intrathecal spread, inadequate spread. Hyperbaric solution, you all know that it tends to move down, so that can also cause a failure rate, and this is hyperbaric, 71% failure rate significantly as compared to isobaric solution. That is a cause of failure. Bekele showed also, this was that hyperbaric, this was a different study. He said he could not find it with hyperbaric, he said 1.4% failure rate, with isobaric 13.9%. Okay, this is unsuccessful with the type of surgery. Yeah, most commonly obstetric surgery में failure ज़्यादा होता है. That is, this study by Bagel showed that it was 37.5%, followed by orthopedic, and I think most often orthopedic में geriatric patients होते हैं. That's the reason. 25%. Then urologic is 15%. Yuksek also found the same findings, 28% failure in obstetric and 21% in geriatric as compared to non-geriatric, which was 13.17%. Urgency of surgery. In emergency situations, you are more liable to have failure rate high. In this study, Demelli, he found 43% failure rate in emergency situations as compared to 8.7%. Drug error, very common. आपने drug ही सही नहीं दिया आपको, and the most common drug is trazomine. ये बहुत commonly वहाँ पे use होता है जहाँ, और this study was done in South Africa, and they found the incidence of peri-op drug errors, they ranged from 1 in 133 anesthetics in retrospective studies to 1 in 2 operations in prospective study. ये बहुत common है वहाँ पे, because that is very lethal error. This was given by American Society of Anaesthesiologists in 2025 October. This was amended, that statement on standard practice for avoidance of medication errors in neuraxial anesthesia. And मेरा ख्याल है सबको पता है कि the most important is कि आप वाइल को खुद पढ़ें, वाइल को proper label करें, color coding कर दें, and you just label, and you should ask another personnel to recheck it. That's important. अच्छा, इसके consequence, अब failure तो हो गया, मैंने लगाया फेलियर हो गया, क्या कॉन्सिक्वेंस क्या होगा? सबसे ज़्यादा तो यह पेशेंट ने मारना ही है, पेन होगी, एंग्जाइटी भी होगी, एंक्शस होगा, आपको मारने आएगा, और तीसरी चीज़ है कि उसको भूत नजर आएंगे दिन में भी, और वो आपको मेडिकल लीगल, ही विल टेक यू टू द कोर्ट्स. साइकोलॉजिकल ट्रॉमा उसको सबसे ज़्यादा होता है. अब आप सोचें फेलियर हुआ, जिस चीज़ के लिए यू हैड गिवन हिम अ स्पाइनल, इट डिडंट वर्क एंड ही इज स्टिल इन पेन एंड शाउटिंग. So that is going to cause to the patient. And what are you going to bear? You are going to be embarrassed. अभी जी डॉक्टर साहब सर्जन ने कहा था जी बड़ा एक्सपीरियंस्ड एनेस्थेटिस्ट है, बड़ा एक्सपीरियंस है, तो आपसे लगा ही नहीं, ये एम्बैरसमेंट आपकी होगी. The other thing is you will be stressed out. What to do now? अच्छा भाई अब मुझे स्पाइनल अब हो गया, अब दोबारा लगाना है, जीए देना है, जीए की तैयारी करनी है, एवरीथिंग. सो यू ऑल्सो फेस द कॉन्सिक्वेंसेज, नॉट ओनली द पेशेंट. और मेरे जैसा मरीज़ होगा ना, वो तो ले जाएगा कोर्ट में, चलो भाई आ जाओ, सू कर देगा, बाहर तो सू होता है, मैं तो यहाँ भी सू कर दूँगा. सो दैट्स अ वेरी इंपॉर्टेंट एस्पेक्ट. व्हाट आर द चैलेंजेस यू हैव टू फेस? द फर्स्ट एंड फॉरमोस्ट चैलेंज इज अटेम्प्ट अगेन. Patient had gone through the pain of spinal, once again you are going to make the position, बैठो भाई दोबारा लगाए, वो कहेगा क्या आ गया ये. Risk of increased local anesthetic toxicity, you've already given it. Maybe insufficient analgesia, ऑपरेटिंग टाइम प्रोलॉन्ग हो जाएगा. डेफिनेटली आपने कहीं और भी जाना होता है, अभी भाई दूसरे को तो मैंने 12:30 का टाइम दिया था, वहाँ तो मैं पहुँच नहीं सकूँगा. Conversion to GA, and you have to convert it to general anesthesia. So this is the actual thing, what to do. What to do is the time from injection to the detection of failure. Failure कितना हुआ है, कौन सा failure हुआ है, sensory, motor, both. So we have to detect that and work accordingly. No block within 30 minutes, just repeat the injection, consider GA. Patchy block है, you can sedate the patient and or IV analgesia कर दें. और so it's all person to person, anesthetist to anesthetist variation है, आपकी practice हर एक की अपनी होती है. So those are the repeated, no block onset, 15 to 20 minutes, repeating the procedure with patchy or low block. You go for other things, you look for it, and the important thing is documentation. आप document ज़रूर करें, ये जो हम lack करते हैं, the anesthesia personals, they lack documentation. उसको ज़रूर point by point document करें. This was study by Bekele. He found that he repeated spinal in 6 and GA was given in 29. 35 में failure हुआ, जिसमें 6 में repeat हुआ, 29 GA हुआ. जिनमें 86 में partial block था, he gave ketamine, fentanyl, pethidine, morphine. Another study is its impact on maternal or neonatal outcomes by Narunath. And the rate of repeated block was 81%, converted to GA was 18%, and of those 81%, 6.5% में फिर fail हो गया. So वो finally GA में करना पड़ा. So this is just an algorithm which I have taken from Sithara Maya. Pain है, रुक जाएं, evaluate करें, skin incision नहीं हुआ, re-evaluate करें, repeat कर दें, और then you move on, फिर check करें, नहीं अगर नहीं repeat पे भी failure है, तो then you have to give GA. So this is just an algorithm. Summary, I would say to have a successful anesthesia, आपको failure को prevent करना है, cause को prevent करना है. The foremost cause is an experienced anesthetist line जिसको puzzles लगाने आते हों. He knows how to build up the block. फिर दूसरा जो बच्चों की ट्रेनिंग, वी कैन हैव सिमुलेशन ट्रेनिंग्स, हमें एक फॉर अ सर्टन टाइम पीरियड करनी चाहिए कि फॉर 6 months और वट एवर यू एवरीबडी डिसाइड्स, वो होती हैं बट बच्चे करते नहीं हैं एंड दे जस्ट अटेम्प्ट इट. एंड देन द करेक्ट डोज, करेक्ट प्लेस, ड्रग का एरर हम उसी तरह कर सकते हैं, प्रॉपर लेबलिंग. एंड आई एम अर्लियर इन टाइम. थैंक यू. आई थिंक आई हैव कवर्ड इट. एनी क्वेश्चंस? G. Sorry, mic dena beta.
First of all, I must say this was a very nice presentation, very thorough, in-depth, and the manner in which you presented was very palatable, and you could understand the flow of the whole thing. Thank you so much for that. I've got two quick questions. First of all, when you said, for example, the study you quoted from Dubai suggested that it was 16.6% failure rate, which is reasonably high. 1 to 17% is generally
1
acceptable.
to 17%.
So they were really at the higher end of the failure. Did they go into the depth of explaining the reasons? For example, did they have any proof of different difficult anatomy or the sighting of the needle?
They didn't. I took that in. That they didn't. Like I said, they repeated spinal. And then they had to turn some into GA, converted GA. But they didn't say what was the cause of the repetition of failure of the repeated spine.
So 7% was, for example, drug related.
Yeah.
I'm just wondering, how did they come to that conclusion? Did they provide the evidence that they had a failed batch of drugs that they eventually prove that they were inefficient? Second question would be relating to the practices generally here in the country. Are we taking consents in detail, and do we document them, and do we get any patient signature about it?
In our local,
local practice.
We do explain. We do explain all the things that it can fail, and we might be able, like the other day, I had one chubby patient. She was chubby, and I had to, for abdominal hysterectomy, and I already told her that we can have difficulty in giving spinal to you, but we are going to try. And so I do it, and we do have in public sector hospitals as well. I've worked there as well, and we used to do in our unit. But it's almost, if you go, I did not do a study on this failure rate actually, okay, how much residents I could have done it, but I didn't go for that. But we do have failure rates. It's not that we don't have it.
No, it's just because, you see, the general consensus, the general understanding is that if your patient, my patient, okay, is having pain during or immediately after the surgery, they would be told that this is part and parcel of the surgery.
No.
There will be some pain. No, I'm not saying you do it, but I'm saying the generally understand, is that if you've had an operation, you're bound to have some pain anyway, first of all. So when it comes to litigation and not compliments, at least at the end of surgery, but at least having not the kind of response from the patient or their families related to your anesthetic. I mean, how do we report it? Does it go to the PMDC? Do you have to declare it to your hospital that I've got so many complaints against me?
Yes, if you have a lot of complaints that the drug was not effective, you give a spinal, and it's not effective. And repetitively, if you find that, we do report it to the pharmacy that this drug was not effective, we have been using repeatedly, and there has been failure of effect. So we do report it to the hospital.
Does it go up a level from
Actually, there is somebody else who wants to ask
Sorry?
a question. There's someone else who wants to ask a question as well. And I would request that please introduce yourself and then ask the questions, okay? So that was Dr. Khalid Shah who was asking the questions. And now
I'm Dr. Ali Sarfraz,
this is the last
consultant in Khan University.
Yeah.
Just for the clarity, it's a primary teaching that whenever we are giving a spinal, so we prepare for the GA as well as a backup, because it may fail. Regarding the failure, as you showed the algorithm, I want to ask, in your experience, because I don't repeat a spinal. If it is failed, I have to manage with the GA or whatever. So in your experience, what is your experience in daily routine? Thank you.
Well, I would suggest, depending on the type of patient, if the patient is obese and you have failure, naturally you are going to have a difficult intubation as well. Personally, if the patient is obese and I fail spinal, I would go for, with everything, if I know I can do it, I will go for general anesthesia. I will not repeat the spinal to that patient because I know that the depth is more, I don't have that long needles to use for an obese patient. But if your failure rate occurs in a normal thin lean spinal, with that I can go for paramedian and I can use that I can go for one time another spinal just once and not keep on repeating, and if I again fail with the paramedian, just go for GA, that's fine. Personally, I would, and I had that experience. Recently, there was a hysterectomy wali thi, usko spinal nahi lag raha tha. Then I went paramedian, and then I just decided that I'll take one chance, and if I get it, I'll get it, otherwise I'll turn to GA.
But by failure, you mean failure of CSF to come out, or by failure you mean no action of the drug? Because once the drug has been put in, I feel we should not repeat the spinal.
The one I'm talking about is no CSF.
No CSF.
No CSF.
I think
that's
very important to differentiate.
I couldn't find the space properly. That was it.
Because I think repeating a spinal after deposition of drug is really, I think we should make that very clear for the juniors.
Total means that no drug is given, no aspiration. I'm talking about that. My experience with DIDA. But,
Okay, so, thank you very much. We have been asked again and again to wrap up this session. So,
I'm so sorry. बट मैं ये कहना चाहती हूँ कि आपने जैसे कहा कि हम कंसेंट लेते हैं टू बिगिन विद द प्रोसीजर जो कंसेंट होना है, इसमें हम एक्सप्लेन भी करते हैं कि इट माइट फेल, लेकिन जो मेरे अपने सेटअप का मैं एक्सपीरियंस शेयर करना चाहती हूँ कि प्लान बी की कंसेंट नहीं ली जाती पेशेंट से. वंस द स्पाइनल हैज़ फेल्ड तो हम खुद डिसाइड कर देते हैं कि अब आप इसको कैटामीन दे दें, अब आप इसको ये दे दें, अब आप स्पाइनल रिपीट कर लें, अब आप इसको GA में कन्वर्ट कर दें. तो ये मेरे हॉस्पिटल में ये बड़ा कॉमनली हो रहा है. और हमने उसको करना शुरू किया कि वो फेलियर की सूरत में भी इफ़ द पेशेंट इज़ एबल टू कम्युनिकेट, उनसे पूछा जाए कि प्लान बी आप क्या करना चाहते हैं.
वेरी राइट.
थैंक यू.
ओके, थैंक यू वेरी मच. थैंक
यू. Thank you, chairpersons and speakers. With this, we conclude our session. I would like to request the chairperson, Dr. Alia and Dr. Hamid Ali, to distribute certificates among speakers as the token of appreciation, please. Dr. Syed Farjad Sultan. Dr. Mohsin Nazir. Professor Naila Asad. I would like to request Dr. Fazal Hamid to come on the stage and give certificates to the chairpersons, please. Professor Alia Ahmed. Dr. Hamid Ali. Thank you.
Thank you, Dr. Aksa. Moving on for the next session, that is session 4, which is Meet the Experts, the when, why and how of anesthesia practice. To coordinate this session, I would like to call Dr. Ramala Shahzada from SIUT.
Assalamualaikum. My name is Dr. Ramala Shahzada and I am from SIUT Pakistan, and I am the coordinator for the session then the when, why and how of anesthesia practice.
To moderate this session, I would like to call upon the stage Dr. Jodat Salim. He is the head of Department of Anesthesia, ICU and Pain Management, PGMI, Lahore General Hospital. He is also the president of PSA Lahore and a member of the faculty of CPSP and University of Health Sciences. Please welcome Dr. Jodat.
Assalamu alaikum ji. Thank you PSA for inviting me for this session, and congratulations on holding your 44th PSA annual conference. So we are going to discuss a very important topic, and for which I'm going to call my esteemed members of this panel. And first of all, I would like to call upon Professor Safiya Zafar. She is the professor and head of department at SIAG, which is the Sindh Institute of Advanced Gastroenterology. My second panelist is Dr. Dilip Kumar. He is an associate professor and director perioperative anesthesia, clinical services at Khan University. My third panelist is Dr. Sadaf Malik. She is the head of department at Farooq Hospital DHA, which is the center of excellence for liver, kidney, bone marrow transplant in a private setup. Then we have Dr. Imran Iftikhar. Dr. Imran Iftikhar is he's an interventional cardiologist at Indus Hospital. He's an old friend of mine, and we started our career together in 1995 from Hamid Latif Hospital as medical officers. Then we have Dr. Salima. She's an assistant professor and a consultant hepatobiliary and pancreatic surgeon and program director, general surgery at Khan University. And then we have our final, the last panelist is Dr. Zahid Salud. He's an assistant professor of anesthesiology, head of department of anesthesiology and critical care at Kohi Goat Hospital, Mariz. And his special area of interest is obstetric anesthesiology and pain management. So our today's debate, it revolves around the phrase which we use commonly in our daily practice, unlimited times, in the operation theaters, in the preoperative anesthesia clinics, in the wards, in the ICUs, and that is the fit for anesthesia. Do we actually have a standardized definition for fit for anesthesia which is globally accepted? Or do we have an international guidelines or the reference literature? I have scrolled a lot of literature, but I was unable to find a standardized definition. Whatever is practicing in different parts of the world that is the term which is used as the perioperative assessment, and it all depends upon the hospital resources, the infrastructure, and the availability of your professional staff and trained staff over there. So Pakistan is no exception to that. In Pakistan, fitness of anesthesia has different meaning for different people. If you talk about the surgeons, it is the permission to operate. If you talk about the administrator, they have a shield of medico-legal coverage through this fitness of anesthesia. If you talk about the patients, it is a guarantee for them for a safe conduct of anesthesia and surgery. And for an anesthesiologist, it is a dilemma. You start with the history taking, you start with the preoperative optimization, you involve the different consultants regarding the perioperative optimization, you seek advice from a cardiologist, nephrologist, then you hold multidisciplinary meetings, and finally you counsel the family, you go ahead with the anesthesia and surgery, and finally, if God forbid something happens, you are also accountable for that fitness. So we in Pakistan, in different provinces, we are dealing with different setups. So there are setups like Khan University, Shaukat Khanam, who are very, very organized. They have got a very tagda anesthesia department. They can take anyone head on. Then we have certain public sector hospitals all over Pakistan, or wahan ka setup, I'm sure everybody knows how they are working. Then we have private setups. In private setups, there are tertiary care hospitals, jahan pe teaching units and anesthesia ke, and they are following the standards. And then we have setups, jo ke compromise condition mein kaam kar rahe hain. These are the small setups, junior anesthetists, and they have to face all the pressure through the administration, patient, and the surgeons. So this is the idea of all this discussion, but why we are going through all this discussion is we talk about the fitness for anesthesia. This is the AI generated definition which I found the most appropriate, and it states that evaluation of a patient physiological reserves and tolerance to anesthetic agent, specifically regarding their ability to withstand airway management, cardiovascular stress, and metabolic stability during a procedure. So our discussion starts from here. Fit for anesthesia. Is it a clinical judgment? Is it risk stratification or risk assessment, or all the way it's a misleading terminology? So should anesthesiologists be moving towards the new terminology, risk stratification, instead of fit for anesthesia? So this is the basic scope of this discussion. So my first question, now this is, if you go through this quickly, ये मैंने मुख्तलिफ जो anesthetists हैं, senior and head of departments, उनसे मैंने ये कुछ कहा कि what do you understand by fit for anesthesia? And there is no fixed definition and no fixed understanding of this terminology in different parts of Pakistan. ये मुख्तलिफ जगहों से आई हुई है. So the most appropriate, इसको हम follow करते हैं अपने setup में. No patient is unfit for anesthesia. It depends on the nature of the underlying surgical emergency. ठीक है जी. एक definition आई, any person who is breathing is fit for anesthesia, and that can include a brain dead patient as well, brain dead as well. And finally, coming to operation room, having anesthetic drugs, tolerated well, and yet going back without any disruption in hemodynamic is fit now, fit for anesthesia. Madam, your first question. What are the medico-legal implications of declaring a patient fit or unfit for anesthesia in view of healthcare commission? Can a physician, cardiologist, pulmonologist, or nephrologist declare a patient fit, unfit, and who is liable for the complication if it all occurs? ये आप ही क्या मैडम नाम के साथ
थैंक यू जौदत मेरा ख्याल में अनफिट फॉर एनेस्थीसिया तो टर्मिनोलॉजी होनी नहीं चाहिए अनफिट फॉर एनेस्थीसिया फॉर दिस मोमेंट हो सकता है कि इस वक्त फिट नहीं है लेकिन इसको ये चार काम कर लें तो ही विल बी फिट फॉर एनेस्थीसिया और जहाँ तक मेडिकल लीगल का ताल्लुक है तो द पर्सन हु इज़ गिविंग एनेस्थीसिया इज़ रिस्पॉन्सिबल फॉर दिस पेशेंट और देर इज़ नो रोल ऑफ कार्डियोलॉजिस्ट पल्मोनोलॉजिस्ट और नेफ्रोलॉजिस्ट टू राइट डाउन दैट पेशेंट इज़ फिट फॉर एनेस्थीसिया दे कैन गिव देयर ओपिनियन दैट पेशेंट को ये कोमॉर्बिड है ये प्रॉब्लम है दैट इज़ इट we are the person who will decide patient is fit for anesthesia or not at this moment और फिर हो सकता है एक दिन दो दिन बाद वो फिट हो जाए उसको करा दें हम.
Okay, I'll request Dr. Dilip because he has got a very comprehensive knowledge of medico-legal and he has studied a lot on this. Can you please elaborate this further?
Thank you, Jodha. Thank you. Actually, if we go back into the era, why the fit word came in the anesthesia? It was not in Pakistan. It was in a continent, even everywhere. Now it has been replaced. The first world they have replaced. Still it's practiced in the Pakistan, India, Nepal, in all that. And the term fit means completely fit. There is zero risk. But in the healthcare, there's no zero risk. If you go into the ASA classification, the ASA 1 healthy, which we call them in a fit, but as less than 1% risk still is there. So there's no zero risk in that. For the medico-legally, if we go like in the team for the cricket, it's an unfit. How can you take an unfit patient into the team? Like you have a blood pressure of 180 by 90 and you are for tympanoplasty. HbA1c 8. According to the medico-legal, it will be unfit. How you will, present yourself in the healthcare commission or judiciary, it will count it as unfit. If it's unfit, how you are taken into the operating room? So I believe, in Pakistan, we are also not practicing fit and unfit, unfortunately, but we use a lip word is a fit. Why? We use a pre-op chart form now, almost everywhere. In Karachi, I have seen, I'm not sure about we have an organized structured form. We can go through the systemic, cardiovascular and all that, and then we label them according to the ASA classification. Second thing, which is more important, is a patient counseling. For the cardiology, you are right. There are already, again, a classification for them to stratify the risk. One is RCRI, Revised Cardiac Risk Index, which is a very clear where, you cannot deny a surgery. Surgery has to be done, depend on the circumstances, like the doctor saying, okay, yes, the patient can be fit after maybe a few days, depend on the optimization. So, for the surgeons, cardiology group has changed into the MACE, Major Adverse Cardiac Event. This can happen, but you will take the patient into the operating room for the surgery. You cannot deny. For the future in the term, I believe we can use like in a patient is optimized for anesthesia. Patient need optimization before taking to the operation. It's a time sensitive, no room for optimization like in RTA, road traffic, the patient like obstructive hernia with the HbA1c of 8.5 and the 9. So we can use a comment in spite of the fit for anesthesia. That may help us in the medical legal.
Thank you, Dr. Deep. I think we should move on. Your next question, but be brief on that. That's how should an anesthetist respond? A colleague has already declared a patient fit to undergo Whipple's procedure in the preoperative assessment clinic, but on the reassessment on the day of surgery, you believe procedure should be delayed as he needs further workup and optimization. So how should we be being anesthetist? Because this is every other day scenario.
Actually, we all anesthetists are facing the same scenario every day in our practice. Like the same patient came in the clinic, was fit, now is upper respiratory tract infection. We know that they turn into the pneumonia and all that, the reactive airway disease. So what we should, okay, some surgeries are the cancer surgeries, are the time sensitive surgeries. We can take even with the certain risk, but need to define with the patient, surgeon, and to document it. But where the avoidable, because we all are here to, we all believe in the patient safety. So not to compromise the patient safety. Thank you.
Thank you. Pass on to please Dr. Sadaf. Dr. Sadaf, I'll give you two questions. What are the common pressures anesthetists face from surgical teams, administration, and patients regarding the clearance of surgery in a private setup? Pehla sawal aapse because you're heading a private setup, multidisciplinary. Okay? Particularly, I would like to know that there are patients who just arrange their vacation and their kids' management and they are there for surgery and they say कि मैं आज ही surgery करानी है. And with the rise of the Ozempic and the GLP-1 agonist, our definition regarding the NPO is rather, it has already changed. How are we looking at our fit for anesthesia criteria? Because you do a lot of bariatric surgery as well.
Thank you very much for inviting me over here. In my experience, मैं अपने पर्सनल एक्सपीरियंस की बात करूँगी तो एडमिनिस्ट्रेशन और सर्जिकल टीम से ज़्यादा जो प्रेशर है ना फिटनेस का वो पेशेंट की तरफ से आता है बिकॉज पेशेंट्स कम बाय अरेंजिंग देयर लॉजिस्टिक्स और उनको पसंद नहीं आता कि अगर आप उनको ये कहें कि आज आपकी सर्जरी नहीं हो सकती. तो 3-4 चीज़ें जिन्होंने आई थिंक विच हैव हेल्प्ड मी रन अ सेटअप एट दिस लेवल आर कि एक तो ये कि वी शुड जो वर्किंग एज अ टीम है वो आपको बहुत ज़्यादा हेल्प करती है. जब व्हेन यू आर नॉट दी ओनली एनेस्थेटिस्ट वर्किंग इन दिस सिस्टम बल्कि आप जो है वो एज अ टीम काम कर रहे हैं सो आपका जो कम्युनिकेशन है वो बेहतर हो जाती है. सेकेंडली हम स्ट्रेस तो बहुत ज़्यादा करते हैं कि कम्युनिकेशन स्किल्स बट आई डू बिलीव कि वी एज एनेस्थीसिया फ्रेटर्निटी आर द वीकेस्ट लिंक इन द कम्युनिकेशन स्किल्स. हमें अगर किसी पेशेंट से कोई बात करनी है या कोई चीज़ कन्वे करनी है तो मोस्ट ऑफ द टाइम वी से कि जी अपने जूनियर को कहते हैं कि जाके सर्जन को कह दें, जाके पेशेंट को कह दें या इसकी कॉल भिजवा दें. सो बीइंग एट द फोर फ्रंट ऑफ कम्युनिकेशन really helps. It makes a huge difference. Thirdly, ये कि we have to turn ourselves from the anesthetist to a perioperative physician. ये एक upcoming definition है या हमारा name है मुझे लगता है कि जो future में change हो रहा है and we have to live up to its standards. उसका मतलब ये है कि मैं ये नहीं कह सकती कि आप पेशेंट को ये पैगाम भिजवा दें कि पल्मोनोलॉजिस्ट के पास चले जाएं या नेफ्रोलॉजिस्ट के पास चले जाएं. वी हैव टू टेक द लीड. ये मेरा पेशेंट है, इसको मैंने एनेस्थीसिया देना है तो मुझे डिफ़ाइन करना है कि इसको क्या ऑप्टिमाइजेशन चाहिए, उसको क्वांटिफाई करें और उसको क्वांटिफाई करना ज़रूरी है. फोर्थ थिंग्स, क्वांटिफाई करना इस तरह ज़रूरी है कि आई शुड नॉट बी गिविंग माई ओपिनियन कि आई थिंक दैट द पेशेंट इज़ अनफिट. जिस तरह अभी बात की कि टॉक इन नंबर्स, टॉक इन साइंटिफिक टर्म्स, आप डॉक्यूमेंट करें कि मेस ये कहता है, आरसीआई ये कहता है, और जब आप सर्जन से, पेशेंट से और एडमिनिस्ट्रेशन से डॉक्यूमेंटेड आरसीआई, मेस या कोई भी साइंटिफिक टर्म में बात करते हैं तो आपकी बात में ऑथेंटिसिटी और क्रेडिबिलिटी ज़्यादा हो जाती है। एंड लास्टली ये कि ऑप्टिमाइजेशन को ना एक टाइम फ्रेम में होना चाहिए, बाउंड होना चाहिए। इट्स नॉट कि ये पेशेंट आज ये नहीं हो सकता, this is not it. When you go and talk to the patient, communicate well, talk in terms of scientific terms, when you are working as a team, आप उनको कहते हैं कि जी ये अभी ये प्रॉब्लम है, ये मैनेजमेंट प्लान है और इसको मैं इम्प्लीमेंट करूँगी और इसको 2 घंटे में कर लेंगे, 4 में कर लेंगे, कल कर लेंगे, और अगर मैं यहाँ पे नहीं भी हूँ तो वी आर वर्किंग एज अ टीम, वी आर अ ग्रुप, और आपको यहाँ पे 24 आवर्स कंसल्टेंट सर्विस अवेलेबल होगी, सीनियर बंदा अवेलेबल होगा, then people do understand. But again, it is a task, but we have to live up to it. NPO guidelines.
We'll switch to the next. Dr. Zahid, my question to you, what does fit for anesthesia actually means in modern anesthesia practice? And does a short neck, large tongue and limited jaw mobility in an otherwise healthy patient make someone less fit compared to his standard parameters?
Actually, the term fit is a magic word which every surgeon wants to hear it. And the moment you say unfit, they become annoyed. So it is rather a misprecise or misleading word. What fitness means is a scientific approach. As everybody has mentioned, we have to take the risk stratification of the patient, its assessments, its perioperative treatment, and then plan. And not only the risk planning, the other planning as well. The planning of what would be the outcome, what would we have to document it, and we have to share with the patient and share with the surgeon as well. So we have to formulate every aspect of it, whether it is physiological outcome, it is the disease-based outcome, or it is the anatomical or the age-based. So this is a complex situation. We come across that patient is fit or not fit. It is simply surgeries could be planned according to the anesthesia point of view, and surgeon also they do plan according to the surgeon's point of view. So I think it's a teamwork which has to be settled amicably with the surgeon, with the patient, with the relatives, and then our objective is to give a smooth sailing anesthesia and have a good outcome of it.
Thank you. Dr. Salima, this is a tricky question. And you're working now, Khan, I know perhaps you're not going to face this scenario, but we are facing it every other day, working in different public sector hospitals. So a 68-year-old diabetic and hypertensive patient with uncontrolled blood sugar, active chest infection, and a hemoglobin of 7 scheduled for an elective hernia repair. The case was postponed by the anesthesia team for optimization due to the above issues and was again brought next week list with the same parameters, and now surgical team is asking to proceed under subarachnoid block and proceed with high risk. Who is responsible for the management of the pre-operative optimization?
So first of all, thank you for the opportunity. So if we look at the scenario, this patient is a perfect recipe for post-operative complications and surgical disasters. And he's got all the modifiable factors, including diabetes, active chest infections, hemoglobin of 7, which can be modified. So if we are, it's not life-threatening surgery, it's not strangulation, it's not an obstruction. So if we proceed for an elective, or if we think that this patient is fit for an elective hernia repair, so I don't think from a surgical point of view, we are going to justify the indication in any way, either medico-legally or ethically. So to my mind, so the basic responsibility lies on the surgeon, because most of these patients present to surgical clinics, and surgeon is responsible for navigating the pathways, referring them for preoperative optimization, and referring them to medical internists. So labeling a patient unfit for this is, I think, is justifiable. However, as a surgeon, we need to understand that we cannot justify an elective procedure with a high-risk label on it, unless it is it's a strangulation or an obstruction, which is obviously a life-threatening condition, where we do have to weigh the risk versus benefits, where obviously the benefits are going to be much higher as compared to the risks. However, in this situation, we cannot just justify or compensate the unfit or high risk for proceeding without optimization.
Thank you. Dr. Imran, final question to you. A patient with acute cholecystitis is booked as an emergency at midnight, but on pre-op assessment, there is no clinical or investigation supportive in favor of sepsis, perforation, or hemodynamic instability. The patient has fast, stable atrial fibrillation, and surgical teams want to operate it immediately on the list. You have been called to give an opinion on this patient regarding the urgent versus optimization. So please tell us how to proceed.
Thank you very much, Joseph, and the PSC for inviting me. These patients, this is a time-sensitive call. Time-sensitive call means the patient who's got acute cholecystitis, and it's in the midnight, and you have to go for the surgery as it is urgent. The only one thing that can be modified according to the American Heart Association, what you can do is to control the heart rate. You cannot go for the optimization of the normal sinus rhythm or something. You just have to control the rate, and for this you can use IV rate limiting agents like beta blockers or calcium channel blockers, or even sometimes amiodarone, so to control the heart rate. And if the heart is around like 90 or less, you can proceed with the surgery, even if it is at the midnight or in the emergency. Later on, we have to take up the patient, and we have to know what was the cause, and was he having other things as well. But I think giving a clearance from cardiac point of view is very tricky. Even if like a mild risk patient who can have a plaque in the coronary artery and he goes for a surgery, he can have a coronary artery syndrome on the table. So American Heart Association has divided this major adverse cardiovascular events, and this is a very good tool. You just have to tell the patient or the attendants, mild risk is this, moderate is 5 to 8%, and high risk is anything beyond 10%. 8 and 10% above is at high risk. And they need to understand. So they need to understand if anything like Atakatsubu can happen on the table, you never know. It is a stress-induced cardiomyopathy that can also come on the table. So the main thing is you just have to clarify the patient कि अगर माइल्ड रिस्क है तो 1 या 1 से 2% तक का रिस्क हो सकता है, मॉडरेट रिस्क है तो आप जैसे अगर 100 मरीज आएंगे तो 5 से 8 में ये प्रॉब्लम आ सकता है और 92 में ये प्रॉब्लम नहीं आएगा, और अगर हाई रिस्क है तो इट इज़ लाइक मोर देन 10%, तो 90% में चांसेस बेहतर.
Thank you, Imran. I would like to have a comment from Professor Khaled, because we were discussing in the morning, and he wanted to.
Thank you. जब कहते हैं फिटनेस और अनफिटनेस, ये तो टर्म ऑपोजिट हो जानी चाहिए, कोई इनका मुकाम नहीं है. बिकॉज व्हेन यू एडमिट अ सर्जिकल पेशेंट, वी मेक अ टोटल कमिटमेंट, टोटल केयर, टोटल प्री ऑप, पोस्ट ऑप, इंटर ऑप, ICU केयर, पोस्ट एंड सेफ डिस्चार्ज टू होम विदाउट एनी कॉम्प्लिकेशन. ये टोटल हमारी केयर की कमिटमेंट पेशेंट के साथ हुई है. सिर्फ ये नहीं हुई कि फिट फॉर एनेस्थीसिया, अनफिट फॉर एनेस्थीसिया. तो एनेस्थीसिया मीन्स टोटल केयर. दूसरा ये कि जैसे कहा कि अनफिट कोई पेशेंट नहीं होता. वन पेशेंट में बी अनफिट फॉर, मे बी फिट फॉर एनेस्थीसिया बट मे नॉट टॉलरेट मेजर सर्जरी लाइक विपल्स और कमांडो सर्जरी. तो इसे टोटल केयर. तीसरी बात यह है कि आप AS देखें, अगर आप क्लास 5 तक, क्लास 5 इज मोरिबेंट पेशेंट, उसको भी उन्होंने अनफिट नहीं किया, उन्होंने ऑप्टिमाइज़ किया है पेशेंट को. तो ऑप्टिमाइजेशन वर्ड्स चेंज कर लें, आप कर सकते हैं कि मे टेक, मे नॉट टॉलरेट एनेस्थीसिया, मे मेक वर्स. और फाइनली जो इन्होंने बात की कम्युनिकेशन की, वो बहुत इंपॉर्टेंट है. सर्जन से कम्युनिकेट हमारे डॉक्टर नहीं करते, पैगाम भेज देते हैं लड़के के हाथ, वो जो मर्जी जाएगा कहते हैं उसको. तो मेरे कैरियर में कभी मुझे मसला नहीं है, क्योंकि मैं खुद कम्युनिकेट करता था हमेशा. Thank you.
One comment from Professor Saida, and finally, Professor Tipu Sultan will conclude the session.
Actually, I put this topic in the conference agenda because in our hospital something very disastrous had happened. A patient who had severe metabolic acidosis was sent in for, I don't remember the surgery, but I think it was orthopedics. And the anesthetist उस वक्त रात में जो भी था उसने कहा कि भाई ये तो नहीं हो सकता है, ये तो इसकी तो मेटाबॉलिक एसिडोसिस इतनी सीवियर ये वो, उसने कहा नहीं, सर्जन ने कहा कि नहीं, वो उसने नेफ्रोलॉजिस्ट ने तो कह दिया, जनरल फिजिशियन ने तो कह दिया, and we will go ahead, and that patient was, surgery was done because हमारे कंसल्टेंट ने भी कहा कि अच्छा अगर उन्होंने कह दिया तो करवा दो, and the patient died. And that was the reason why I got this put. I think it is not, ये सब तो बहुत theoretical बातें हैं कि हम इसको क्या कहें और क्या. I think we don't take the responsibility. I think it is the anesthetists who do not take the responsibility. I should not send my patient to Imran Iftikhar for him to give fitness of anesthesia. I do that. That's why he writes down fit for, he has done that. He writes fit for anesthesia.
With moderate risk.
गलती मेरे ख्याल से हमारी है. We have to stop doing this. We should only ask either for them to treat the problem, if it is diagnose a problem or treat the problem. But we should not ask them for, they don't know what sevoflurane does or what, what. And I think ये हमारा वो है. और दूसरी बात ये है कि एक suggestion था कि आई थिंक हम लोग अगर कम्युनिकेशन अपना बेहतर कर लें एज अ मल्टीडिसिप्लिनरी टीम, एंड उसके लिए बहुत आजकल रीसेंट वो है कि वर्चुअल हडल्स अगर शुरू कर दें तो दैट इज गोइंग टू सॉल्व अ लॉट ऑफ प्रॉब्लम्स.
थैंक यू मैडम. फाइनली प्रोफेसर टीपू सुल्तान, दिस इज लास्ट कमेंट. सर कंक्लूड ही कर दें आप इसको.
ये आपने बड़ा अच्छा किया कि कंक्लूड ही कर दें. फाइन. देखिए ये देयर इज नो मिथ एंड मिस्ट्री जो आप लोगों ने लिखा, मिथ एंड मिस्ट्री इन दिस वर्ड. The word fitness of anesthesia is the word only to be used by the anesthetist who is giving anesthesia. No other fankar has got this right to write a word that fitness, who the hell is, number one. Number two, the fitness declared by the anesthetist now or after optimization is his decision. The risk factor is his decision. A patient who is serious and whose different organs are malfunctioning, and if cardiopulmonary system is malfunctioning, and if there is an emergency, I will give anesthesia because I know what is wrong with that heart or with that lung or with the gas exchange. So it is the person who is expert on that who is anesthetist, and the risk factor, optimization, and all these decisions are the anesthetist. The other colleague, my respected colleague, other colleague, have got a right to say that this machine is working this way, this machine known as heart pump is working this way, or lungs, or liver, or kidney, or any other thing. But the final decision is the person who is conducting anesthesia. And if that disaster which Dr. Saida has mentioned, that in that case I will say, okay Baba, आप ही anesthesia दे दो, आप ही सब काम कर लो, I am standing here. क्योंकि भाई आप दे दो. Thank you.
Sir, एक चीज़ इसमें ये कि we are, you being the patron of PSS Center, Professor Shahida is here and Professor Saida Haider, Khalid साहब.
तीन पैटर्न खड़े हैं इधर. अच्छा.
जी जी.
और आप
and sir, can we change this through the forum of PSA? Can we change this term, fit for anesthesia, को risk stratification for anesthesia?
फिट फॉर एनेस्थीसिया का जो लफ्ज़ है ये सिर्फ एनेस्थेटिस्ट इस्तेमाल कर सकता है बस, बाकी तो ये राइट ही नहीं है किसी का. और जो एनेस्थीसिया देगा वो अगर समझता है कि फिट है तो भाई रिस्पॉन्सिबिलिटी उसकी है. अगर कुछ मेडिको लीगल मसला होता है, बिकॉज ही इज़ द पर्सन हु अंडरस्टैंड्स the physiology and the applied physiology, the pharmacology, the applied pharmacology, the pathophysiology and other things also. सर्जन या जो भी हैं ये तो बेचारे या तो प्लम्बर हैं या
सर लास्ट वो बस वो बेल पे बेल बजा रहे हैं।
सॉरी बस थैंक यू। मैं सिर्फ ये कह रहा हूँ सर, आपने जो सवाल किया ना, रिस्क स्ट्रेटिफिकेशन कैन रिप्लेस फिट फॉर एनेस्थीसिया, इन माय हम्बल ओपिनियन इट इज़ नॉट द सेम, because risk stratification we do after carefully assessing and evaluating the patient, and maybe we may ask for certain optimization and everything, but fit for anesthesia is a terminology but we should discourage because there is nothing like fitness for anesthesia as you have said.
सर करेंगे क्या टर्म लेके
मैं बता देता हूँ आप क्या करेंगे। आपने
मैं बताता हूँ क्या
अब सुबह इन्होंने 10 मिनट दिए थे, हमें भी 3 मिनट 4 मिनट और दे दें।
अगर कोई सीरियस केस है, it is the honest ethical duty of the anesthetist to explain to the patient that this is the amount of risk factor. I am giving anesthesia because there is no choice, he is dying in all case, so I will give anesthesia, and I have done it dozens of times.
एक कमेंट में कर दूं।
अच्छा मैं 1 मिनट, मैंने तो भाई कफन भी मंगा के रख लिया सामने उनको दिखाने के लिए कि रखो सामने एनेस्थीसिया दे रहा हूँ, और वो पेशेंट चल के अस्पताल से गया, लेकिन रिस्क इतना ख़तरनाक था कि उनको समझ ही नहीं आया। रिस्क मन का अच्छा कफन ले और फिर मैं एनेस्थीसिया दे रहा हूँ, और दे दिया मैंने, ठीक हो गया वो। तो एक्सप्लेन कर दे ईमानदारी से कि ये मसला है।
एक पेशेंट मेरे पास, एक छोटा सा कमेंट कर दूं, एक पेशेंट मेरे पास आए अपने वालिद को लेके, 96 उनकी एज, 4 को मॉर्बिड्स उनको, और मुस्तकिल एक ही बात बार बार पूछे जा रहे हैं, मैडम कुछ होगा तो नहीं, मैडम कुछ होगा तो नहीं। अब मैं
आपने क्या बताया 96 साल कुछ नहीं होता, अब क्या होना है?
तो इस तरह का माइंडसेट भी होता है, तो उनको भी समझाना ही पड़ता है किसी तरह।
हेलो, I think we have already taken 10 minutes more. I would like to extend my thanks to all the panelists.
I just want to add one thing.
जी।
I just want to add one thing. कि ये सारी हम बातें कर रहे हैं कि पेशेंट को ये हो जाएगा, why can't we take an informed consent with the patient, from the patient कि ये कुछ हो सकता है, write it down, get it signed by the family, the patient. तो you can go for the surgery कि ये कुछ हो सकता है, जिसमें आप परसेंटेजेस बता दें कि जी ये कार्डियक हो सकती है प्रॉब्लम, ये उसको पल्मोनरी हो सकती है, he can go to the ICU. So why not we risk stratification तो की किन basis के ऊपर? So that's my take.
Thank you. I think we should conclude now.
Thank you so much, Dr. Jodhat. I would like to invite Dr. Jodhat on the screen for the distribution of certificates. Dr. Zahid Salood. Dr. Dilip Kumar. नहीं बस मैं कर लूँगी। डॉक्टर सफिया जफर। डॉक्टर सफिया जफर। डॉक्टर सदफ मलिक। ये लो। डॉक्टर सदफ मलिक। डॉक्टर सलीमा बेगम। Dr. Imran Iftikhar. I would like to invite Dr. Dillu Raja on the stage to give certificate to Dr. Jodhat Salim.
moving on to the next session, which is the parliamentary debate. I would like to call Dr. Amber Gulamani to come and facilitate this, please.
Assalamu alaikum everybody. Good afternoon. My name is Dr. Amber Gulamani. I'm Senior Instructor, Department of Anaesthesiology, AKUH. It is my pleasure to welcome you all for this session. This is the parliamentary debate on burnout and depression among the anesthesia trainees, a myth or reality. So burnout is increasingly recognized as an important concern in medical training, especially in demanding specialties like anesthesia. I would like to invite the moderator for this session, Dr. Asma Abdul Salam. She is the former General Secretary of PSA Karachi. She is the Associate Professor at Jauddin University Hospital and Program Director for the Residency Program. Dr. Asma, please.
So in the meanwhile, I start this, session. Can I have my audience attention, please? How many residents are here? जो residents यहाँ बैठे हुए हैं? Okay, good. So we have quite a few here. Because ये वाला session जो है वो आप लोगों के लिए ही है basically. नहीं, बाकी लोगों के लिए भी है, obviously. So burnout in anesthesia residency is a very important topic. और last year इसका थोड़ा सा background मैं आप लोगों को बताऊं कि last year जो हमारी conference थी उसमें faculty research में एक faculty ने burnout के ऊपर paper present किया था और that was the last paper to be presented for that day. और उसके बाद जो debate शुरू हुई थी, there was actually two group of opinions. One, we had a very respectable senior Dr. Fawzia Anis Khan, who is not present here, और जो दूसरे थे वो डॉक्टर हमारे प्रोफेसर टीपू साहब थे. तो जो डिबेट थी वो थी बर्नआउट इन एनेस्थीसिया. ये टॉपिक सर की बहुत करीब है, तो सर अभी आके अपने ख्यालात का इजहार करेंगे. बट ऑब्वियसली बिकॉज इट इज़ अ वेरी इंपॉर्टेंट टॉपिक दीज डेज एंड वी हैव मेड पार्लियामेंट्री स्टाइल डिबेट session on this. For that, in the proposition team, I would request Dr. Arshad Taqi, Dr. Tahir Akbar, and Dr. Rabia Iqtidar, along with Dr. Zahid Rao, to please come on stage. Sir. Thank you. And from the opposition team, it has been led by Professor Tipu Saab, along with Dr. Shehryar Ashraf, Professor Leena Aziz, and Professor Muhammad Ashraf. Can I please have you on stage? So for those who don't know, burnout is the syndrome of emotional exhaustion, depersonalization, and reduced personal accomplishment, which is experienced in response to the chronic job stresses. And I think most of us may or may not, at some point in time during our residency program, and maybe later, must have gone through some of these symptoms. So my question is, पहले तो आप लोग में से बताएं कि बर्न आउट के बारे में आपका क्या ख्याल है कि आप लोगों में से कितने लोग हैं जो ये फील करते हैं कि एनेस्थीसिया की ट्रेनिंग में और बाद में बर्न आउट आप लोगों ने फील किया है. हाउ मेनी ऑफ यू कैन यू प्लीज़ रेज योर हैंड? सर लेट्स सी व्हाट ऑडियंस सेज. ओके, सो मेरा पहला क्वेश्चन मेरी बोथ टीम से है. पहले मैं टीपू साहब की टीम से पूछूंगी और फिर उसके बाद डॉक्टर अरशद तकी माइट आंसर दिस क्वेश्चन. हाउ मेनी ऑफ यू बिलीव, तो आप लोगों ने बता दिया ये था कि आर वी समटाइम्स लेबलिंग नॉर्मल प्रोफेशनल स्ट्रेस एज बर्न आउट? इज इट द सेम सर और इज इट डिफरेंट?
सवाल ज़रा दोहराइए.
सर, क्या नॉर्मल प्रोफेशनल स्ट्रेस जो है वो और बर्नआउट दोनों सेम है या अलग अलग है आपके?
नहीं, ज़मीन आसमान का फ़र्क है, क्योंकि आप एनेस्थेटिक्स को जलने वाली चीज़ है. Why the hell you should burn yourself? You are the captain, you are the captain of the ship, you are the leader, you are managing a patient, you are saving a life, you understand all the system of the patient. So how you can declare that I am burnout? You are there to fight it out. And you never are exhausted. And anesthetist has got 20 hands. Anesthetist has got all the energy of the world. So the word ये burnout हो गए, यह बहुत ही बेहुदा लफ्ज़ है और ऐसा नहीं होना चाहिए. Anesthetist मजबूत इंसान होता है. Thank you.
So, sir, with this, I would request Dr. Arshad Taqi to actually answer this question.
अब ये तकी बोलेंगे कि मैं कमज़ोर हूँ, ये कभी नहीं बोलेंगे कि मैं कमज़ोर हूँ.
Dr. Arshad Taqi, Dr. Fawzia Anis Khan and Dr. Liaquat Ali previously in 2019 has published a paper in Anesthesia and Analgesia on residents burnout. So that was actually the first paper from Pakistan to be published anywhere. I would request Dr. Arshad to please have a comment on that.
So I thank you क्योंकि वो आपने जब रात बता रहे थे तो आपने वो उस लास्ट डिबेट का आपने रेफरेंस दिया जिसमें एक साइड पे टीपू साहब थे, दूसरी साइड पे प्रोफेसर फौजिया थी. आज मुझे वो आपने बिठा दिया क्योंकि डॉक्टर फौजिया के साथ मैं को-ऑथर था इस पेपर में. तो आपकी बातें से तमाम बातों से मैं एग्री करता हूँ, बिल्कुल सामने स्टार्ट वहीं से कर रहा हूँ. एक एनेस्थेटिस्ट के 20 हाथ होते हैं, उसको 1500 आँखें होती हैं. मैंने बल्कि इंटरेस्टिंगली आजकल मैं एक किताब पढ़ रहा हूँ, वो बड़ा इंटरेस्टिंग है, वो अगर चाहे तो मैं आपको ला के दिखा दूँगा. उसमें है कि बहुत सारे जानवर जो हैं दुनिया को कैसे देखते हैं. तो उसमें मुझे पता चला कि बहुत सारे जानवर जो हैं उनकी आंखें उनके पेट पे होती हैं, किसी की कहीं होती हैं, किसी के सारा जिस्म आंखें होते हैं, किसी के सारा जिस्म कान होते हैं. सो दैट्स वेरी इंटरेस्टिंग. सो एनेस्थेटिस्ट इज़ वन ऑफ दोज एनिमल्स हु हैज़ आइज ऑल ओवर, हैंड्स ऑल ओवर. और उसको कभी नहीं बर्न आउट होना चाहिए, उसको कभी भी नहीं ये सब कुछ होना चाहिए. वो तो स्ट्रांग होता है. सर होना चाहिए और होता है में बहुत फ़र्क होता है. अनफॉर्चुनेटली सारे लोग आप जैसे नहीं होते, इतने रेजिलिएंट नहीं होते. बाकी लोग हमारे जैसे मॉडल बीइंग भी होते हैं जो बर्न आउट हो जाते हैं. सो सवाल ये नहीं है कि बर्न आउट होना चाहिए कि नहीं होना चाहिए. सवाल ये है कि क्या बर्न आउट होता है.
सर तो कमिंग बैक, प्रोफेशनल स्ट्रेस बर्न आउट है या नहीं है?
देखिए, प्रोफेशनल स्ट्रेस और बर्न आउट दो डिफरेंट चीज़ें हैं. स्ट्रेस तो आपकी लाइफ का पार्ट है और स्ट्रेस इज़ व्हाट एक्चुअली ड्राइव्स यू. द क्वेश्चन इज एट do you have the capacity to cope with that stress? When that level of stress exceeds your capacity to cope with it, that's when the likelihood of burnout occurs. So it's not that it's not the stress, it is stress relative to your capacity to cope. If it is beyond your capacity to cope, then it is burnout. And at some point, people say, I am burned out. They might not say it, बट वो बर्नआउट हो रहे होते हैं. बहुत सारे तरीके हैं, टूल्स हैं जिनसे आप उसको कर सकते हैं, ऑब्जेक्टिवली मेजर कर सकते हैं.
Sir, so do you believe burnout is inevitable in anesthesia training or is it largely preventable then?
So if it is not inevitable, of course. If it was inevitable, then it would happen to everyone. The fact that it happens to some and does not happen to others means that it is there. Largely preventable, yes. However, अब प्रॉब्लम क्या हो रही है कि हम एक जब बर्नआउट के मेजर्स ले रहे होते हैं. और मैं कमिंग बैक और आपसे मैं बात कर रहा था, जब हम पाकिस्तान मेडिकल कमीशन में थे तो YDA हमारे पास आई बहुत बड़ा एक शोर लेके कि जी रेजिडेंसी के वर्क आवर्स के ऊपर आप एक कैप लगाएं. एंड दे हैड दैट ऑल दैट. उन्होंने बड़ी 2-3 वो स्पीकर बड़े अच्छे होते हैं. सो उन्होंने पूरी इसी किस्म की तकरीरें की. वो सारी रात काम करता है, सुबह वो थका होता है, उसको कहा जाता है वो मरीज़ के ऊपर ये गलती कर देता है, सब करता है. एंड आई सेड फाइन, आई एम ऑल आउट विथ यू, मैं आपके साथ हूँ और हम मिल के और वील जस्ट फोर्स द प्रोविंशियल गवर्नमेंट्स. आप मुझे सिर्फ एक बात की मुझे गारंटी दीजिए कि अगर हम कह दें कि एक 12 आवर शिफ्ट के बाद किसी डॉक्टर को अगली शिफ्ट पे नहीं लगाया जाएगा, उसको ऑफ दिया जाएगा, कैन यू एक्चुअली गारंटी कि वो जाके मून लाइटिंग नहीं करेगा, वो बच्ची जाके घर में खामद को नाश्ता बना के और बच्चे पालेगी और अगला सारा दिन घर का काम नहीं करेगी. इफ़ यू गारंटी दैट, सो आई मीन यस प्रिवेंटेबल. हाउएवर उसको हम समझते हैं कि सिर्फ वर्क प्लेस जो है that has got the sole responsibility to making it preventable, no people can still get a burnout because of circumstances which are beyond the workplace.
So from your team as well, Dr. Tahir and Dr. Zahid, I would request your opinion on that as well. Is it preventable or is it
I think yes, it is preventable. Why not? So there are certain rules. एक तो rule है हर एक के लिए होगा department में कि nobody should be stressed out physically or mentally, whatever. Then you have to tailor according to individual needs. जैसे for example हम ACLS में जाते हैं तो during compression they clearly advise कि अगर किसी की limitations हैं, बैक पेन है, प्रेगनेंसी है, तो दे शुड टेल अस, तो उसमें हम रोल मॉडिफिकेशन कर देंगे. तो लाइक दैट थिंग्स आर प्रिवेंटेबल, वी जस्ट हैव टू टेलर इंडिविजुअल.
सो डॉक्टर लीना का एक कमेंट है इसके ऊपर, अभी उन्होंने किया.
मैंने कहा आप तो हमारी साइड के हो गए फिर कि ये कंट्रोलेबल है और इंडिविजुअल वेरिएशन है. मेरा ख्याल है बर्नआउट एनेस्थीसिया में यूज़ नहीं करनी चाहिए टर्म, क्योंकि आप बाय चॉइस मेजॉरिटी यू ऑप्ट फॉर एनेस्थीसिया, और एनेस्थीसिया का वही बंदा होता है जो इन्जॉय कर रहा होता है अपना. अगर इन्जॉय नहीं करेगा वो अपनी सर्विसेज पूरी नहीं करेगा. सो आई थिंक ये मल्टी फैक्टोरियल है और मल्टी आई थिंक स्पेशलिटी से कंसर्न है. आई डोंट थिंक सो कि एनेस्थीसिया में बर्नआउट वाला ज़्यादा देर चल भी सकता है. यस, स्ट्रेस इट कुड बी, मगर ये नहीं.
जी, इसको मैं रिस्पॉन्ड, अगर आप इजाज़त दें तो मैं रिस्पॉन्ड कर दूं. बिल्कुल बात आपकी ठीक है कि एनेस्थीसिया में बर्नआउट नहीं होना चाहिए. वंस अगेन आप वही कह रहे हैं. हाउएवर मेरा सवाल ये है कि अगर ये बात आपकी ठीक होती और ये है कि ह्यूमन है बर्नआउट ह्यूमंस, इफ़ यू टेक अ कोहॉर्ट ऑफ समथिंग लाइक से 1000 पीपल एंड यू पुट देम इनटू अ प्रोग्राम, तो जो वो सर्विस शो कर रहे हैं बर्नआउट का, मॉडरेट टू सीवियर बर्नआउट का, कि उसके हिसाब से
सर तो यहीं पे हमारी ऑडियंस बैठी, इनसे पूछ लेते हैं आप लोगों में से कितने लोग हैं जो कि बाय चॉइस एनेस्थीसिया में आए. प्लीज रेज योर हैंड्स.
वाह वाह वाह, जिंदाबाद जिंदाबाद. एंड नोबडी इज गोइंग टू बी बर्न आउट.
अच्छा, मेरा सवाल सिर्फ ये होगा कि बाय चॉइस आप एनेस्थीसिया में आए, बाय द रॉ ऑफ स्टैटिस्टिक्स, एंड यू आर नाउ स्टडीइंग स्टैटिस्टिक्स, कभी भी नहीं हो सकता कि एक कोहॉर्ट जो एक स्टार्ट हो 100%, ठीक है, वो वहाँ तक पहुँचे. कुछ लोग हैं जो कि जिनको बाय द लॉ ऑफ नेचर कुछ लोगों को उसमें से एक्सेप्शन होना चाहिए, जो आउटलायर्स होने चाहिए. मेरा सवाल ये है कि प्रोग्राम में से ड्रॉप आउट रेट कितना है? आपके पाकिस्तान के प्रोग्राम में से ड्रॉप आउट रेट बहुत कम है. इसका मतलब है कि देर आर पीपल आउट देयर हु एक्चुअली are burning out, and burnout is not a permanent condition. You may go through a phase of burnout and then come out of it due to various factors. But मेरा सवाल ये है कि अगर उसमें से कोई भी छोड़ नहीं रहा तो इसका मतलब है they are facing burnout and still going on. और उसका एक और चीज़ सवाल है, कितने आपके क्रिटिकल इंसिडेंट हैं जिनकी कि आपने रूट कॉज एनालिसिस करके देखा कि इसके पीछे बर्नआउट था? आपने किया ही नहीं है. सो यू आर एज्यूमिंग कि इनमें से किसी को बर्नआउट नहीं था, सब मोटिवेटेड थे, सब टिका के काम कर रहे थे क्योंकि हमें पहलवान होना चाहिए.
सर आपका क्या ख्याल है इस बारे में?
देखिए, देयर इज अ गुड ओल्ड सेइंग दैट यू व्हाटसएवर यू डू यू मस्ट एंजॉय इट. अगर आप जो भी काम करें, सर्जन बन जाए गलती से तो एंजॉय करें उसको. एनेस्थेटिस्ट हैं तो यू मस्ट एंजॉय करें. तो इफ़ यू आर नॉट एंजॉइंग योर वर्क you must not do it. बाकी जहाँ तो बर्न का ताल्लुक है, जो जल गया वो मर गया.
Dr. Zahid, and then I'll take Dr. Ashraf's comment on that.
अच्छा, इसमें जो एनेस्थीसिया की बात हो रही है ना, बर्नआउट तो देखें, स्ट्रेस तो हर मेडिकल फील्ड में है ही, लेकिन एनेस्थीसिया के अंदर स्ट्रेस बहुत ज़्यादा है क्योंकि पेशेंट की लाइफ जो है ना वो हमारे सेकंड्स के ऊपर है. मेडिसिन वाले तो 10 दिन के बाद 15 दिन के बाद पता चलेगा कि क्या हुआ उसको, लेकिन हमारे तो सेकंड्स लगते हैं. तो उसमें स्ट्रेस तो है, और स्ट्रेस जब आपका इतना स्ट्रेस इंक्रीज़ हो जाए तो वो फिर बर्नआउट में ज़्यादा चेंज होता है. अब कितने लोग हैं हमारे के जो उस स्ट्रेस को बेयर कर सकते हैं, उसको कोप अप कर सकते हैं? मेजॉरिटी कर सकते हैं ट्रेनिंग वाइज. जैसे हमारी ट्रेनिंग ही ऐसी होती है कि ऐसा ऐसा करके इनिशियली हो सकता है बहुत सारे बच्चे ऐसे हैं कोई स्ट्रेस में आ जाते हैं और उनको प्रॉब्लम होती हो, लेकिन बाय द टाइम जब वो 4 साल की ट्रेनिंग करते हैं तो वो इस काबिल होते हैं कि उसको बेयर कर लेते हैं, और बर्नआउट इतना ज़्यादा नहीं है जितना कि वो होना चाहिए, लेकिन डेफिनेटली बर्न
सर, तो आपके
है।
ख्याल से व्हाट इज द बिगेस्ट कंट्रीब्यूटर इन द बर्नआउट इन एनेस्थीसिया? इज इट वर्कलोड, इज इट हायरार्की सिस्टम, एग्जामिनेशंस, और द लैक ऑफ सपोर्ट फ्रॉम द टीम?
नहीं, एक तो वर्कलोड है, वर्कलोड डेफिनेटली। अगर आप सुबह से लेकर शाम तक कंटिन्यूसली काम करेंगे तो स्ट्रेस तो बढ़ता ही जाएगा।
तो एनेस्थीसिया में तो यू कैन नॉट लीव द पेशेंट अलोन।
हाँ, लेकिन उसको रेस्ट देना चाहिए ना। इसमें से अगर आप 4 ऑपरेशन सुबह से लेके एक ही उससे एनेस्थीसिया से करवाएंगे तो फिर तो स्ट्रेस बढ़ेगा। लेकिन कोई भी ह्यूमन बीइंग जो है ना, इतना वो पॉसिबल
डॉक्टर
नहीं।
अशरफ, डू यू वांट टू कमेंट?
मैं एक्चुअली ये जी प्रीवियस
ये है मैम डेफिनेशन: syndrome of emotional exhaustion, depersonalization and reduced personal accomplishment, which is experienced in response to chronic job stress.
Chronic job stress is not
पहले डॉक्टर अशरफ।
अच्छा जी जी, एक्चुअली ये प्रीवियस जो डॉक्टर जाहिद से पहले मैं इस बात पे कमेंट करना चाह रहा था कि मेडिकल प्रोफेशन के अंदर एक चीज़ हमें ज़रूर समझ लेनी चाहिए, और एक दिन में तो हम डॉक्टर नहीं बन जाते। एक ये है कि इट इज़ नॉट अ जॉब, इट इज़ अ सर्विस। सर्विस के अंदर आपकी प्रायोरिटी ठीक है। मैं दुनिया में रहते हुए इसी दुनिया के अंदर प्रैक्टिकल बात करूँगा। सर्विस में आपकी अहमियत कम, और जिसको आप सर्विस प्रोवाइड कर रहे हैं उसकी अहमियत ज़्यादा होती है। आपकी ज़िंदगी का कोई ऑब्जेक्टिव होना चाहिए। जब आप ऑब्जेक्टिव लेस ज़िंदगी गुजार रहे हैं तो फिर आप जिसको कहते हैं मैं बोर हो रहा हूँ, मैं डिप्रेस हो रहा हूँ, ऑब्जेक्टिविटी ऑफ लाइफ इज़ मोर इम्पॉर्टेंट। किसी भी ट्रेनिंग प्रोग्राम में नॉट ओनली इन एनेस्थीसिया, अगर आपकी ऑब्जेक्टिविटी नहीं है, आप उस चीज़ को समझ नहीं रहे, तो फिर उनको बहुत पहले सोच लेना चाहिए। एनेस्थीसिया में आने की भी ज़रूरत नहीं है, किसी और में। तो एक शेर मैं सिर्फ पढ़ता हूँ ताकि लाइटर भी रहे। ये कदम कदम बलाएं, ये सवाद कुएं जाना, वो यहीं से लौट जाएं जिन्हें ज़िंदगी हो प्यारी।
डॉक्टर रबिया,
can I add something to this?
जी मैम, I'll take your comment after Dr. Rabia.
Actually, when we are talking about the depression or the burnout, there is the main thing about behind it is the chronic stress, which can be a perceived or it is an actual threat to the internal physiological and the psychological state of a human body. And when there is chronic stress and it is not going to overcome in the early phase, then ultimately it will lead to the development of some negative energy inside the human body, and that will lead to the depression or the burnout. And when you are talking about particularly the anesthesiologists and the young anesthesiologists, that include the newly appointed trainees and the newly appointed physicians. So there are the number of external and internal stimuli, and if they are not going to overcome in the early phase, ultimately lead to a depression or the burnout. The biggest threat to the anesthesiologist is the mental stress rather than the physical stress, because we are working in the closed loop environment. So we need to initiate some preventive and some preventive strategies, and we need to encourage them. And obviously, as Dr. Zaidra mentioned, that the biggest issue is with the chronic stress, and not everyone is capable to face the same level of stress. Individual have the different level of energies, so we don't have the same level of energies to cope up all these social or psychological or the family factors. There are a lot of studies that have been published. One Chinese study that I went through, that there are the major impact of this chronic stress on the cardiac system, the immune system, and the third one is the early onset of the neurodegenerative diseases. So one should have developed the way to get rid of this chronic stress through the physical measures or through any other way. That gives you the internal happiness.
Dr. Leena?
जी, मैं सब के ये ऑब्जेक्टिवनेस के ऊपर ही थोड़ा और इसको बढ़ाऊंगी बात को। एनेस्थीसिया एक ऐसी फील्ड है जिसमें बाकी सब स्पेशलिटीज़ में पेन को आप ले लीजिए, जब पेशेंट को आप उस वक्त ब्लॉक लगाते हैं, पेन फ्री होता है, कितनी मतलब है, यू गेट योर रिवॉर्ड देयर ऑन द टेबल विच इज़ वेरी रिवॉर्डिंग। अंडर किया, आउट किया, जो जो चीज़ें हम कर रहे होते हैं वो वहीं पे रिवॉर्डिंग होती है एंड इट्स वेरी हार्टनिंग। रह गई बात, डॉक्टर साहब ने जैसे भी लॉन्ग स्ट्रेस की बात की है, तो आई थिंक कि जो डॉक्टर इतना लंबा स्ट्रेस नहीं ले सकता वो एनेस्थीसिया का जॉब परफॉर्म प्रॉपरली नहीं कर सकता। तो उसमें उनकी काउंसलिंग मेरा ख्याल है शुरू में ही कर देनी चाहिए। अभी एक डॉक्टर की फैमिली लाइफ भी है, दूसरा भी है, तो उसको थोड़ा बहुत कोप अप कर लेना चाहिए, नहीं तो फील्ड चेंज कर देनी चाहिए।
डॉक्टर अर्शद वांट टू कमेंट?
जी, सिंस दिस इज अ पार्लियामेंट्री डिबेट, तो आई टेक द लिबर्टी टू बिहेव लाइक अ पार्लियामेंटेरियन। सो बस मसला ये है कि मेरे मोहतरम जो हैं मेरी राइट साइड पे सब बैठे, इंक्लूडिंग मेरे उस्ताद, के वो मसला ये है कि आप सबके सब, मैं आपकी तमाम बातों से एग्री कर रहा हूँ। प्रॉब्लम ये है कि आप लोग कर रहे क्या रहे हैं कि आप मेरे वतन के सजीले जवानों तराने गा गा के आपकी कोशिश है कि हम लोगों को जहाद में भेजी रखें। प्रॉब्लम असल जो टॉपिक है, जो असल इशू है, उसकी तरफ आप लोग नहीं आ रहे, और वो ये है इसलिए कि आप आ ही नहीं सकते कि द फैक्ट इज़ दैट इन स्पाइट ऑफ ऑल दोज तरानास, there are some people out there in the profession who are facing burnout. We need to identify them. Identify them. Why? Because of their presence, the systems become unsafe. जब हम systems approach की तरफ जाते हैं, तो you have to identify people who are those weak links who may be, और वजह क्या हो रही है कि because of this taranas, बिकॉज ऑफ दीज तरानास हमने कोई अभी तक मैकेनिज्म नहीं दिया कि टू ऑब्जेक्टिवली आइडेंटिफाई पीपल हु आर फेसिंग दैट बर्न आउट एंड देन हैंडल देम। लास्ट थिंग आपने कहा था ना फाइनेंशियल का, टू मी एक तो मैं बता दूं कि काफ़ी जब से एवर सिंस दैट स्टडी आई हैव बीन ट्राइंग टू हैव अ फॉलो अप स्टडी, और अब हम कर रहे थे क्योंकि आई वाज टॉकिंग टू आवर साइकेट्रिस्ट, और मैंने कहा कि जी ये हम अब तक जितनी भी स्टडीज़ हैं दे आर सर्वेज बेस्ड ऑन वन सिंगल क्वेश्चनियर जिसकी ऑलरेडी वैलिडिटी, हमारी जो 2019 की स्टडी थी उसमें आप देखें सैम्पल साइज में 31% फीमेल्स, वो रेशो चेंज हो चुकी है। सो दैट ऑलरेडी इज़ नो लॉन्गर एज वैलिड एज इट वॉज देन। सेकेंड, अभी तक जितनी भी स्टडीज़ हुई हैं बेस्ड ऑन वन सिंगल टूल, अब हमने कहा यार ऐसे बैठ करते हैं कि लेट्स डू अ क्वालिटेटिव स्टडी एंड सी के एक्चुअली क्या कोई ऐसी थीम्स हैं जो उस टूल में नहीं एड्रेस हुई और हमें करनी चाहिए, और वो हमने IRB को सबमिट किया उसके लिए कि एक क्वालिटेटिव स्टडी इन डेप्थ इंटरव्यूज़ करें। डीप जो सबसे बड़ी मुझे लग रहा है फैक्टर है एनेस्थीसिया के स्पेशली में, दैट इज़ डिसएम्पावरमेंट। आपको जो एक बेबसी का एहसास एक रेजिडेंट को हो रहा होता है ना, कि उसके मुकाबले में वो सर्जिकल रेजिडेंट भी आके चौड़ा हो रहा होता है, दैट इज ऑल्सो कंट्रीब्यूटिंग।
नहीं तो क्या एक, अगर आप ये बात कर रहे हैं तो हमें एक एप्टीट्यूड टेस्ट नहीं कर लेना चाहिए पहले इन गिविंग इन डिफरेंट स्पेशलिटीज, एंड इफ यू आर वेरी अकम्प्लिश्ड एनेस्थेटिस्ट तो क्यों भाई हम सर्जन की क्यों बात सुने।
So Dr. Leena, coming back to this point of yours, is emphasizing resilience becoming a convenient excuse for the institutions to avoid these toxic systems?
नहीं, दैट इज़ नॉट ओनली इन एनेस्थीसिया। देखें एनेस्थीसिया कुछ अब फील्ड्स हैं, जिस तरह इन्होंने फौज की बात कर दी, तो अब जो पीछे बैठा हुआ है वो फ्रंट लाइन पे तो नहीं लड़ेगा, फ्रंट लाइन वाले की कुछ और रिसिलियंस है, और जिसने पीछे से तोपखाना बनाना है या किसी ने कुछ और करना है उसकी रिसिलियंस कुछ और होगी। अब पूरी फौज तो नहीं ख़राब हो गई ना, तो उसमें ये है कि आप अकॉर्डिंगली, और कुछ फील्ड ऐसी हैं जिसमें तो जो बेचारे का इतना ज़्यादा है भाई हमने जस्टिफाई करना है, तो उसको मत रहने देना उसमें।
डॉक्टर साहब
जी, पहली बात ये कि हमारे कोलीग्स तो डिनाई कर रहे हैं कि देयर इज़ नो बर्नआउट, लेकिन बट एनीथिंग विच यू कैन क्वान्टिफाई, यू कैन मेजर, यू कैन कंपेयर, सो दैट इज़ I mean physically available. There are a lot of multiple parameters. So you can quantify, you can measure burnout, and there are multiple studies international from all around the world, and Pakistan में भी luckily है, otherwise सब we rely on international data. तो जब ये exist करती है तो we should accept there is burnout. Then again ये work related, for example Dr. Jodat, he just went out. मैंने उससे पूछा कि can we start this another service like acute pain in public sector? He said I have 43 operation tables and I have only 42 residents. So this is work related burnout and this is continuous, you cannot deny. Again आपके पिछले question में एक बात थी कि all these factors are part of burnout, but I think we are lacking in support. एक रेजिडेंट से फॉर एग्जांपल एक कॉम्प्लिकेटेड केस किया, अनफॉर्चुनेटली पेशेंट की डेथ हो गई, देन अनदर 2 days दैट पुअर यंग guy or girl, they cannot normalize themselves, but we don't have a support system. पहली बात, सब लोग बैठे हैं, nobody in the department has quantified, किसी ने मेजर नहीं किया कि बर्नआउट लेवल क्या है रेजिडेंट्स में. फिर उनको साइकोलॉजिकल सपोर्ट, क्या कभी किसी ने साइकेट्रिस्ट को बुलाया एक लेक्चर देने के लिए? I think once or twice a year they should be, consulted by psychiatrists.
देखें, मेरा ख्याल है कि आपके जो दलील थी ना, उसके अंदर एक जवाब भी मौजूद था, और जवाब ये था कि कोई एवेल्यूएट नहीं करता. इसका मतलब है प्रॉब्लम तो उसकी बर्नआउट के साथ नहीं है, प्रॉब्लम तो सिस्टम के अंदर है ना, कि डिपार्टमेंट में इफ़ आई एम लीडिंग द डिपार्टमेंट, तो मुझे अपना स्ट्रक्चर ही ठीक करना नहीं आ रहा कि मैं वर्क फोर्स को किस तरह यूटिलाइज़ करूँगा. और हॉस्पिटल की एडमिनिस्ट्रेशन के साथ बैठ के बात करना मेरी रिस्पॉन्सिबिलिटी है, टू टेल देम हाउ टू रन दीज थिएटर्स. और उससे भी ज़्यादा इंपॉर्टेंट है कि आई हैव टू असेस माई सेल्फ व्हेन आई एम अ लीडर, कि मैंने किस तरह इस वर्क फोर्स को यूज़ करना है, उसकी कैपेसिटी से काम लेना है या नहीं लेना. अगर हम ये रोल अदा नहीं करेंगे, रोज़ मैं एक देखता हूँ रेजिडेंट के वो टाइम पे आता है, लेकिन फॉर द फ्यू डेज आई एम नोटिसिंग कि वो टाइम पे नहीं आ रहा या नहीं आ रही, तो मैं उसको कभी भी इग्नोर नहीं करूँगा. आई जस्ट वॉन्ट टू टेल कि सीनियर फैकल्टी इस मुख्तलिफ़ चीज़ों के ऊपर फोकस करे, सिर्फ काम के ऊपर या एनेस्थीसिया के ऊपर नहीं करे. मैं उसको बहुत आराम से कहीं अलग से पूछूंगा 2-4 दिन के बाद कि आपके साथ कोई पर्सनल प्रॉब्लम है, मैं आपके साथ कोई चीज़ डिस्कस करना चाहता हूँ, आई वॉन्ट टू डिस्कस विद. और मैंने 90% देखा है दोज पीपल हैव देयर पर्सनल प्रॉब्लम एंड स्पेशली विद द फैमिली. और उनको इतनी इनकरेजमेंट करें कि हो सकता है उसकी वालदा बीमार हो सकता है उसके घर के अंदर कोई ऐसे इश्यूज़ हों, उन इश्यूज़ को आप अगर इन अपनी प्रोफेशनल के साथ ऐड करेंगे तो उसको देखेंगे. हम जो बाहर की किताबें पढ़ते हैं, जिनके कोर्सेज अटेंड करते हैं, उनको अगर कहें ना कि मेरा रेजिडेंट इसलिए देर से आता है कि उसका घर बहुत दूर है, वो कहता है नन इज़ योर बिजनेस. मेरा बिजनेस है, अगर मेरा बिजनेस ना हो तो मुझे सोशल फैक्टर्स को भी देखने की ज़रूरत है. तो लिहाजा अगर हम किसी बर्नआउट किसी को देख भी रहे हैं तो डज नॉट वी लेबल इट एज अ बर्नआउट.
सर, तो आप ये एक्सेप्ट करें कि बर्नआउट होता है?
अच्छा,
सर ने एक्सेप्ट किया कि बर्नआउट होता है?
नहीं, आप ये देख रहे हैं कि वो काम ठीक से नहीं कर रहा, कोई मसला है, तो उसको आप देखें तो सही ना, उसकी रीज़न उसका काम तो नहीं है. ह्यूमन बीइंग.
सर, नाउ कमिंग बैक,
देखें, चले
ओवरवर्क है, बर्नआउट नहीं है.
सॉरी, एक सेकंड सर,
एक मिनट जरा बात.
मान लिया कि बर्नआउट होता है, आप कुर्सी लेके इधर आ जाए.
अच्छा, ये एक जो आप लोग जो टॉपिक बदल रहे हैं, ये साजिश हो रही है इस वक्त. देयर इज अ बिग चेंज बिग डिफरेंस बिटवीन स्ट्रेस एंड द बर्नआउट. आपका स्ट्रेस का क्वांटिटी अगर बढ़ रही है, घट रही है, तो दैट इज़ अ टोटली डिफरेंट थिंग. बाकी उसको आप इधर क्यों मिक्स कर रहे हैं? बाकी जो इस किस्म की चीज़ें मैंने देखी है कि अब जो एनेस्थेटिस्ट अब सब बाय चॉइस आए, 99% इधर हैं जिन्होंने हाथ उठाया कि वो बाय चॉइस आए. अब बाय चॉइस उनको पता है कि द ग्लैमर ऑफ ए सर्जन इज़ नॉट हियर. दे हैव चूजन दैट, आई हैव चूजन दैट. द अगर प्रायर प्रैक्टिस में है, द अमाउंट ऑफ मनी इज़ नॉट हियर, इट इज़ विद द सर्जन. आपने चूज़ किया है, तो इसमें परेशान जलने घुटने की क्या ज़रूरत है? आपने खुद सोचा है कि भाई मैं कम पैसे कमाऊँगा, अल्लाह ताला के साथ मुआहदा कर लिया. तो अगर आपके पास मनी, ग्लैमर, ये कनेक्शन, वो कनेक्शन, गवर्नर से बातचीत अगर वो नहीं है, तो आपने चॉइस कर लिया है एंड रिलैक्स एंड एन्जॉय इट. इसलिए कि ये आपने प्रोफेशन खुद चुना है बिकॉज यू लव इट एंड यू आर गोइंग टू एन्जॉय इट. इफ़ यू डोंट एन्जॉय इट, प्लीज़ लीव एनेस्थीसिया और जाकर के PIDC के पास पान की दुकान खोल लो, that will be better. Enjoy it.
Sir, so coming back to this question that many senior anesthesiologists trained under similar conditions and survived.
सर उसका इसकी इसी पे बड़ी अच्छी बात.
Why should current training system?
बड़ी अच्छी बात हुई आपने ये सवाल पूछ लिया. वो एक ज़माने में क्या होता था जब यूरोपियंस निकले थे ना वॉयजेस पे, तो वो शिप्स पे जाते थे, तूफ़ान आते थे, बड़ा ख़तरनाक सफ़र होते थे. तो वो हमेशा शिप में एक पादरी होता था जो बाइबल लेके, उसके दो काम होते थे कि जब वो तूफ़ान आता था तो उसने बाइबल पढ़नी होती थी, जब वो आगे जहाँ कहीं जाके लैंड करते थे तो वहाँ उसने फतवा देना होता था कि ये हीदन्स हैं, इनके साथ जो मर्ज़ी करना है कर लो, इनको गॉड का वर्ड सुनाओ. तो वो जब तूफ़ान आता था तो बाइबल लेके खड़ा हो जाता था, पादरी दुआ करता था. जब वो बच के शिप वापस आती थी तो वो कहते थे कि जी so this was great, we had this great storm, we would have died, and the priest stood up and he offered prayers and we were saved. And वो चलता रहा मिथ, जिस वक्त तक किसी ने खड़े होके कहा ना, did you ask those who did not survive, कि उन शिप से जाके पूछा समुंदर के नीचे पड़ी हुई क्योंकि तुम्हारे पास भी कोई पादरी खड़ा दुआ कर रहा था. तो सवाल ये है कि many senior anesthesiologists trained under similar condition and survived. Have you tried asking people who did not survive? Was it burnout?
Very nice. So Dr. Shahryar, please.
थैंक यू. अच्छा, मैं इसमें कुछ कमेंट्स भी करना चाहता हूँ. और पहले एक तो ये चीज़ है कि हम जो यहाँ पे आज जिस टॉपिक पे बात कर रहे हैं वो पर्टिकुलरली बर्नआउट इन रेजिडेंट्स है. समवट हम इस सारी डिबेट जो है इसको हम सीनियर लेवल पे या कंसल्टेंट लेवल्स पे भी इस चीज़ को रूल आउट करने की कोशिश कर रहे हैं. सेकंड ये है कि क्या सिर्फ जो हमारा काउंटर मेरे रिस्पेक्टेबल जो चेयर्स हैं वो ये समझते हैं कि सिर्फ एनेस्थीसिया फील्ड जो है बर्नआउट है, या ओवरऑल मेडिकल, और फिर मेडिकल भी छोड़ें, क्या डेली लाइफ डेली जीना भी मुश्किल है कि नहीं है. तो अगर ये सब चीज़ें हैं तो वो स्ट्रेस हैं डेली लाइफ के. इट्स नेवर अ बर्नआउट. बर्नआउट कब होता है? जब आपकी चीज़ों को एक्नॉलेजमेंट नहीं दी जाती है. मैं कहता हूँ कि एनेस्थीसिया माशाल्लाह आज सब यहाँ पे बैठे हुए हैं, ट्रांसफॉर्म्ड हुआ है. हम इस बात को क्लेम भी कर रहे हैं, हम इस बात को एविडेंट भी कर रहे हैं. आपके पास पेन क्लिनिक्स हैं, आपके पास क्रिटिकल केयर में आप फर्दर कर सकते हैं, आपके पास रेजिडेंसी प्रोग्राम्स हैं, आपकी एक्नॉलेजमेंट है हर लेवल पर. और अगर मैं इसको फिनेंशियल बर्नआउट के लिहाज से देखूँ तो अभी रिसेंटली मैं क्योंकि क्रिटिकल केयर हेड करता हूँ तो मेरे एमओस जॉब्स के लिए इंटरव्यू थे. जस्ट मेरे पास टोटल 30 वैकेंसीज थी, उसके लिए 1000+ मेडिकल ऑफिसर्स के लोगों ने मुझे अप्लाई किया, जिसमें डबल FCPS थे. मोस्टली डबल FCPS गैस्ट्रोएंट्रोलॉजी मेडिसिन किया है, इंटरनल मेडिसिन, उसके साथ उन्होंने नेफ्रोलॉजी किया हुआ है, प्लस आर्थोपेडिक सर्जन्स हैं. तो वो सब, और जो उनको जॉब ऑफर दी जा रही थी वो जस्ट 90,000 था. डबल FCPS 90,000 के लिए आके कह रहे थे कि आप हमें यहाँ पे रख लें. तो अगेन मैं उस तरफ आऊँगा कि क्या एनेस्थीसिया, नहीं, एनेस्थीसिया में मैं समझता हूँ कि रिकग्निशन भी है, फाइनेंशियली कोई बर्नआउट नहीं है. इवन एक कैंडिडेट, एक रेजिडेंट अगर वो फर्स्ट या सेकंड ईयर में होता है तो उसको कहीं ना कहीं से ऑफर्स आना शुरू हो जाती है, और इंडिपेंडेंटली सब जो है वो अपना मतलब अदर देन स्टाइपेंड्स उसके अलावा भी उसकी कहीं ना कहीं से चल रही होती है. तो लिहाजा रिकग्निशन फाइनेंशियली कहीं पे भी नहीं है. और इस बात पे मैं थोड़ा सा आ जाता हूँ जो कि काउंटर हमारे उसमें है, स्ट्रेसेस हैं. डेफिनेटली जैसा सर ने भी, टीपू साहब ने कहा है कि एनेस्थीसिया फील्ड ही स्ट्रेस और इन चीज़ों के, लेकिन क्राइसिस मैनेजमेंट भी इसमें आपकी स्किल्स डेवलप करती हैं. आपने कॉल फॉर हेल्प से लेकर पेशेंट के इंट्यूबेट करना है, तो उन स्ट्रेसेस को आप कभी भी बर्नआउट मत गए. वो बर्नआउट तब बनता है जब वो बंदा ज़्यादा खुद कैपेबल नहीं होता. तो वो अपनी इनकेपेबिलिटीज़, अनप्रोफेशनलिज्म और जो सीनियर्स का रिगार्ड है, अगर उसके अंदर वो चीज़ें नहीं होती तो उनको वो हाइड आउट करता है और विक्टिमाइजेशन देने की कोशिश करता है कि जी बर्नआउट है. तो डेफिनेटली मेरा तो इसमें ये पर्सपेक्टिव है.
Dr. Saida, can I have your comment on that, because you were talking about finances and the rest of the thing you mentioned.
मैं कमेंट कर दूं?
Oh, sorry.
2 कमेंट्स हैं. एक तो ये कि जो बात की एम्पावरमेंट की, एज एनेस्थेटिस्ट we are one of the most accommodative people in the medical specialties, because we have to accommodate all specialties, all sort of patients, all sort of surgeons and all sort of systems. हर जगह अलग अलग है. So by training कहते हैं we become very accommodative, but no surgeon can say कि नहीं यार इसको spinal लगाओ, GA नहीं दो, या GA दो spinal नहीं लगाओ. That is still our decision. So if we let some junior surgical resident dictate to our residents, that is our fault. Burnout का इससे कोई ताल्लुक नहीं है. और हम लोग को empower अपने residents को करना है कि you take a stand for yourself, and I keep telling myself, my residents that thing, कि एक surgical resident आकर कुछ भी बोले, you are in ICU, this is your patient, you can take their opinion, you don't have to follow it. एक दूसरी बात ये जितनी बातें हो रही हैं ये सर stressors हैं. इसका बर्नआउट से कोई ताल्लुक नहीं है, एनेस्थीसिया का ताल्लुक नहीं है इस चीज़ से। किसी का घर में मसला चल रहा है, भाई एनेस्थीसिया से क्या ताल्लुक है, ड्यूटी नहीं करें। अगर इतने मसले हैं छुट्टी ले लो ना, छुट्टी ले लो। छुट्टी नहीं लेनी क्यों? 4 साल पूरे करने हैं सर। सी अब टाइम सर, आई डिड 8.5 years ऑफ ट्रेनिंग अब्रॉड, वहाँ पे मिनिमम है ही 7 साल, किसी का नहीं होता 7.5-8 साल लगते हैं। टाइम इज़ इररेलेवेंट। मगर आजकल जितने भी रेजिडेंट हैं, नो ऑफेंस टू एनीवन, ऑफेंस सब होना है तो हो जाओ, बट फैक्ट ये सर टाइम पूरा कर लें। 4 साल एक दिन होगा मौत आने लगेगी, हाई स्ट्रेस हाई स्ट्रेस। छुट्टी ले लो, छुट्टी अलाउड है। यू हैव अ प्रॉब्लम एट होम, सॉर्ट इट आउट, कम बैक। इसका जो भी स्ट्रेस के बर्नआउट के, इसका एनेस्थीसिया से ताल्लुक नहीं होंगे, पर्सनल सर्कमस्टेंसेस से।
डॉक्टर फरजाद, कमिंग बैक टू योर कमेंट, जो एनेस्थीसिया रेजिडेंट स्पेसिफिकली, बिकॉज एनेस्थीसिया एक तरह के दे आर लिमिटेड टू द ऑपरेटिंग रूम्स एंड दे आर नॉट very at very few places they go to the other places. जो surgeons हैं,
Can I respond to that?
जी सर।
Can I respond? 5 सेकंड रह गए।
जी सर, इसीलिए मैंने
ये टाइमिंग ऐसी थी कि टाइम जवाब देने का मौका ना मिले। देखो एग्जैक्टली बिल्कुल बात ठीक है, बट वी आर नॉट गेटिंग द पॉइंट। द पॉइंट इज कि हम सब यहाँ बैठे जज कर रहे हैं कि बहुत ज़बरदस्त स्पेशलिटी है, अगर मैं ना मानता होता तो मैं इस स्पेशलिटी में ना होता। हमें रेजिलिएंट होना चाहिए। हम लोगों ने ये जो बैठे हुए हैं, हम सब ने भी अब तक सरवाइव किया है, हमने किसी ने क्लेम नहीं किया बर्नआउट है। मुझे एतराज़ इस बात से है कि समहाउ आप सब ये फतवा देने की कोशिश कर रहे हो कि इसके बावजूद अगर कोई बर्नआउट कर रहा है तो समहाउ दैट पर्सन इज़ अ लेसर बीइंग, और उसको या तो निकल जाना चाहिए स्पेशलिटी से, या फिर उसी तरह जैसे हम कह रहे हैं काम करता रहे, वरना दिस पर्सन देखे सॉरी आप बायस्ड हैं वैसे भी एक चीज़ का हमें क्रेडिट दें, हमने पूरी कोशिश की है इसको पार्लियामेंट्री डिबेट बनाने की, बट द फैक्ट इज कि प्लीज़ अंडरस्टैंड दैट यू कैन हैव परफेक्टली नॉर्मल मोटिवेटेड पीपल and we all have a kind of a different way our set of neurons interact and interplay and work. Human psychology is complex. We still may have brilliant people who are facing at some point burnout. We need to have a way of identifying them, objectively measuring them, providing with them with the support. Sir, आप जाके देख लें, मैं आपने लाइफ स्टोरीज पढ़ लें बड़े बड़े अचीव करने वाले लोगों की। उन्होंने खुद कंसीड किया कि आई फेस्ड बर्न ऑफ, आउट टुक टाइम ऑफ फ्रॉम वर्क, वेंट बैक, रिफ्लेक्टेड एंड केम नो दे केम बैक डिड द सेम, नो दे केम बैक डिड द सेम थिंग, नो दे केम बैक डिड द सेम थिंग एंड अचीव बेटर।
भाई जो थक गया है वो रेस्ट कर ले बस।
So in the interest of time, Dr. Fazal has a last comment and then Dr. Saida and then we
के अंदर सबसे बड़ा कंट्रीब्यूटिव फैक्टर डिपार्टमेंट खुद है। डिपार्टमेंट की वजह से ये सारा बर्नआउट होता है। डिपार्टमेंट अगर सही तरह से, उन्होंने तो आइडियल बात की ना कि डिपार्टमेंट में ये होना चाहिए वो होना चाहिए, कितने डिपार्टमेंट है जो इस तरह से करते हैं। डिपार्टमेंट खुद एक मेन फैक्टर।
जी, last 2 comments from Fazal साहब and then Dr. Saida and then we will wrap.
अच्छा देखिए अशरत, देखिए आपने खुद अभी कहा कि इंडिविजुअल डज हैव दिस प्रॉब्लम, होता है। क्या ये सिर्फ एनेस्थीसिया में? आप अपने आप से खुद पूछ लें। इट इज़ एवरीवेयर, इट इज़ इन इंजीनियरिंग, इट इज़ इन बैंकिंग सेक्टर, every sector of this country has got the same problem. Why we want to relate it to anesthesia only?
Sir, as per studies, anesthetists are most prone to suicide in medical practice.
मैं सर ये अर्ज कर रहा हूँ कि मुझे मेरा सबसे बड़ा प्रॉब्लम बाकी नहीं है। मेरा प्रॉब्लम ये है कि मेरी एनेस्थीसिया स्पेशलिटीज़ में जो बर्नआउट में हैं उनको आइडेंटिफाई करो और उनको ठीक करो। बाकी को हो रहा है तो ये कोई जस्टिफाई नहीं कि यहाँ भी
होता है। So the clubs have finalized this parliamentary debate and now we know what everyone else is thinking, that ignoring burnout or stress is no longer an option because residents' well-being directly affects the patient safety, learning and the future of our
ये आप हुकूमत की तरह कह रहे हैं, सब ठीक है और मानने को तैयार नहीं है।
So I'm grateful to every one of you. Thank you so very much for this
असल opposition हम हैं।
engaging session. Thank you everyone. Thank you sir. बहुत शुक्रिया।
टाइम नहीं है,
Thank you, Dr. Asma, and the prestigious faculty. Okay. Okay, so we'll close the session here. Thank you so much.
Thank you so much. It was a wonderful debate. For the next session, which is the pro-con session, general anesthesia and challenges. To moderate this session, I would like to call Dr. Mohammad Suhaib on the stage, please.
Assalamu alaikum everyone. My name is Dr. Suhaib. I am working as an assistant professor in Department of Anesthesia at Aga Khan Hospital. So today our session is a pro-con debate, and we are here not discussing that whether one technique is superior to another, but we will be discussing that what the current evidence says right now in a modern perioperative practice, that is total intravenous anesthesia is superior than inhalational anesthetics. For this session, we have the chairperson, so I would like to call Dr. Tahir Akbar. He is a consultant anesthetist at Shaukat Khanum Hospital, and he has an expertise in acute and chronic pain management. Sir has started structured training in regional anesthesia program at a national level. One disclaimer as well, because he shared the same medical college from where I graduated, so I feel proud for that. Our second chairperson for the session is Dr. Zahid Salud. He is an assistant professor at and a head of department of anesthesiology and critical care at Kohigood Hospital. Over to you, sir. You can call for a pro-con debate.
Thank you very much, Dr. Zuhaib. So for this debate, a very interesting topic, and I assume there will be a lot of questions for this debate as well. So the first speaker in favor, I would like to invite Dr. Sidra Javed. She is anesthesia consultant. She is assistant professor in pain physician at Shahid Mohtarma Benazir Bhutto Institute of Trauma. She is gold medalist in FCPS, and she has done pain fellowship from AKU as well. Dr. Sidra.
Thank you. Assalamu alaikum and good afternoon. Today I am going to debate in favor of the topic that is total intravenous anesthesia is superior to inhalational anesthesia. I have no conflict of interest to declare. So what is TIVA? It is a technique in which anesthesia is induced and maintained exclusively using intravenous medications without inhalational anesthesia, either by manual infusion or target control infusion pump, which calculates the exact dosage. And in inhalational anesthesia, a technique where anesthetic gases or volatile vapors are administered through patient respiratory system to induce general anesthesia. So, first of all, the most important post-operative nausea, vomiting, and recovery. One of the most reported consequences of TIVA is its positive effects on post-operative nausea and vomiting, which affects up to 27% of patients and cost healthcare system billions in additional patient cost. A meta-analysis was done in which approximately 229 randomized controls trials were included, and approximately 21,000 patients were enrolled, and it shows that TIVA had reduced post-operative nausea, vomiting risk compared to inhalational anesthesia, better recovery, and lower post-op pain. Another study was done in which approximately 80 female patients undergoing thyroid surgery. Again, it showed, the study found that those who had TIVA experienced a significant better recovery in terms of post-op pain and nausea and vomiting. So, fourth consensus guidelines for post-operative nausea vomiting showed that a strong evidence level to use propofol-based TIVA to reduce baseline post-operative nausea and vomiting. A systematic meta-analysis was done in terms of safety and recovery profile of patients after inhalation anesthesia versus target control TIVA, and it showed that TIVA reduced post-op nausea, vomiting, and agitation. And if we use TIVA with TCI, it might decrease post-operative cognitive dysfunction and increase recovery time. Another meta-analysis was done intravenous versus inhalation maintenance of anesthesia for quality of recovery in adult patients, and again it shows a significant decrease in total quality of score on the day care of surgery. And the main improvement was in 5 dimensions: physical comfort, emotional status, psychological support, physical dependence, and also in terms of pain. Meta-analysis was done in terms of mortality and morbidity after both of them, and it includes approximately 317 randomized controlled trials and 51,000 patients, and it shows that TIVA is superior in terms of it decreased lower post-operative nausea and vomiting, lower emergence delirium, better quality of recovery, better post-operative cognitive outcomes in elderly patients, and so it has the strongest evidence in favor of TIVA. Role of TIVA in neurosurgery, as we all know that for neurosurgery we need hemodynamic stability, controlled intracranial pressure, and effective brain relaxation. So it is a national study, the evolving role of anesthetic techniques in neurosurgery, and it showed that TIVA has better control of intracranial pressure, brain relaxation, hemodynamic stability, and it is more reliable for neuromonitoring intraoperatively. So this study also emphasized that modern neurosurgery requires anesthesia techniques tailored to tumor surgeries and minimal invasive neurosurgery. So TIVA is generally superior to inhalation anesthesia for high-risk neurosurgical cases also. Regarding environmental advantage, we all know that it is a modern argument regarding greenhouse effect, carbon footprint. So we all know volatile agents have potent greenhouse effect, especially dust fluorine. And TIVA lower these like atmospheric pollution, reduce greenhouse impact, and sustainable anesthesia practice. Multi-center observational comparison of intravenous and inhalation anesthetic was done in this study. It is a real-world study in which multi-center scope analyzing over 35,000 adult surgeries across the major French hospitals were done between TIVA and inhalation anesthesia. And it showed that TIVA, the carbon footprint per hour in TIVA was much lower. That is 0.4 carbon emission per hour as compared to inhalational anesthesia. And it shows that the carbon footprint overall in TIVA is very lower as compared to inhalational. Royal College of Anesthesia also shows that sustainability in terms of intravenous and local anesthetic agents, and it shows that TIVA has lower overall carbon dioxide equivalent emissions, no direct greenhouse release, and better aligned with sustainable healthcare. This picture shows that only nitrous oxide has much more 75% to 80% carbon dioxide emission and carbon footprint in atmosphere, and it is from 2000 to 2030, and it is very hazardous for our environment. This shows the comparison between inhalation and TIVA, and it shows all the environmental pollution, plastic pollution in terms of propofol, but carbon footprint emission, and shows that even when consumers and drug production are considered in a cradle to grave analysis, IV remains environmentally preferable to high emission. TIVA has also advantages in airway procedures, like it has less cupping, less laryngospasm chances, and smoother extubation, so especially benefit asthmatic and ENT procedures. So we can say that TIVA suppresses airway reflexes more effectively, reducing bronchospasm and laryngospasm during airway manipulation. It also has a good outcome in respect to hemodynamic stability. If we use remifentanil-based TIVA, it provides stable heart rate and MAP, better control during stimulation, and reduce sympathetic surges. So we can say the precise controllability of propofol-based TIVA makes it an ideal technique when cardiovascular stability is a priority. There are some researches regarding TIVA in cancer patients also, and it shows that TIVA has better cancer-related outcomes, less immunosuppression, and reduced recurrence risk compared with inhalational anesthesia. It is a campus vegan is a place to learn health from healthcare professionals, and it shows also emphasis on switching from inhaled to intravenous anesthesia. And he raises many points why sustainability matters more than ever because of greenhouse effect, environment, and many other things. And it also shows that switching from inhalational anesthesia to TIVA is not merely a technical change, it is a commitment to modern, sustainable healthcare. So the key points are TIVA is superior to inhalational anesthesia in terms of lower carbon footprint. That is, TIVA is not only patient-friendly but planet-friendly also. Also, in terms of less post-operative nausea and vomiting, patients remember post-operative nausea more than surgery itself, and faster, smooth recovery. And last but not the least, no operating room pollution for anesthetists also. So I conclude my debate with the term that choosing TIVA is not merely a change in technique, it's a shift towards safer, cleaner, and more sustainable anesthetic practice. Thank you.
Thank you very much, Dr. Shedra. Our next speaker is Dr. Nasir Khoso. He is consultant anesthesiologist and critical care physician, Director Critical Care and Emergency Services at South City Hospital, head of the Rapid Response Team and Director Postgraduate Medical Education at South City Hospital. Dr. Nasir Khoso, please.
Assalamu alaikum. So, is TIVA is superior than inhalation anesthesia? This is a great debate. Okay, so I am going to present the con, but moderator ने पहले ही मुझे कहा था छोटा करने का time नहीं है, तो moderator are also biased. So the important thing is that I don't have any conflict of interest. किसी inhalation agent ने ना कोई गाड़ी लेके दी ना कोई gift दिया, but उसके बावजूद I am going to present in the favor of them. And I am a critical care physician, and I usually give a propofol and TIVA all agent, but in spite of that, I'm going to present what is evidence-based practice. I'm not going to present my own experience, but I'm going to present evidence-based practice. So what does superior mean? My colleague just described that the TIVA is more better in post-operative nausea vomiting. TIVA is more better than quality of the recovery. TIVA is more better than discharge readiness. Is superior called like that? Superior should be superior in all aspects, like patient important, like patient mobility, modality, organ dysfunctions, in the safety, awareness, monitoring, and important thing, cost effective. These all are the domain. अगर कोई इन चारों में अगर superior है तो then we can call that is a superior. Only one frame agenda we can't call that superior. So this is the evidence. My colleague present that study that in this study that shows that yes, TIVA reduced perioperative nausea vomiting, TIVA improved recovery quality, and also TIVA lower emergency and delirium incidence. But in this systemic review, these all are the secondary outcomes. These are not the primary outcomes. So in this study, my colleagues comments only on the secondary outcomes, but not on the primary outcome. I'm going to show you detail of the primary outcomes. There's no difference in primary outcome. In hospital mortality, in 30 days mortality, in 1 year mortality, there is no primary outcomes benefit in the TIVA as compared to inhalation agents. So again, this TIVA improves some recovery outcomes like post-operative nausea vomiting, emergence, delirium, and quality of recovery. So audience, please tell me, these are the benefits? Only recovery secondary outcomes are the benefit for the TIVA? No, it's not. This is again a study that is published in BMC Anaesthesiology in 2018. The key finding was that TIVA significantly induced post-operative nausea vomiting only and reduce agitation in smooth recovery, but volatile anesthesia agent has slightly faster emergence than TIVA. And there's another study that is published in the Anesthesia Analgesia. My colleagues also mentioned that study, that is a 4 consistent guideline for management of post-operative nausea vomiting. In this study, that also conclude that this TIVA is beneficial in only post-operative nausea vomiting rather than morbidity and mortality. There's no difference in mortality and morbidity. So this is another study, that is anesthetic drug and survival. That is a meta-analysis that volatile anesthesia may improve survival in cardiac surgeries and reduce myocardial injuries in troponin release, and suggested that superiority over TIVA in cardiac procedures. And then other study that is published in Anaesthesiology in 2020, and that key finding that volatile anesthesia agent has a cardioprotective effect, lower ischemic injuries, and better perioperative cardiac biomarkers. So this is a high level evidence in regarding myocardial protections. Now again there's a two study that is again high level cardiac surgery evidence that TIVA is more better, and then inhalation agent is more better than TIVA in terms of cardiac surgeries. So cardiac surgery does not rescue for the superiority claim. So as my colleague mentioned that this in cardiac surgery TIVA is superior, so no, in cardiac surgery TIVA is not superior. And we have that evidence in the primary outcome, that is a neutral, 1 year mortality is slightly neutral and more towards the volatile, and again ICU in hospital stay, that is again more towards the volatile agents. And now the cancer outcome. Again, my colleague said that in the cancer, the TIVA is much superior. These are the studies. In 2020 study that said, analyzed that oncological outcomes, a systemic review, there is no benefit for the TIVA. And again, in 2023, there is a study done by Sister et al. In 2023, the major cancer surgeries, OCTs, follow-up, long-term survival in older patients given propofol or sevoflurane anesthesia has a major cancer surgery, no results. Same recently in 2016, that's published in the January, that is the cancer argument for the common PRO claim, that this hypothesis also said there's a no survival benefits in the cancer surgery either with an inhalation agent or for the TIVA. So again, environmental cost. The environmental cost dysphlorine at high emission, but that is on the high flow, that is not on the low flow anesthesia. If we are giving the low flow anesthesia, then again environmental changes, hazards we can manage. And cost effect, the cost is very much important. So why safety monitoring is matters in TIVA? That is published in Anesthesia Journal, the guideline for safe practice in total intravenous anesthesia. If you see these 4 bullet points, we need a competency in the TIVA, we need a guidelines to develop for the TIVA, and we need a monitoring for the TIVA, and again we need a very program, infusion pump, all these in the TIVA. So safety challenges, monitoring, awareness, these are the major risks, only reducing the incidence of post-op nausea vomiting as compared to all these safety challenges. These safety challenges are the big matters. And delivery reliability matters. Again, it's very difficult. In inhalation agent, we just monitor by end-tidal CO2. While for the TIVA, we need a BIS monitoring, we need a EEG monitor as well. Now in the Pakistan, in low-income countries, is it possible to give TIVA? I think so, no. These 2 studies published that anesthesia assessment workforce capacity in Tehsil Sindh in Punjab. So I'm going to present just few things. That is the pulse oximetry available in 99% in Punjab setups, and continuous waveform capnography 17.9. In Sindh, full anesthesia physician, that is 75% only. And again, 1 full anesthesiologist is 59. So in this lower middle income country, is the TIVA is possible that we have only 59% full-time consultant in a hospital? I think so that's not possible. So what PRO will say? PRO will say TIVA reduce post-operative nausea vomiting. I agree to that, but one recovery endpoint does not prove overall superiority. And yes, TIVA is greener, often true, but versus high flow anesthesia, but for the low flow gas, that is the duration matters. And other TIVA improve cancer outcome. Randomized trial do not confirm the survival benefits. And the 4th one is that TIVA is ideal for selected patient. Okay, I'm okay with that. That's a selected indication, but not universally superior. And the proposed EEG and awareness, it is an extra safeguard required. Superiority is harder to claim in that case. So the TIVA is valuable. It's not a universal superior. The modern anesthesia should be individualized, not ideological. So choose for the right anesthetic for right person, surgery, team, and system. So my last slide is that the evidence supports precision context, not declare one technique superior in all patients. Thank you.
Yes, thank you very much, both speakers. Any questions from the audience?
Any questions? कितने लोग टीवा यूज़ करते हैं? टीवा बहुत सारे लोग यूज़ करते हैं, बहुत सारे लोगों ने हैंड उठाए. So any question from the pro debate or a con debate? Like one was like favoring.
There is a question, please.
Please.
Mike.
You have a question from a pro speaker or a con speaker? Con speaker. Nasir, you have a question.
Assalamu alaikum. I am a pro for the TIVA basically because I like TIVA. It's a rapid recovery after giving propofol induced anesthesia. But you are more towards the favor of inhalational anesthesia just because we are living in a country where we don't have equipments, we don't have monitoring, and we don't have TCI pumps. So don't you think it's I mean if you're recommending using inhalational, so we are going backwards using inhalational, or rather we should encourage newer generations to use TIVA. Living in a country where I don't think so sevoflurane is available in each and every hospital. As you mentioned sevoflurane for cardiac patient, you didn't mention the agent, you just said the inhalational agent is superior, but you should also mention in those studies, did they use sevoflurane or did they induce the patient through isoflurane? Is it the same for both, or is it just for the sevoflurane, or using the sevoflurane using the inhalational agents? Because I think TIVA is more superior and we should encourage our residents to use TIVA more rather going into the inhalational agents. So that's just my question. Thank you.
It's not just encouraging that use only inhalational agent, not the TIVA. So we can use both, but in the selected patients in the environment and duration of surgery. That is again important thing. My debate was that TIVA is not superior than inhalation agent. Yes, it is good, but it's not superior. If we call that superior, then we can only use the TIVA. We are not using inhalation agents. So yes, in the past we used inhalation agent mostly, not TIVA, but TIVA did not replace inhalation agent. The most of the studies done with the sevoflurane, not with the isoflurane. Okay, again, I think so the equipment that need for the TIVA and monitoring that's need for TIVA are more costed than sevoflurane. Sevoflurane is not too cost.
Yeah, I know sevoflurane is not that, but I know आप equipment की बात कर रहे हैं. But at least we should encourage the newer generation to use the recent which the world is using. Why we are encouraging? Just because the cost effective. If the institutions like the private institution, if they can, if they can encourage using TIVA, we should encourage the newer generation. Rather, in some cases or in all cases where if needed, rather pushing them backwards toward inhalational agents, because in those studies you mentioned, it is more with the sevoflurane, not with the isoflurane. We cannot use isoflurane in cardiac patient in each and every, and we say that it's the same outcome like TIVA. Don't you think?
Thank you so agree much to you, but the important thing is that we invest our all exercise in major things that have a mortality and morbidity benefits, like a president of the anesthesiologist is theater. Again, there's a mortality benefit. Okay? So as a compared to TIVA with the inhalation agent, there's no mortality and morbidity benefits. There's reduced only post-operative nausea, vomiting, and quality of recovery, nothing else.
Thank you so much, Nasir. Any other question? Dr. Saad wants to ask one question, and then we will just like.
I want to comment one thing. जैसे कि डॉक्टर नासिर ने कहा कॉस्ट इफेक्टिवनेस जो है वो इन्हेलेशनल में कम है. ओवरऑल अगर टीवा में है तो हम ये लगता है कि कॉस्ट इफेक्टिवनेस ज़्यादा है, लेकिन अर्ली डिस्चार्ज हॉस्पिटल से जल्दी होता है, नॉजिया वॉमिटिंग कम है और बहुत से कोमॉर्बिड्स कम हो जाते हैं. तो ओवरऑल अगर हम देखें तो कॉस्ट इफेक्टिवनेस इक्वल हैं दोनों के, क्योंकि पेशेंट के वो पैसे बच जाते हैं.
डॉक्टर साहब
So just a comment. So I think debate का point नहीं ये नहीं था कि one agent is superior. I think the new anesthetists and us as well should know both techniques, TIVA and inhalational, and the right technique should be collected. So just one question from Dr. Nasir. So abhi we're getting a lot of studies on the environmental impact of things that we have been using for generations. For example, plastics, radioactive materials, jo uski total cost, if we accumulate with the generations that are going to be affected by it, it is still exponentially increasing. So do we have any studies which has shown what would be the generation-wise impact on the environment on the use of inhalational anesthetics?
No, sir. I tried a lot to figure out that as well, but I couldn't have any conclude that what is the effect of the inhalation agent over the generation. But again, you are right, there may be some effect on population as well.
Thank you so much. Actually, we are short of time. I think so. TIVA wins on our recovery and inhalational wins on practicality. And both, like some of the outcomes are both have the same, like if we label it a mortality benefit or like the outcomes of 1 year or 30 days or 1 year. So, and it all depends upon what we are targeting with the TIVA. Like either we are targeting the patient have a strong issue of post-operative nausea and vomiting, we will be using TIVA in that, not inhalation anesthetics. But like in a cardiac surgery patient, we usually know that inhalation anesthetics are protective for protecting from ischemic reperfusion injury. So with this, we will conclude our session. May I request our chairperson to come on the stage and give these certificates to the presenters. So.
Okay. I think both the techniques are in our armamentarium, and the anesthesiologist should be well versed with these things. The debate is something good, but the practicality, what we are needing, TIVA in certain places, like emergency, ketamine, certain other drugs, in emergency accident cases, in radiodiagnostic tools, and of course in the prolonged cases, we have to avoid TIVA, as that could be PRIS, one of the possibility of getting propofol infusion syndrome, and other things can happen. So inhalational anesthesia is our gold standard in many cases. Of course, regional and all the techniques are good for the anesthetist to have it, and it should be well balanced and appropriate. Thank you so much.
Thank you, sir, for the valuable comments in that. So first, so can you come on stage to give the certificates? So may I request Dr. Siddha Javed to come on the stage and Dr. Nasir Khoso. May I request Dr. Safia Zafar please come on the stage to give the certificates to chairperson of this session. Open for the next session.
Good afternoon, ladies and gentlemen, and Assalamu alaikum. We will now begin our final yet the most awaited and anticipated session, the PSA Resident Jeopardy Challenge 2026. I am Dr. Abdullah Nisar, and I will be serving as the quiz master and the moderator of this session. First of all, I would like to invite our session chairs, Dr. Safia Zafar Siddiqui. She is currently serving as the head anesthesiology at Sin Institute of Advanced Endoscopy and Gastroenterology. She has served as CBSP supervisor and the past head of the Department of Anesthesia, Dow University of Health Sciences Civil Hospital, Karachi. Next, I would like to have Dr. Ahmed Sumro, Professor of Anesthesiology and Departmental Head and Chair, Chanka Medical College and Hospital, Larkana, who has a special interest in ICU and high-risk obstetric cases. So today's competition is designed to test not only the knowledge but also the clinical reasoning, decision-making under pressure, teamwork, composure, and collaboration, qualities that define our specialty every single day in the operating room, ICU, and pain practice. We have prepared a mixture of challenging and competitive questions. Starting with the game format, there would be 5 teams. Aga Khan University Hospital, Dow University of Health Sciences, Indus Hospital and Health Network, Fizaya Rutfao Medical College, Shahid Mohtarma Benazir Bhutto Institute of Trauma. Each team will attempt 4 questions of their choice. The questions range from 100 to 500 points, increasing in difficulty. Full points would be awarded on the correct answer, while a full negative points deduction will proceed a negative or an incorrect question. The quiz categories are anesthesia rapid recall, pain and critical care, history and discoveries, sports arena, and around the world. So with that said, I would like to invite the participants to come at the front and be seated for this session. So the names at the bottom, that would be the scoring. The names were randomized and evenly agreed by all the participants with regards to their turn. So first of all, we will be starting with the trauma team to choose the button.
Can I explain rule of this session?
Yes, ma'am. हमने rule कर दिए थे, आप disclaimer बता दीजिए.
अच्छा. अच्छा, before the start of this session, there are 2 rules. बल्कि law. All questions included in this quiz have been carefully reviewed and verified from standard academic and authentic references. Questions or answers will not be open or challenge or debate during the session. Rule number 2, we also request the audience to maintain fairness and professionalism throughout the competition. Any prompting, signaling, verbal assistance or communication from the audience directed towards the participating teams will result in deduction of points at the discretion of judges. Thank you.
Thank you, Dr. Safia. So starting with the first team, Trauma Center. Pain and critical care, 400. And your question is, which opioid is least affected by renal dysfunction? Pardon? C-fentanyl. The answer is C-fentanyl. So 400 to the trauma team. Next up is Team AKU.
Pain and critical care, 500.
Pain and critical care, 500. Opioid-induced hyperalgesia is primarily mediated through what receptors?
B.
B, NMDA receptors? Okay. And that's the correct answer. Next up is Indus Hospital.
Pain 400, pain and critical care.
Pain and critical care is done. हो चुका है.
Around the world 400.
Around the world 400. So which strait separates Asia from North America? The Strait of Hormuz, Bosphorus Strait, Bering Strait, and the Strait of Malacca.
Asia from North America. Asia from Europe.
Please, audience, please quiet.
Bosphorus. B, Bosphorus Strait.
B, Bosphorus Strait. So the answer is Bering Strait actually. So we go negative here. Negative 400. Team, the next team is Fizaya.
Anesthesia rapid recall 500.
Anesthesia and rapid recall 500. That's highly adapted in recent TIVA registries for structural cardiovascular stability. This short-acting sedative features metabolism entirely reliant on tissue esterases. Which one would be?
A, dexmedetomidine.
A, dexmedetomidine, but the answer is B, Remazulam. Lastly, Dow University of Health Sciences.
Anesthesia rapid recall 400.
So here it is, during one lung ventilation, hypoxic pulmonary vasoconstriction is inhibited most by which drug?
Isoflurane, C.
C, isoflurane, that's the right answer. We got the first round done. We got 3 more attempts available. We would be coming back to the trauma center.
Pain 300.
Pain 300. So the WHO analgesic ladder was initially developed for the management of what type of pain? And I would like to request the audience to hold their horses, please.
C, cancer pain.
C, cancer pain, and that's the answer. Right. Next up, Team AKU.
Sports 400.
Sports 400. Who has the most Olympic gold medals in history? Team AKU.
C.
C, Michael Phelps. That's the answer. Great. Google तो नहीं कर रहे आप? So Team Indus is next.
Sports 500.
Sports 500. So Jahangir Khan actually is considered the greatest squash player of all time. What is the record for the most consecutive matches won by him between 81 to 86?
C.
C, 555, and that's the answer. Next up, Fizaya.
History and discoveries 500.
History and discovery 500. So, who discovered the euphoric and analgesic effects of nitrous oxide?
A, Humphrey Davy.
Humphrey Davy is the right answer. Lastly, Team Dow.
Anesthesia rapid recall 300.
Rapid recall 300. According to a Huygens process equation, if you decrease the radius of an ATT by half, by what factor does the resistance to laminar flow increase?
16.
C, 8-fold, which is not the answer here. 16-fold. C का नाम है?
16, 16,
16 का.
16, yes.
Did we hear the 16? Okay. 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 Say fine. I'm sorry for this. So, थोड़ा आसान हो जाएगा अगर हम ABCD में बात कर सकें इस पर. Next up is Team Trauma Center.
History and discoveries 300.
300, and here it is. Who invented the LMA?
Audience, please keep quiet.
B. Archie Brain.
Archie Brand B is the answer, yes. Okay. So, next up is trauma.
Marks नहीं हुआ.
जी जी ऐड कर रहे हैं आपके टीम AKU.
Around the world for 300.
300 around the world. Here it is. What is the capital of Canada? ये audience की आवाज़ आ रही, so if the chairperson would suggest, हम फिर omit करेंगे if we feel कि there is an unfair advantage to the participants.
अगर किसी ने बोला तो
A.
Toronto is not the answer. Team Indus.
Around the world 500.
Around the world 500. The ancient city of Troy is located in present day which country?
A. Greece.
Greece is not the answer. Turkey it was. Team Fizaya. Team Fizaya. Okay, I'm sorry. G.
History and discoveries 400.
History and discovery 400. So, who used chloroform to anesthetize Queen Victoria during her childbirth? Team Fizaya.
B. Jon Snow.
B. Jon Snow, and that's the answer. And Team Dow.
Pain and critical care 200.
200. In the ICU, the most common cause of normal and non-gap metabolic acidosis would be
A.
A. Saline resuscitation. Team Trauma Center. And this is the last round.
Anesthesia rapid recall 200.
200. So in a patient with myasthenia gravis, how is the response to succinylcholine typically altered?
B.
B. Relative resistance, yes. Team AKU, final call.
Sports Arena 300.
Sports Arena 300, and that is who scored the Hand of God goal? Team AK, your answer.
D.
B.
D for dog.
Zidane. Okay, so the answer is Maradona. Team Indus.
200 sports.
200 sports. So which Pakistani bowler has the most hat-tricks in international cricket?
B. Wasim Akram.
B. Wasim Akram. Yes, that's the answer. Team Fizaya.
History and Discovery is 200.
History and Discovery is 200. So which anesthetic was publicly demonstrated by William Morton in 1846?
B. Ether.
B. Ether, and that's the answer, right. Team DUHS. Last question.
Pain and critical care 100.
Pain and critical care 100. So which tool is commonly used to assess ICU delirium?
C.
C. CAM ICU. That's the answer. And that's it from our participants. So Team Trauma has scored 1200 points here, who are actually the winner of this quiz. Second up is, which are being displayed as well here as well. The second team is Team Dow University of Health Sciences, scoring 1000 points. Third is Team Fizaya, scoring 600. Fourth up is Team AKU with 300 points. And finally, we have Indus with a negative of 200 points. But let's have a round of applause for them as well. So with this, I would like to invite the winners and the runners-ups to be on the stage for their prize distribution. And congratulations again.
I must congratulate all the participants to sit in the front of audience and responding the questions. It is a very good activity, and I must congratulate you, Abdullah. आपने इतना अच्छा बनाया और सारे लोग ने इतना अच्छा behave किया, बीच में कोई बोल नहीं रहा था. That is very good. और ये मेरे ख्याल में हर दफ़ा होना चाहिए. बहुत अच्छा, very nice.
So I'd like to have Team Dow University of Health Sciences first on the stage to receive their runner prizes. And I'd like to have the chairpersons, both of you, Dr. Ahmed and Dr. Safia, to present the awards to the winners. And now I'd like to have the winners on the stage from Trauma Center, Dr. Shafak and Dr. Tariq. And that's it for all. Hope you guys had enjoyed this initiative, and we hope that this continues as well in the future.
Thank you so much. we'll be having a last talk, which is the recent advances in sedation. It has to be given by Dr. Shahryar Ashraf. May I request Dr. Shahryar Ashraf to come and deliver the talk, please? It's the last talk, ladies and gentlemen. Please be seated. Khana nahi khula hai abhi.
Assalamu alaikum and good afternoon, respected professors, consultants, colleagues, and residents. Thank you, PSA Karachi, for the invitation to speak today at this prestigious conference. May I have your attention, please? Please be seated. Today I will discuss the topic of recent advances in ICU and the evidence-based strategies for optimal patient outcomes, advocates protocolized care, and meanwhile minimizing the complications like delirium prevention, prolonged ventilation, and neurocognitive dysfunctions. In the last decade, the transformation of ICU sedation has been changed from deeper and prolonged sedations towards the lighter, patient-centered, and protocolized strategies. And the major research trials like PADIS and TRENDS 2 is always there to shape our understanding. In this presentation, I will review along with you the current goal of ICU sedation, the delirium prevention, and the role of dexmedetomidine in intensive care, and definitely comparison of major research trials. In the modern critical care, the sedation is not only to sedate simply the patient, but it is nowadays transformed to just wake up your patients at the earliest with more enhanced recovery, safety, comfort, and lighter stay at the hospital and early liberation from the ventilator. ICU sedation strategies matters because previously somewhat it is believed and considered protective to keep your patients excessively sedated and its things to be convenient. But the major trials and the studies done in the past, in the recent, in 2025 by Society of Critical Care Medicine, so they have evolved that the excessive sedation is almost associated with more delirium, with more coma days, and also the ventilation duration and hospital stays also prolonged, and there is worse outcomes of neurocognitive dysfunctions. So in the right upper corner of the screen, there is a comparison between the light sedations and deep sedations. So definitely the light sedation has a more coma and sedation free days like 8.6 in comparison to deep sedation where the coma or delirium free days are 4.1. And another thing that is focused and stressed in the new guidelines is the conversion of our choice of the sedations from benzodiazepines to non-benzodiazepines as propofol or dexmedetomidine associated with lower delirium risk with early mobilization and early ventilator liberation. And by these studies have evident that there is an early extubation while you using these non-benzodiazepines, and there is a 25% reduction in delirium, 68% early mobilization, and overall there is a 42% reduction in mortality. So evidence-based sedation for better outcomes and faster recovery. The current goals in ICU sedation, the concept is basically stated over the 4 pillars. The first one is analogous sedation. Analogous sedation means while you are offering your patient sedations, offer first them analgesia. What it do, it keeps your patient ready to assess systematically and treat pain before adding hypnotics. definitely minimize opioid requirements, and it is recommended through studies. Analgesia first strategy reduces sedative needs. The second pillar is targeted light sedation to keep the RAS around -2 to 0 to keep your patients under the light sedations and avoid routine benzodiazepines, and also implement daily trials like spontaneous awakening and spontaneous breathing trials. And definitely in response to these trials, you have to minimize the nurse-driven sedation titration protocols. And the conditional recommendation is to have your patient in light plane of sedation for faster recovery. And the third pillar is delirium prevention and reduction. So reduction is always comes through the screening, and screening usually in the intensive care done through confusional assessment method, CAM ICU. And to minimize or prevent the delirium, you have to keep your patient lightly sedated, early readiness for extubation, and try to mobilize them early and promote sleep hygiene. The sleep hygiene is simply a concept that you keep your patient with less disruptions during the night time, and conditionally you can add melatonin, a natural substance that gives the brain night signals, so it promotes the optimization of sleep. So it's again a conditional recommendation as per the guidelines. And the fourth and final pillar is liberation and sleep optimization and preservance of circadian rhythm. So that's coordinated with spontaneous awakening and breathing trials for ventilator liberation. Definitely minimize nighttime disturbance, keep your monitors at the low noise and keep the lights switched off, and schedule your nursing course definitely in the daytime rather in the nighttime, and consider melatonin, that is conditional, and always go for non-pharmacological sleep strategies. Definitely the goal is to restore circadian rhythm. This slide represents the philosophical aspect of modern critical care ICU sedation, that we have to compete somewhat between the two competing forces. The one is that is you keep your patient under sedation, and one is over sedation. While you keep, the both has potential benefits and risks. If you keep your patient over sedated, definitely it has prolonged ventilation stay, it has delirium risk, the patient may opt further complications, while at the same time, if you keep your patient understated, so definitely there is a distress, there is a time that there is some device removal can happen, and definitely there is adrenaline surges in between sympathetic activity. So the main art is to get the right balance, and by achieving this balance becomes our part to healing. As per the current guidelines, suggested as a 2025 PADIS. PADIS stands for pain, anxiety, agitation, sedation, delirium, immobility, and sleep disruption. So these guidelines have advocated and suggested to continue favor non-benzodiazepines over benzodiazepines for routine ICU sedation. And they suggest using Dexmed over propofol for mechanical ventilated adults where light sedation and or delirium reductions are priorities. And there are conditional recommendations that evidence shows Dexmed may reduce delirium duration versus propofol. And what is stressed in these 2025 updates to manage your patient, the new are to manage your patient's anxiety, keep their sleep optimized, and enhance their mobilization at the earliest, and every patient should go under intense monitoring and protocolized light sedation. And for the delirium management, they always emphasize prevention plus non-pharmacological bundles intervention. So sedation assessment and implementation is again have 6 components. The first one, in the modern critical care, you have to monitor your patient sedation levels through Richmond Agitation Sedation Scale, that is RAS. So we advocated and advised to keep the target of -2 to 0, that is the lightly sedated, and frequency should be 2 to 4 hours. And goal is to have a adequate, not over, not under, but a proper sedation and daily monitoring. The second concept is to have a pain assessment tools. So we have two tools. One is the critical care pain observation tool, and other is the numeric rating scale. The difference between the two, the NRS is using for the awake and cooperative patients, while CPOT is used for the ventilated and comatized patients. So by treating your pain first, definitely you prioritize analgesia. And the third is for prevention delirium. So you always have to screen your patients through CAM ICU scoring system. And for prevention of delirium, definitely you need light sedations, daily awakening and breathing trials, and keep your patient extubated at the earliest and when feasible. And definitely by doing all this, you keep your patient oriented. So delirium reduction is somewhat important in modern critical care. Then it's the fourth and fifth concepts are spontaneous awakening and breathing trials. In the spontaneous awakening trial, purpose is daily safety screen, and definitely you minimize the sedations and evaluate neurological status of the patient. Once patient neurological status is optimum, so you go for the spontaneous breathing trial that is coordinated between the respiratory therapist and nursing. And once patient is able to extubate, so extubate them at the earliest, and by doing this, you optimize the winning success. And then the final and the last concept is ABCDEF bundle. That is a complete ICU liberation program. A stands for awakening and daily trials, B for breathing coordination, C for choice of analgesia, and D for delirium monitoring, E for early mobilization, and F for family engagement and empowerment. And in the modern critical care concepts, what we monitor consistently is what we improve successfully. If you can't measure, you can't improve. So these tools are implemented to measure or monitor your patient sedations. So as per the recommendation of Society of Critical Care Medicine, it's the dexmedetomidine that is the agent of choice for arousable sedation and delirium management. It's purely alpha-2 and inhibits the locus coeruleus and produces the cooperative arousable sedation, and somewhat it also produces analgesia and symptolysis. It has a unique property of minimal respiratory depression and also having a opioid sparing potential. It has a rapid infusion onset of 5 to 10 minutes, and metabolism is hepatic and excreted renally. The current guidelines suggest the patient who should be opted or offered the dexmedetomidine are those who are needing the light sedation protocols best for cooperative arousable sedations, the patients who are prone to develop delirium, so it reduces the delirium risk versus benzodiazepines, and in alcohol withdrawal, adjunctive in the management, and for nocturnal sedation when agitation precludes rest. So this is a comparative evidence of MENTS trial. MENTS trial is a randomized trial comparing Dexmed versus propofol in mechanical ventilated patients, and somewhat it has proven that no clinical significant differences between Dexmed and propofol in any primary outcome, and both agents are viable options for light sedation and sepsis. So there is no difference in propofol and Dexmed in delirium-free days, ventilator-free days, and 90 days mortality. But somewhat this trial is evident that one of the unique properties, that is the cooperative and arousable sedation, somewhat they would not be able to eliminating these aspects of Dexmed over propofol. And also these trials has some of the limitations, warnings, and caveats that there is a median 22-hour delay from eligibility of the study drug start may have limited ability to affect outcomes, and also there is a 14% unmasking episodes, means the clinicians and staff who are involving in the trial knew the treatment, and definitely by knowing the treatment agent, it can affect their assessment and management of the patients. And there is a 5% crossover between the two arms. Definitely you can't keep strictly one patient in one study arm. So it's a crossover contamination. And finally, it is the adjusted enrollment target that a patient, for some reasons, refusal or clinician would not choose them to eligible for the study. So all these findings are robust but should be interpreted within the pragmatic trial constraints. Practical advantages of Dexmed definitely is a cooperative arousable sedation. It offers minimal respiratory depression, its opioid sparing effects, and it has a symptolysis effects. It's control the heart rates and BP management. It produces REM and 2 sleep-like features, and delirium-sensitive contexts that it suggests for dexmedetomidine or propofol when delirium reduction is priority. Physiological aligned ICU sedatives used when light sedation is targeted, early extubation increases planned delirium risk in high versus opioid minimization. Safety and limitations, hemodynamic effects and risk, it has potential effect of bradycardia and hypertension, and that is dose related, and in some cases you have to give anticholinergics to treat it, and you have to keep monitoring, and what patients in which you can't use, who are needing the deep sedations in RDS and ICPs and in the shock states. Definitely the recent advances in ICU sedation is analgesia first, sleep promotion bundles, and objective monitoring and daily awakening and breathing trials. Patient selection should be the light sedation targets, and always go for monitoring and apply the RAS, CPOT, and awakening and breathing trials daily, and assess your patient readiness for extubation. So this is the good news. The final slide has come. The key home take message is focus on light titratable sedation with daily sedation interruption paired with multimodal analgesics and early mobilization to reduce delirium and improve outcomes. Together, through evidence-based practice, we will improve patient care and outcome. Thanks.
Thank you, Dr. Shahriyar. I would request Dr. Fajad to come on the stage and give a certificate to Dr. Shahriyar, Ashraf, please. Thank you, ladies and gentlemen. We have a cake cutting ceremony by one of our pharmaceutical company, Genix Pharma, who has recently launched sufentanil, fentanyl, remifentanil. So I would request the management of the company to come on, and all the senior personnel of PSA Karachi to come on the stage, and PSA Pakistan also to come and have the cake cutting. Professor Rana Altaf, Professor Tipu, Dr. Delu, Professor Saida, Dr. Akhtar Aziz, Dr. Safia Zafar, Dr. Mohammad Hamid, Dr. Shabir, please kindly come. And the management of the company as well. People at the back are requested to proceed to the ballroom B for the lunch, and those who have coupons can only enjoy the lunch. The senior people can wait and have the lunch at the henna hall, please. All of you need to show your lunch coupons before entering the hall, please. Those who does not have the lunch coupons, please refrain from entering the hall. Thank you. That's all for the day one. Tomorrow is the day two, so we'll start sharp at 8:30 in the morning for the breakfast session, and all of you are requested to kindly make it to the Xavier Hall for the breakfast session tomorrow morning, please. Thank you so much. Thank you for coming.